Hello, check. Hello, hello. morning, respected dignitaries, esteemed guests, and my beautiful audience. It gives me immense pleasure to be your host today. As we gather here, let's embark on the journey of thought-provoking perspectives and invaluable learning. Let's start our event by a prayer song.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणादित्याय गुणदिशायाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुहप्रवराय गुरवे गुरगुणवे गुरुदैत्यकलाक्षेत्रे गुरुधर्मसदाराध्याय गुरुपुत्रपरित्रात्रे गुरुपाखण्डकण्डकाय एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि
We are about to commence our event by lighting the lamp of knowledge and wisdom. This is a symbolic movement that signifies dispelling of darkness and igniting of thought and enlightenment. It's our honor to invite Dr. Sudhir sir, Dr. Ambedkar sir, Dr. Srinivas sir, Dr. Raviteja sir, Dr. Kalyan sir, Dr. Samata ma'am, and Dr. Shrija ma'am for lighting the lamp.
आरोग्यं धनसम्पदम् warm greetings for the day. I hope everyone are doing really great. First, I would like to thank the experts for taking their precious time out and making to this event. Secondly, I want to thank you all the delegates for being present here today. I would like to invite Dr. Sudhir sir, Dr. Srinivaslu sir, Dr. Ambedkar sir to please join us on the dais and share their valuable opinions as an encouragement for us for today. Sir, please come. I would like to invite Dr. Samta ma'am to join us on the dais. Dr. Raviteja sir, kindly join us on the dais. I would like to invite Dr. Rakesh sir to kindly join us on the dais. HRE of NRA, Vizag. Good morning, sir. I would like to invite Dr. Sudhi sir to oblige us with few words of encouragement for the day. Sir.
శుభోదయం. ఆదివారం నాడు తెలుగులో మాట్లాడాలనే నియమం నాకుంది. సో మీరు వినక తప్పదు. వేదికను అలంకరించినటువంటి భీష్మ సమానులైనటువంటి మన అంబేద్కర్ గారు, మన జెమ్స్కి పర్యవేక్షణాధికారి శ్రీనివాసులు గారు, నేటి కార్యక్రమానికి పరిశీలకులు రవితేజ గారు, ఏ కార్యక్రమంలోనైనా తప్పనిసరిగా ఉండే వ్యక్తి మన సమత గారు, ఈవేళ కార్యక్రమానికి గాయత్రి నుంచి వచ్చినటువంటి మీ విభాగాది ఎన్ఆర్ఐ కాలేజీ నుంచి వచ్చినటువంటి రాకేష్ గారు, మన కళాశాల యొక్క మత్తు శాస్త్ర విభాగానికి చక్రవర్తి, ఈవేళ వేదికకు కళ్యాణ శోభం తెచ్చినటువంటి మన కళ్యాణ్ చక్రవర్తి, ఆహుతులైనటువంటి వైద్య విద్యా ఉపాధ్యాయులు మరియు విద్యార్థులందరికీ నా ఆహ్వానం, స్వాగతం, వందనాలు కూడా. ప్రతిరోజు మనం దినపత్రికని తిరగేస్తే ఏం చూస్తాం? మత్తు బానిసలు, మత్తును ఉపయోగించి మత్తులో ముంచుతున్నటువంటి ఎన్నికలు, మత్తు పదార్థాల రవాణా, మత్తుని ప్రజలకు ఉపయోగించి ధనార్జన, ఇలాగా మత్తు అనే పదానికి ఒక అనైతికమైనటువంటి అర్థాన్ని ఇచ్చేటువంటి సమాచారం ఎప్పుడూ మనం పేపర్లలో, మన పత్రికలలో చూస్తూ ఉంటాం. అయితే ఈ మత్తు అనే అనైతికమైన పదమే అశేష జనావళికి ఈ ప్రపంచంలో ప్రపంచ మనుషుల యొక్క ఆరోగ్యానికి ఒక కీలకమైన శాస్త్రంగా మార్చినటువంటిది వైద్య శాస్త్రం. అటువంటి కీలకమైన మార్పు వలన ఈవేళ ప్రతి వైద్య కళాశాలలో మత్తు శాస్త్ర విభాగాలు ఏర్పడి అవి ప్రజల యొక్క ఆరోగ్యానికి ముఖ్యమైనటువంటి ఒక అంటే పరికరం అని కాదు, ఒక ముఖ్యమైనటువంటి విషయంగా, ఒక ముఖ్యమైనటువంటి ప్రక్రియగా మార్పు చెందింది. అంటే ఒక అనైతికమైన పదం ఈవేళ ఇంత నైతికమైనటువంటి ఒక విలువైన పదంగా మన శాస్త్రంలో మారింది. అది అటువంటి పదాన్ని, అటువంటి శాస్త్రాన్ని అభ్యసించడానికి మీరందరూ దానికి ముందుకు రావడం అసలు అన్నిటికన్నా హర్షించవలసిన విషయం. అయితే మీకు అందరికీ తెలుసు, శాస్త్రం అనేది ఎప్పుడూ అది ఒక స్థిరంగా అలా ఉండిపోతుంది, మారుతూ ఉంటుంది. కొత్త విలువల్ని చేర్చుకొని, కొత్త విషయాల్ని నేర్చుకొని, కొత్త కొత్త పరిష్కారాలని చూపిస్తూ ప్రజలకు, మానవాళికి మరింత ఉపయోగంగా మారుతుంది. అటువంటి ప్రక్రియని నిరంతరం చేయడానికి, అటువంటి కార్యక్రమాలు నిర్వహించడానికి కళాశాలలు, విశ్వవిద్యాలయాలు అన్నీ కూడాను ఎప్పుడూ సమాయత్తమై ఉంటాయి. అటువంటి కార్యక్రమం ఇది. ఈవేళ మన వైఎస్ఆర్ విశ్వవిద్యాలయం యొక్క, వైద్య విశ్వవిద్యాలయం యొక్క దార్శనికతో మన జెమ్స్ కళాశాల యొక్క నిర్వహణలో నేడు జరుగుతున్నటువంటి ఈ నిరంతర వైద్య ప్రక్రియ, నిరంతర వైద్య విద్యా ప్రక్రియ కోసం నిర్వహింపబడుతున్న ఈ కార్యక్రమానికి వచ్చినటువంటి ఉత్సాహవంతులైన మీకు అందరికీ కూడా నా శుభాకాంక్షలు. అయితే ఈ కార్యక్రమంలో జనరల్గా సాధారణంగా ఇటువంటి కార్యక్రమాల్లో విద్యార్థుల యొక్క తత్వం ఎలా ఉంటుంది? సగం వింటాం, సగం వినం. విన్నది అర్థం కాదు, అర్థమైంది ఏమి బయటికి వెళ్ళి ఏం చేయలేం. ఇట్లా ఉంటుంది పరిస్థితి. చివరికి కార్యక్రమం పూర్తిగా చాలా విజయవంతమైందనేసి మాత్రం మనం అందరం అనుకుంటూ ఉంటాం కదా. అలా కాకుండా ఈ కార్యక్రమంలో వచ్చినటువంటి, ఈ కార్యక్రమాన్ని నిర్వహించడానికి, దీంట్లో చర్చలను జరపడానికి వచ్చినటువంటి వక్తలందరి యొక్క వాళ్ళ యొక్క నైపుణ్యం, వాళ్ళ యొక్క అనుభవాలని మీరు శుభ్రంగా విని మత్తులోకి ఆవహించకుండా వాళ్ళ యొక్క వక్తల యొక్క చెప్పిన విశేషాలను మీరు విని ఈ మత్తు శాస్త్రంలో ఉండేటువంటి ఎత్తుల్ని, పల్లాల్ని, వాటిని పూర్తిగా కొత్త విషయాలు నేర్చుకొని, అవగాహన పెంపొందించుకొని, ఈ మత్తు శాస్త్రం యొక్క ఉన్నతికి మీరందరూ కారణమయ్యి, మీరు దాన్ని మీ యొక్క దైనందిక కార్యక్రమంలో వాటిని ఉపయోగించి మిమ్మల్ని మీరు ఇంకా నిష్ణాతులుగా తయారు చేసుకుంటారని నేను భావిస్తున్నాను, కోరుకుంటున్నాను. చివరగా ఈ కార్యక్రమానికి నన్ను ఆహ్వానించినటువంటి కళ్యాణ్ చక్రవర్తికి నా ధన్యవాదాలు. నమస్కారం. ఇట్ ఈస్ ఫర్ ఎ చేంజ్.
Thank you, sir. Now I would like to invite Dr. Ambedkar sir to kindly share his thoughts for us today. Mic.
ఈరోజు మన డిపార్ట్మెంట్ ఆఫ్ ఎనస్థీషియాలజీ how it is coming, is conducting our CME in this college. I am very glad. I thank Kalyan and Department of Anaesthesiology for inviting me for this function. All the dignitaries on the dais, and my dear students, and all the delegates coming from all the other colleges. The university thought we update our students by conducting zonal CMEs to improve our standards. The medical education, in all branches is very, very important, because this directly reflects the patient care ultimately. అందులో ఇవాళ మీరు ఏదో ఆర్టిఫిషియల్ ఇంటెలిజెన్స్ ఇన్ అనెస్థీషియా ఆల్సో ఇస్ we are trying to combine these two. I think it is a new thing we should learn, and I think artificial intelligence is coming a very big way in all branches, not only in medicine, in every field also. I tried to speak about a little experience in anesthesia. As a postgraduate, I used to give for manipulation of various fractures in the OP itself, pentyl sodium. We don't have even Boyle's apparatus also, not even oxygen. I am speaking about 50 years ago. Sometimes we used to manipulate, we asked the house surgeon to give. That fellow used to give like a bolus, and there's a respiratory arrest and death also. Nothing happened those days. My chief used to come and tell, ఏదో అనెస్థీషియా ఇచ్చాం, కాంప్లికేషన్ వచ్చింది, డెత్ అయిందంటే పిల్లలు, ది పేరెంట్స్, బాబు నువ్వు బాగానే చేసావు, మా అదృష్టం బాగలేదు అని డెడ్ బాడీని పట్టుకెళ్ళిపోయారు. ఆ రోజుల్లో యాజ్ ఎ స్టూడెంట్ నాకేం అనిపించలే, కానీ 50 ఏళ్ళు జర్నీ అయ్యాక పాత రోజుల్లో చాలా హ్యాపీగా బతికిస్తాం, చాలా తప్పులు చేసాం, ఎవరు అనలేదు సరి కదా. వాళ్ళందరూ బాబు వీళ్ళంతా దేవుళ్ళు, మీ తప్పేం లేదు, మా దురదృష్టం కొద్దీ పోయారు అన్నారు. ఇలా చాలా ఇన్సిడెంట్స్ జరిగాయి. అలాగే నేను ప్రాక్టీస్ చేస్తాను, కాకినాడలో ఉన్నాను చాలా కాలం. వన్ ఆఫ్ ద సీనియర్ అనెస్టిస్ట్, వన్ యాప్సిస్, ఆస్టోమైటిస్ వచ్చిన యాప్సిస్. సార్ చాలా సెప్టిక్ మీద ఉన్నాడు, అనెస్థీషియా ఇస్తున్నారు, కొంచెం చూసుకోండి సార్ అన్నాను. అని ఇలా పెంటలు ఇచ్చాడు, రెస్పిరేటరీ అరెస్ట్ వచ్చేసి. ఐ యాంటిసిపేటెడ్ దట్ బికాస్ ఆఫ్ మై ఎక్స్పీరియన్స్, బికాస్ పేషెంట్ ఇస్ సివియర్ సెప్టిసిమియా. అఫ్ కోర్స్ ఆయన ప్రిపేర్డ్గా ఉన్నాడు, నేను ప్రిపేర్డ్గా ఉన్నాం కాబట్టి వీ కుడ్ సేవ్ ద లైఫ్. లైక్ దట్ సో మెనీ ఎగ్జాంపుల్స్ ఇన్ మై లైఫ్ టైమ్ విత్ రిలేషన్ టు సర్జన్ అండ్ అనెస్థెటిస్ట్. ఒకరోజు మా ఇంట్లోనే టెన్నిస్ ఎల్బోకి జైలోకేను ప్లస్ కార్డిజోన్ కలిపి ఇంజెక్షన్ ఇవ్వబోతున్నాను. వన్ లేడీ కేమ్, షీ ఈజ్ వైఫ్ ఆఫ్ ఏ బిగ్ రైస్ మిల్లర్స్ వైఫ్. ఒళ్ళంతా బంగారమే, నాకు చూడగానే భయం వేసింది, బాబు ఈ భయం ఇంత బంగారు వేసుకొచ్చింది అంటే. I gave injection Jalican with cortisone. She developed a reaction. So, sir, gabra అయిపోతుంది సార్, ఆయాసం వచ్చేసి ఇలా ఉంది. ఐ ఇమీడియట్లీ రియలైజ్డ్ ఇట్. ఇంటి ముందే లక్కీగా మెడికల్ షాప్ ఉంది. మై వైఫ్ హ్యాపెన్ టు బి డాక్టర్. సో ఇమీడియట్లీ స్టార్టెడ్ సెలైన్, ఐ గివింగ్ ఐవిల్ injection, cortisone injection, everything very well. This happened nearly some 30 years ago. From that time onwards, I never gave tennis elbow injection. Why I am telling all this is, surgery is very easy. What is there in surgery? You cut it now. Only structure you should learn is the surgical anatomy and blood vessel, particularly artery and vein. Other things you cut it, you can repair. You just learn about anatomy only. Anesthesia is not like that. You give little injection, respiratory center stops. You give something, heart stops. And if you are not well aware of it, కష్టపడి చదవలేదనుకో, వస్తే ఏం చేయాలో తెలియదు కదా. మనకి ఏం చేయాలో తెలుసుకోవాలి. అంతకన్నా ముందు ఏం చేయకూడదో తెలుసుకోవాలి. నాకు చాలాసార్లు అనిపించింది, స్పైనల్ అనెస్థీషియా కూడా గొప్పలు ఇచ్చేయడం చక్కగా హ్యాపీగా ఉంటుందని. ఆ బీపీ పడిపోతుంటుంది, చూసుకోపోతే చచ్చిపోతాడు, సర్జరీ అయిపోతుంది. సో చాలామంది అనెస్థీషియా చేరుతుంటారు పోస్ట్ గ్రాడ్యుయేట్స్గా. నాకు అనిపించేది అనెస్థీషియా మోస్ట్ డిఫికల్ట్ సబ్జెక్ట్ అని. ఎందుకంటే అక్కడ 3 minutes ఉంటుంది. ఆ రెస్పిరేటరీ సెంటర్ ఆగిపోవడానికి, హార్ట్ ఆగిపోవడానికి ఆ 3 నిమిషాల్లో రివైవ్ చేసేయాలి. సో దట్ మీన్స్ ది ట్రైనింగ్ ఆఫ్ అనెస్థీషియా మస్ట్ బి సూపర్ అండ్ highest grade, because in 3 minutes you are going to kill somebody. Surgeon will have a lot of time. నేను ఒకరోజు కళ్యాణ్ దగ్గరికి వెళ్ళాను. సార్ మా పోస్ట్ గ్రాడ్స్ ఎవరు క్లాసులో రావట్లేదు, ఈవినింగ్ 4 to 5, మీరు థియేటర్ కొంచెం వేగం మొదలుపెట్టి 3 కల్లా వదిలేయండి. వాడు సాయంకాలం 6-7 దాకా థియేటర్లో కేసులు చేస్తూ ఉంటారు. మరి మీ పిల్లలకి ఎప్పుడు చదువు చెప్తారు సార్ అని అడిగాను. ఇంకేం చదువు చెప్తారు, పొద్దుల్లా ఆపరేషన్ థియేటర్లో ఉంటే అందరూ. సో why I am telling all this is, anesthesia is one of the very important subject, most dangerous subject. Therefore I expect all of you to have a good experience in your own department and learn how to treat the complications. You have only 3 minutes. I have so many anesthetists struggling in those 3 minutes to survive the patient. Thank you very much for giving this opportunity, Kalyan. I wish this CME will help you to gain a lot of knowledge. Thank you.
Thank you so much, sir.
Now I'd like to call Dr. Raviteja sir to share a few thoughts with us.
Nothing much to speak after these two stalwarts. So first of all, I would like to thank Kalyan sir for selecting me as an observer for this program, and all the best to all the speakers who are going to speak in this CME, and I wish all the delegates to have a good academic feast. Thank you.
would like to invite Dr. Srinivas sir to accept our token of gratitude.
Sir, I request you to speak few words, sir.
Wish you best of luck. Thank you.
Thank you.
I would like to invite Dr. Samta ma'am to kindly share her beautiful thoughts with us.
Good morning to one and all. అనస్థీషియా డిపార్ట్మెంట్ అంటే నేను మైక్రోబయాలజీ హెచ్ఓడినండి. కానీ మాకు అనస్థీషియా డిపార్ట్మెంట్తో ఏం పని ఉంటుంది అనేది చాలామందికి
కంప్లైంట్స్
ఇది ఉండొచ్చు. ఈవెన్ కళ్యాణ్ సార్ అండ్ ఐ both were working for HICC, Hospital Infection Control Committee, and it plays a major role in OT. అందుకని అంటే నేను ఇప్పుడు అందుకనే సరే ఒక నిమిషం అన్నా మాట్లాడదాం అనిపించింది, ఇప్పుడే అనిపించింది. వాట్ ఎవర్ ద సర్జన్స్ హు ఆర్ డూయింగ్ ద సర్జరీస్, ఎవరి సర్జరీ ఎంత పెద్ద సర్జరీ ఎంతసేపు చేసినా సరే వాళ్ళది ఇన్ఫెక్ట్ అయ్యింది అని అంటే దాని అర్థం ఏంటి అని అంటే ఆ పేరు అనేది ఆ సర్జన్కే వెళ్తుంది. అది మంచి అవనండి చెడవనండి, అవునా కాదా అండి? కదా, పేషెంట్ అదే మాట్లాడుకుంటారు కదా. సో అలా ఇన్ఫెక్ట్ అవ్వకుండా ఎలా కాపాడొచ్చు అనేది ద ఓటీ ప్లేస్ ఎ వెరీ రోల్, అండ్ ద రోల్ ఆఫ్ ఎన్ ఇస్ ఆల్సో ఎ వెరీ ఇంపార్టెంట్ దేర్. ఎందుకు అని అంటే మీరే ఎప్పుడు 24 hours అక్కడ ఉంటారు, సర్జన్ ఒక్కళ్ళే కాదు. ఈవెన్ యూ పీపుల్ ప్లే ఎ వెరీ గుడ్ రోల్ ఇన్ దాట్. సో ఐ హోప్ దాట్ you'll be having a new technologies even in the HICC topics also in the later, and now you'll be I think you'll be enjoying with your new technologies and advancement in your course also, and all the best.
Thank you, ma'am. I would like to invite Dr. Rakesh sir, Professor and HOD of ANETS Visakhapatnam, to kindly share his opinion.
అందరికీ నమస్తే. స్టేజ్ మీద ఉన్న పెద్దలకి, సో ఆదివారం ఎగ్గొట్టకుండా ఈ ప్రోగ్రాంకి రావాలి అని ఎందుకు అనిపించిందంటే ఒకటి రెండు కారణాలు. ఒకటి, నాకు కొంత అనుబంధం ఉంది ఈ కాలేజీతో. ప్రీవియస్గా 3-4 సార్లు వచ్చాను. ఒక 2 సార్లు BCLS వర్క్షాప్ చేసినట్టున్నాను. ఒకసారి భాస్కరరావు గారిని కలిశాను, రామ్మోహన్ రావు గారిని కలిశాను వేరే సంబంధంగా. తర్వాత ఈయన నాకు చాలా క్లోజ్ ఫ్రెండ్. సో ఎగ్గొట్టడానికి అవకాశమే లేదు. తర్వాత మోస్ట్ ఇంపార్టెంట్ థింగ్ ఈజ్ టాపిక్స్ మాత్రం ఎక్సలెంట్గా ఉన్నాయి. ఎవరు సెలెక్ట్ చేశారో కానీ, బట్ దే ఆర్ రియల్లీ వెరీ వెరీ గుడ్. చాలా ఇంట్రెస్టింగ్గా చేశారు. అందుకోసం ఎట్టి పరిస్థితుల్లో మిస్ అవ్వకూడదు అని మార్నింగ్ 8:50కే ఇక్కడ వచ్చి కూర్చున్నారు. ప్రాబ్లీ ఇంకా అప్పుడు ఓపెన్ కూడా చేసిండు. మేము కింద కూర్చున్నాం సార్, పార్కింగ్లో వెయిట్ లొకేట్ చేయలేకపోయాం ఇది ఎక్కడ ఏంటి అనేది. సో టాపిక్స్ చాలా బాగున్నాయి. అండ్ ఐ రియలీ కంగ్రాచులేట్ అనస్థీషియా డిపార్ట్మెంట్. థ్యాంక్ యూ వెరీ మచ్.
Thank you, sir. Thank you, Sudhir sir, Ambedkar sir, Srinivas sir, Raviteja, Samantha madam, and Rakesh sir for attending the inauguration function. Thank you very much, sir. So a warm welcome to all the delegates who have come. I expected to start at 9 a.m. but until 10 I was unable to start because of lack of participation. But anyway,
Somebody
please,
should give a memento to your HOD. And Kalyan sir.
Meanwhile, one good song for your department. Mattu Vadalara. Niddara Mattu Vadalara. Okay? Okay.
I would like to thank all the respected dignitaries and esteemed guests for sharing their experiences and valuable thoughts for us. Now let us embark on the journey of insightful lectures, thought-provoking perspective and invaluable learning. May I now request Dr. Padmalata ma'am, Associate Professor of NRI Vizag, to bestow the wisdom upon us and share their valuable insight on the topic, newer anesthesia agent remimazolam in ADV 6209.
Good morning, everyone. Good morning. I need a loud response because we are going to talk about sedative hypnotic drugs, so I want everyone to be alert and conscious. Okay? Good morning. Loud. Good morning. Okay. So, the topic for today is newer anesthetic agents, which is remimazolam and ADV 6209. These both drugs are benzodiazepine derivatives, which are the novel anesthetic agents, sedatives and hypnotics. So first drug is remimazolam. So remimazolam, when you speak about this drug, it has the unique properties of two drugs, that is remifentanil and midazolam. So from remifentanil, the metabolic feature like tissue ester hydrolysis that has been taken, and the midazolam properties. So both have combinedly, they have taken the combined properties and developed this drug remimazolam. Okay? So it is an water-soluble, ultra-short-acting IV benzodiazepine. US FDA approved this drug based on 3 clinical trials. First trial and the third trial, they have done in the subjects who underwent colonoscopy. And the third trial, they have done the studies in the subjects who have underwent bronchoscopy. So based on the evidences taken from these studies, they have approved this drug for the clinical use in anesthesia as sedative and hypnotic. So it is sold under the brand name of Bifavo. Coming to mechanism of action, like all the benzodiazepines, it also acts on GABA receptors. So where GABA receptor has alpha, beta, and gamma subunits. So this drug acts at a specific site between alpha and gamma subunit. So by binding to this site, it increases the frequency of channel opening and increases the chloride ion conductance, resulting in hyperpolarization of the postsynaptic cell membrane and causes the inhibition of the neurons. So this results in anxiolysis, sedation, and anticonvulsant properties. So how is it different from the other midazolam type of drug? So in this remimazolam structure, the ester moiety is incorporated into this structure, making it more susceptible to the, its affinity to the esterases, tissue esterases is increased, and the metabolism is done by the tissue esterases. So because of the addition of the carboxyl group, this structure, it is more susceptible to the metabolism by tissue esterases. Coming to pharmacokinetics, it has a unique pharmacokinetics when compared to the other benzodiazepine group of the drugs. So it has a high clearance rate, small steady state volume of distribution, short elimination half-life, short contact sensitive half-life, first order, and linear pharmacokinetics. And it has a superior safety profile, that is, it has less cardiorespiratory depression and no pain on injection, and so both these features make this as a good sedative agent. Coming to absorption, it is absorbed through intravenous route, and it can be given in oral route and nasal route also, but nasal route, it is more painful, and oral bioavailability is very less. Distribution half-life is 0.5 to 2 minutes, and its volume of distribution is 0.9 liters per kg. Remimazolam has a metabolite. It is CNS 7054, which is an inactive metabolite. The carboxyl esterases, it will metabolize the drug, and the product is inactive form. It is 300 times less potent than the parent drug. So even if it gets metabolized also, the effects will stop there. Its metabolite will not carry the pharmacological effects of the parent drug. Okay? And it is 90% protein bound like the other benzodiazepine group of the drugs, mainly to the albumin. So in case of hypoalbuminemia, the clinical effects will be more enhanced because the free fraction of the drug will be more. Okay? And remimazolam is rapidly and extensively metabolized by tissue esterases to its pharmacological metabolite like CNS 7054. Coming to elimination, it has a mean elimination half-life of 7 to 11 minutes. Clearance is high and not related to the body weight. And it is predominantly excreted in the urine. When you give a drug, when you give this drug, 90% is excreted in the urine. Only 99% is excreted in its inactive metabolite form. Only 1% is available in its unchanged form. So most of the drug is metabolized and eliminated. Coming to context sensitive half-life, it is a time when the infusion has been stopped, the concentration of the drug becomes less. 50% of the metabolism will be done. So offset of the remimazolam after the cessation of the infusion was faster than that of midazolam, but it has similar context sensitive half-life like that of propofol. So context sensitive half-life of remimazolam is 7.5 minutes. It has a similar context sensitive half-life to that of propofol, which is same 7.5. But for midazolam, it is 40 minutes. when you keep midazolam infusion, when you stop, to reach the 50%, midazolam takes 40 minutes. But remimazole and propofol, they both take 7.5 minutes. Okay? So these are the studies regarding the pharmacokinetic parameters. So phase 1 studies are mostly to assess the dose. So which dose, dose finding studies. Phase 1 studies are dose finding studies. So what dose should be given to different age groups, and what are the pharmacokinetic parameters, like mostly they have focused on the volume of distribution, clearance, and the terminal elimination half-life. When compared to midazolam and the propofol, actually these drugs has been compared, and when compared to these two drugs, the mean half-life or the elimination half-life, these are all less for the remimazole group of the drug. So it is sold by the brand name of Bifavo. It is available in 20 mg vial. It should be reconstituted before using as a sedative drug. So for reconstitution, 0.9% sodium chloride is used. How much volume should be used? 8.2 ml of 0.9% normal saline is used to dilute this lyophilized powder form of remimazole. So finally, you will get a solution of 2.5 milligram of midazolam per ml solution. Okay? This is the recommended dilution which is given by the US FDA. And other constituents are, it has 7.13 mg of dextran, 40 for injection. Additional doses can be given for the desired sedative effect. But 2 minutes you have to wait to fully assess the sedative effect. Only after 2 minutes only you can repeat the dose. When it is co-administered with other opioids, the dose adjustment is required. So dose adjustment when it is administered with opioids is, first give opioids, wait for 1 to 2 minutes, and then give 5 mg of remimazole over 1 minute and wait for 2 minutes for it to assess its sedative effect. For maintenance, 2.5 mg over 15 seconds can be given. And in elderly age group greater than 65 years and ASA 3 and 4 patients and body weight less than 50 kgs, same, administer opioids first, wait for 1 to 2 minutes, and dose here it is reduced, because elderly in ASA 3 and 4 we have to reduce the dose of remimazole to 2.5 to 5 mg. It is given over 1 minute, wait for 2 minutes, and then for maintenance half of the dose, 1.25 to 2.5 mg should be given. Without opioid, the induction dose is 7 mg, that is 2.8 ml over 1 minute should be given. And maintenance dose is 2.5 mg over 15 seconds. For elderly age group greater than 65 years and ASC 3 and 4 subjects and body weight less than 50, without opioid, the injection should be given at a dose of 2.5 to 5 mg over 1 minute, wait for 2 minutes, and the maintenance dose is 1.2 to 2.5 to 2.5 mg over 50 seconds should be given. So with opioid administration, the maximum total dose administered in the clinical trials was 33 mg only. And without opioid, it is 33 mg in adults less than 65 years, and 17.5 mg is the maximum dose which was used in adults greater than 65 years and ASA 3 and 4 subjects. It is also available in 50 mg dose, same lyophilized powder. So to use this form, it should be reconstituted with 0.9% sodium sodium chloride. But for usage, it should be diluted to 1 to 2 mg per ml. So for that, according to recommendations, they have given this reconstitution like concentration of 2 mg per ml, 1 mg per ml. For ease of dilution, take the 50 mg vial. In that, if you add 25 ml, it will become 2 mg per ml, and 50, 1 mg per ml, 50 ml of NS. It is compatible with normal saline and with other solutions like glucose 5% weight by volume, glucose 20%, sodium chloride 0.5%, sodium chloride 0.9%, Ringer solution containing sodium chloride, potassium chloride, calcium chloride. And it is not compatible with Ringer's lactate or estated Ringer solution and bicarbonate solutions because and other alkaline solutions, because the solubility of the product is reduced at pH of 4 or higher. If there is any incompatibility of the solution with other solutions, it may cause precipitate and can cause occlusion of the venous site. What are the dose pharmacokinetic dose adjustments in special populations are like in elderly and ASA 3-4 patients and body weight of less than 50 kgs. You have to adjust the dose. You have to give the half of the dose. In pediatric population, age of 0 to less than 8 years, actually the data has, the safety and efficacy has not been studied yet, and there is no data available in pediatric age group. They are giving for sedation, procedural sedation, but there are no different studies regarding their safety and efficacy. And in renal impairment, no dose adjustment is required with GFR of less than 15 ml per minute. Hepatic impairment, no dose adjustment is required in mild or moderate hepatic impairment, but in severe hepatic impairment, rather than the dose adjustment, the dose should be titrated according to the effect, because it may affect with the metabolism. Coming to pharmacodynamics, the primary pharmacodynamic effect of rimemazolum is sedation. So for sedation, single bolus doses of 0.05 to 0.75 mg per kg is recommended, and the onset of sedation is 1 to 2 minutes. For midazolam, it may take up to 3 to 4 minutes. For this rimemazolum, it will take up to 1 to 2 minutes. And loss of consciousness is seen at doses of 0.1 mg per kg in elderly or 0.2 mg per kg in healthy young adults. Depth, duration, and recovery from sedation is dose dependent. And time to fully alert was 10 minutes for 0.075 mg per kg of rimemazolum. So in 10 minutes, patient becomes fully alert. It will not happen with the midazolam group of the drug. At least it will take 1 to 2 hours for the patient to become fully alert. But here, because of this faster onset and faster recovery, within 10 minutes, patient will be fully alert. These are the studies regarding the pharmacodynamic parameters. Here also, same comparison was done. And regarding the dose, and here to assess the sedation, modified observers alert score short form was used, and other index like BIS and Argotrend was used to assess the sedation, level of sedation. And here also all the sedation scores were less when rimemazolum was given to these subjects when compared to propofol or other midazolam group of the drugs. Clinical applications of midazolam are mainly it is used for procedural sedations like colonoscopy, bronchoscopy, GI endoscopy. So all these studies are related, like done in these procedures only. So IV rimemazolum was used at the dose of 5 milligram over 1 minute for induction of sedation. Supplemental IV doses of rimemazolum, like 2.5 mg is given over 15 seconds with greater than or equal to 2 minutes between doses can be given. And dosage should be reduced in patients with ASA 3 or 4. And induction in ASA 3 and 4, like we have discussed in the previous table, the dose should be reduced. For general anesthesia, an initial dose of 6 or 12 milligram per kg per hour for induction, followed by 1 milligram per kg per hour for maintenance is a recommended dose. But like bolus administration, like propofol and all, will give as a bolus doses. No data has been given regarding the bolus doses. It is still under the study. Only the initial dose and the maintenance dose they have given. For ICU sedation, because of its properties like shorter fast onset and shorter recovery times and non-organ dependent hydrolysis, it is an actually best drug for ICU sedation. But till now there are no studies on ICU usage of this drug in ICUs. Because in ICU many patients have liver diseases and severe renal impairment and liver diseases will be there. So considering that this is the best drug, but till now there are no studies. So when propofol, midazolam and remimazolum were compared, ready-to-use injectable formulation is available for propofol and midazolam, but remimazolum it is available in the lyophilized powder. Free from pain on injection, obviously you know propofol has pain on injection, but midazolam and remimazolum it will not cause any pain. Remimazolum is water soluble, but midazolam is lipid soluble, even though it does not cause any pain. Free from liability for cardiovascular and respiratory depression. So remimazolum has no cardiorespiratory depression or it doesn't cause any apnea and all on its use. But it can be seen with propofol. Active metabolite is seen with midazolam, but it's not seen with propofol or remimazolum. Availability of a reversal agent. For benzodiazepine group of the drugs, we can reverse it with flumazenil. It is the reversal agent of the choice in the benzodiazepine overdose. So it is same for remimazolum also. Short contact sensitive half-life. For propofol and remimazolum, it is 7.5 minutes, and from midazolam, it is 40 minutes. Time to recovery, propofol and remimazolum are same. Time to recovery is 10 minutes, whereas in benzodiazepines, it takes up to 20 to 80 minutes. Metabolism, hepatic or extrahepatic metabolism in propofol. In midazolam, it is hepatic, and remimazolum, it is hydrolysis by tissue esterases. Protein binding is same for all. Most of the drugs bind to the proteins, like albumin, it predominantly binds to albumin. So in case of benzodiazepine overdose, the reversal agent of choice is flumazenil. So in remimazolum also, if there is an overdose, the signs and symptoms are the extension of their pharmacological effects like hypotension, respiratory depression, bradycardia and all. First, you need to give supportive management. Support the airway, get an IV access, take care of the ventilation, and to reverse the sedative effect of benzodiazepine, flumazenil at a dose of 0.2 mg is given as an initial dose, and it should be slowly injected over 15 seconds period, because if you inject fast, it may cause hypertension, tachycardia, and anxiety. So when to repeat the dose? If the sedative effect is not reversed, then you can repeat the dose after 60 seconds of the interval, and maximum of 4 doses can be given. And remimazolum, flumazenil has, it may cause resedation also, but with when given with remimazolum, it may not cause, because the elimination half-life is same for both of them. For repeated treatment, no more than 1 mg should be administered at any one time, and no more than 3 mg should be injected during a 1 hour period. So during 1 hour period, you should limit your dose to 3 mg only. So this is a quick reference table regarding the remimazolum. Take home points, you remember 10 points at least. It is a benzodiazepine group of the drug. Sedation time is 11 to 14 minutes. Time of peak effect is 3 to 3.5 minutes. And elimination half-life is 37 to 53 minutes. Metabolism is ester dependent. Excretion is through urine. Distribution is 0.76 to 0.98 liter per kg. Protein binding is 91% primarily to the albumin, and it is an FDA labeled drug and recommended dose is 2.5 to 5 mg bolus over 1 minute. Dose reduction is recommended in AAC 3 and 4 patients and elderly patients. And this all we have discussed. It has rapid systemic clearance, low volume of diffusion, so short termination, elimination half time, can be given intravenous, oral and nasal routes. Oral bioavailability is very poor, 1 to 2%, and intranasal it is painful and bioavailability is 50%. Sedation doses and general anesthetic doses already we have discussed. Coming to the second drug, which is ADV 6209. It is an oral formulation of midazolam. Till now, for pediatric sedations, pediatric department is using trichlorphos, which is an ethanol group of drug. So comparison is not done with those drugs, but comparison has done with the IV midazolam, which is given orally, which has a bitter taste, and the children will not accept the bitter taste. So to increase the acceptance by the pediatric group of population and to increase its solubility, gamma cyclodextrin has been added into the chemical structure of the midazolam, and it is made more palatable and more pleasing to the pediatric age groups. So studies has been done comparison with this oral midazolam and the IV formulations of midazolam, which is given orally, to assess the acceptance of these drugs, acceptance of this solution, and the sedation to decrease the preoperative anxiety levels and all. These things are compared. Okay. So considering the lack of, and it has been approved in Europe. Till in India it has not been, it is not available in India. Rememozolam is available in India, but this drug is not available in India. It has been approved in Europe. Okay. Considering the lack of available oral medications for moderate sedation in children in most European countries, ADV 6209, an innovative 0.2% oral solution of midazolam for children from 6 months of age group, it was developed. And sucralose was added to decrease its bitterness and orange flavor to improve the taste. pH of the formulation ranges from 3.8 to 4. Its development and the formulation were first reported by Markan and colleagues. It is used as a pre-medication in pediatric anesthesia, and in clinical trials based on the evidence taken from this study, it got approval to use as an oral pre-medicant drug. Okay, and in this study, they have taken 80 subjects, 40 subjects were given oral midazolam and other 40 given IV formulation as oral syrup, and they have seen the preoperative reduction in the anxiety levels based on the modified observer's sedation scale. So when they have compared the ADV 6209 drug, it is more acceptable, and almost 100% of the children, they have accepted this oral solution, and 15% they have rejected this IV midazolam formulation, which is given orally. And it is sold by the trade name of Ozolin. It is available as 2 milligram per ml of oral solution in single dose container. Each 5 ml ampule of Ozolin contains 10 milligram of midazolam. Therapeutic indications are, it can be used in infants, children and adolescents from 6 months to 17 years old for moderate sedation, for any diagnostic and therapeutic procedures, and pre-medication before giving anesthesia. Mode of administration, perorally, this drug can be given single dose of 0.25 mg per kg. And this, after giving this initial dose, the dose should not be repeated. It is a single dose drug. The maximum dose should not exceed 20 milligram of midazolam, corresponding to 2 ampules, even for children and adolescents weighing more than 80 kgs. So this drug is a single dose drug. Calculate the weight and give this drug, that's it. Subsequent doses should not be given. Even for obese children, total dose should be 20 mg only. It should not exceed it. Ozalin is indicated for single dose administration, and so for it is available with a filter straw, ampule, and an oral applicator. The oral applicator is filled with the drug according to the weight of the child, and it should be given 30 minutes before the procedure of anesthesia. So this is the straw. This is an ampule. From the ampule, the contents are taken with a straw into the oral applicator. According to the weight, it is filled and it is given to the child 30 minutes before giving anesthesia, general anesthesia, to reduce the anxiety levels. So what are the dose adjustments in the special population? In renal impairment, it should be used with caution because elimination of midazolam may be delayed and its effects can be prolonged. In hepatic impairment, decrease the clearance of midazolam, which increases the terminal half-life as well as bioavailability. Careful monitoring of these effects and of vital signs are necessary. In pediatric population, the safety and efficacy has not yet studied, so no data is available. In chronic respiratory failure, it should be used with caution because respiratory depression may be exaggerated. In severe respiratory failure and anatomic abnormality of the respiratory tract or lung disease, it is contraindicated. In patients with heart failure, it is used with caution because clearance of midazolam may decrease. During co-administration with ethinyl estradiol or norgestrel, which is used as oral contraceptives, exposure to midazolam is not significantly altered. And when it is co-administered with other sedative and hypnotic drugs, synergistic action may occur and may increase the sedative effect and decreases the mean annular concentration of inhaled anesthetics. This is a summary of pharmacokinetic profiles of midazolam 0.2%, which is the Ozalin. It is compared to that of the midazolam IV formulation. And these are the studies related to that, which is pharmacokinetic profile of both the drugs is almost similar. Only difference is because for its acceptability and solubility only the gamma dextrin has been added. Rest of all the things are same. Adverse effect reported are tachycardia, bradycardia, and eye disorders like blurred vision, gastrointestinal disorders like vomiting and nausea, unusual fatigue, feeling of weakness, hypersensitivity, angioedema, impaired muscular control, and prolonged or over sedation, drowsiness, somnolence, dizziness, and other CNS effects. Psychiatric disorders like paradoxical reaction, agitation, excitation, hallucination, similar to the midazolam group of drug only, IV formulation. Respiratory, thoracic, and mediastinal disorders like hypoxemia, transient desaturation, laryngospasm, respiratory depression, airway obstruction, hiccups, and dyspnea can occur. Skin and subcutaneous tissue disorders like pruritus, urticaria, and skin rash may occur. So rest of the pharmacodynamics and all, they are similar to IV formulation of midazolam. Okay. Thank you. Any doubts you can. Any doubts you can ask.
Thank you for the insightful topic, ma'am. You have truly set the tone for upcoming interactions. Now I would like to call our HOD sir and Dr. Pradeep sir, Associate Professor, to present a token of gratitude to Padmalata ma'am. Let us now extend a warm welcome to Dr. Shanti Shweta ma'am, Assistant Professor, Government Medical College, Srikakulam, to enlighten and inspire us all on the topic newer innovations in anesthesia machine and enhanced safety features. Please join me in giving them a round of applause as they take the stage.
Good morning, everybody. I just want to find out one thing. PG students, what are the anesthesia machines you are using? Do you have any idea? Which company? What is the model? Just one can stand up and tell. Or just sit down and tell. BPL, okay. Mindre, okay. Dragger, GE, yeah, okay. So, Dragger, who is using Dragger? GEMS, okay, GEMS PGs. Can you tell which model of Dragger? Or can you tell the type of ventilator you are using in that model of Dragger? Okay, it's okay. Even I am like you only in my PG days. I know that it is Dragger, but I don't know what is the type of ventilator or what is that machine, what does it do and all, okay? I hope you'll get some idea about this now after this class. Just remember, like, what you are seeing in the operation theater. You'll get some clues and ideas about what is happening in the anesthesia machine. Okay, I'll continue with my class. So I'm not going to, like, safety features. Every one of us know, like color coding, pin index system, diameter index system, all these every one of us know. And some things are very elusive to all of us, like Link 25 system, the OSRC system and all. I am not going into details of those. Those are the older, like the newer generation machines have changed. I'm just going to present 2 or 3 slides about what we have in our textbooks. And the next, majority of my topic will be the enhanced features. What are the new innovations happening in the anesthesia machines? Okay, I thank Dr. Kalyan sir for giving me this opportunity, because these are not available, I hope. Like, even I have not seen these features till now. For giving me this opportunity, by giving this opportunity, I have learned so much what is happening in the recent things. So we have come from basic boils to anesthesia workstations. So what are the main things the developers have kept in mind while developing these machines? It is mainly the patient safety. And then comes the economy of the anesthetic agents and environmental sustainability, like decreasing the greenhouse effects of other gases, and to provide an integrated platform for all the anesthesia services. So, but even though many machines has come, the ultimate responsibility for their safe use, it rests with the end user, that is all of us, okay? And an oxygen analyzer and a vigilant anesthetist is a minimum mandatory requirement for providing safe anesthesia. So this is a brief picture of the division of the different divisions of the anesthesia machine. We all know the high pressure system, the intermediate pressure system, and the low pressure system. High pressure system starts from the cylinders. Here you can see the cylinders, their pressure gauzes, the cylinder hanger yoke assembly will be there here. All these constitute the high pressure system. And the intermediate pressure system, this okay, this is the intermediate pressure system. It starts from the pipelines, includes that pipeline pressure gauzes, all the fail-safe valves, the oxygen supply failure alarms, the second stage pressure regulator, and the oxygen flush valves. All these are included in the intermediate pressure system. And downstream from the flow meters, it is a low pressure system. We all know this. And this in brief is the what we already know, the safety features in the modern anesthesia machine. The anesthesia machine has pneumatic components, electronic components, and a scavenging system. And all these are the safety features. These are depicted in this picture. So coming to this, in the high pressure system, we have the color-coded cylinders. The cylinder is made up of molybdenum steel alloy, which is stronger and lighter. The pin index system in the hanger yoke assembly and the cylinder head. The pressure relief valves in the cylinder, which comprises of rupture disc, fusible or plug, and pressure regulators to decrease the pressure from the cylinder. Okay? And then in the intermediate pressure system, we have the Schrader probe to prevent misconnection to the wrong gas service, the color-coded kink-proof hose pipes, the diameter index system, the non-interchangeable screw thread at the machine end. The Schrader probe is at the wall end. This non-interchangeable screw thread is at the machine end. And then we have and then we have the color-coded pipeline pressure indicators. All the pipelines are color-coded. And then we have the oxygen flush, control flush, which gives around 35 to 75 liters per minute of oxygen supply. And this is protected from accidental activation. It is present in a recess so that it cannot be touched accidentally. And low pressure system, there is a mandatory minimum oxygen flow of 200 ml per minute in some machines. The flow control knob for oxygen is the largest, most protruding and fluted. The Link 25 system, which is a mechanical linkage of oxygen and nitrous oxide flow control knobs. All the flow meters have an anti-static coating on both surfaces, preventing the bobbin from sticking. Neoprene washers at both ends of the flow meters. The oxygen flow meter is always positioned downstream or last in the sequence of flow meters. Even though if it is present in the upstream also, the flow of oxygen goes and mixes downstream of the flow meters. Then there are some safety features in the vaporizers like lock system, the interlock system, so that two vaporizers cannot be used at once. The vaporizers are again color coded, and they have a transport mode so that the anesthetic gases don't spill. And they have a keyed fillers. All these are also some safety features. Then in the electronic component, we have the main on-off switch. We have the battery backup for the anesthesia machine. And these are the self-checkout features and the electronic flow meters. These are present in the newer anesthesia machines. And scavenging system, it has a separate connector so that we cannot mistake with the breathing system and the scavenging system. We cannot do a mistake. So these are some of the safety features. All these are some pictures. These are the Bodox seal at the hanger yoke assembly. This is the pin index system. These are the pins in the yoke part, and this is the holes in the cylinder part. This is the flow control knobs. This is the non-interchangeable screw thread at the machine end. This is a Schrader probe at the wall end. So coming to the limitations of these older anesthesia machines. So these are completely mechanical systems, and they were designed to meet demands of anesthesia practice in the era of semi-open circuits and high fresh gas flows. There are multiple exposed connections in these systems which are subject to disconnection, misconnection, kinking, or obstruction. The small leaks, they are inherent to the such systems. They make the practice of low flow anesthesia very difficult. And the flow meters are inaccurate in the delivery in the low flows. And there are no performance feedback mechanisms in the older anesthesia machines. So in the older anesthesia machines, most anesthesia ventilators, they are the bellows type. That is the bag-in-bottle double circuit machines. And these bellows type ventilators, they use a pressurized oxygen for driving these bellows. So there is a increased consumption of oxygen. Some of the newer variants, they don't use oxygen, but they should use pressurized air. So there is a increased consumption of gases for driving these bellows and ventilating the patient. So they don't have a internal PEEP valve, and external PEEP valve might be used with its inherent risk. It increases the barotrauma. And advanced modes of mechanical ventilation, they are not available with the older generation ventilators. And this can be shortcoming when you want to anesthetize a critically ill patient who is having so many respiratory complications. And older ventilators, they do not have integrated volume and pressure monitors. Like they don't show the flow volume loops and all. And this exposes the patients to unrecognized risks, disconnections, and barotrauma. And they are unable to deliver the tidal volumes with accuracy. So all these are addressed in the newer anesthesia machines. So they are compact in design, they're easy to use with enhanced safety features. They have electronic flow meters. They have modern ventilators, like what ventilators you can use in the ICU, they are incorporated into the newer anesthesia machines. What all modes we can use in the ICU patients, though all the ventilator modes are incorporated into the anesthesia machine. And all these above features, they led to a practice of target controlled anesthesia. We'll discuss what is target controlled anesthesia further. And there is an auxiliary common gas outlet in the newer anesthesia machines, and they features the enhanced environmental sustainability. These are some of the latest anesthesia machines from the various companies. In this, the Drager Perseus A500 and Drager Etlon and Drager ZS, these are the most innovative, like these are the latest machines. You can see here the Drager Etlon 350. You can see the electronic flow controls, integrated patient monitor, provision for 3 vaporizers, and this is a piston type of, this is a turbo vent type of ventilator used. There is no bellows here. You can, and all the infusion pumps can be integrated into the machine itself. This is a Drager Perseus 500 machine. All these you can see, same features. And this is a Drager machine, same, but this is a ceiling mounted machine. So you can mount it in the pendant itself, so that the OT floor is free of wires. The messiness of all the wires hanging out is reduced. But the disadvantage is in this is you cannot shift the ventilator from one OT to the other. It is fixed. So this is a GE machine, the latest one. It is a GE Care Station 750. So if you go into the net and search all these companies, they will give you the product brochure details. So in it itself, you can get all what innovations they are doing here. So here we can see all the machines are, they're mainly concentrating on providing the low flow anesthesia, lung protective ventilation, and integrated monitoring for tailored anesthesia. So these are the newer happenings in the anesthesia machine things. So this is again the GE brochure. Here we can see a thing called EcoFlow. We'll come to that. And this is nothing but the economy flow. Then they have also introduced the lung recruitment also in this machine. And spirometry loops are also introduced. So coming to these topics one by one. So electronic flow meters, these are more accurate, and they do not have the disadvantage of having multiple mechanical parts which are prone to leaks and breakages. This is the main advantage why people are shifting from the flow meters to the electronic flow meters. And the underlying mechanism, the Drager has kept it the same. There is a needle valve which goes into the flow meter. So flow control knobs are present in the Drager machine. But in the GE machine, this needle valve is removed, and it is completely, fully electronic. The flow system is fully electronic in the GE machine. This is a GE machine electronic flow meters. Coming to the circle system. All the newer anesthesia machines use a circle system, and they are equipped with features for providing low flow anesthesia. Here we have a concept of something called fresh gas flow O2 and FiO2. So what will happen in low flow anesthesia is, we keep the fresh gas flows less than 1 liter per minute. Okay? So it consists of carrier gas and also oxygen. So combined, it is less than 1 liter per minute. In this low flow anesthesia, in the newer anesthesia machines, what we can do is, we can alter the FiO2. Like we set an FiO2 of 50% or something, like in the normal ventilator. But if we alter the gas flows, like if we set it at 500 ml per minute instead of 1 liter, the FiO2 will decrease. So the hypoxia prevention devices are incorporated in the machine itself for these newer anesthesia machines, so that the FiO2 supplied will never come down below 25%. So in the circle system, all the connections are internalized to reduce the likelihood of misconnections or disconnections, and the circuits are made compact to reduce circuit volumes to enable rapid changes in gas composition at low flows. And also the manifold. In some machines, this manifold, the circle system manifold, it may be heated. A temperature element, a thermal element may be provided to heat this manifold to prevent the condensation of water vapor, which was responsible for unidirectional valve malfunction in older versions. Some machines have water trap also incorporated in them. And the current trend of using low flow anesthesia has driven development of new alkali-free carbon dioxide absorbers like AMSORB to reduce carbon monoxide formation and to reduce the degradation of volatile anesthetic agents. So this is a integral breathing systems present in the newer anesthesia machine. I suppose all of you have seen this. This is the inspiratory O2 sensor port with inspiratory valve. This is the inspiratory port. This is the expiratory port. This is a connector for manual breathing bag. This is the expiratory valve. And these are the PEEP valves. And this is the APL valve. So in dragger machines, there are some features called the low flow wizard and the econometer. So this low flow wizard, it compares the calculated fresh gas consumption, that is the patient uptake plus circuit leakage plus volume of CO2 absorption by soda lime, with the current total flow in an easy to interpret graph. Each of these tools are useful in low flow anesthesia as well as assisting to provide economical anesthetic gas delivery at the same time. At the same time as preventing hypoxic situations. So I told no, when we practice low flow anesthesia, even if we keep FiO2 at 50%, as we decrease the flows, the FiO2 supplied actually decreases. So to prevent this, the machine itself calculates the flows and it will suggest us what are the flows to be kept. Like it shows a total flow, like this is 2 liters per minute, and required fresh gas flow, it will suggest us. So we can reduce the fresh gas flow. So, and it denotes us if it is efficient low flows anesthesia or not. And coming to the econometer, this is present in the Perseus A500 monitors. What it does, it monitors the filling level of the manual breathing bag and displays the qualitative fresh gas supply in a bar graph of the econometer. When in the yellow area here, there is a surplus of supply and the possibility to save fresh gas and therefore anesthetic agents. Means when the indicator is in this yellow area, it indicates that we can decrease the fresh gas flows and save more on the anesthetic agents. Here the red area means there is insufficient fresh gas supply and the user needs to fill the manual breathing bag. The econometer trend graph provides an indicator for the qualitative fresh gas supply during the last 30 minutes. So coming to the auxiliary common gas outlet. We all have seen this. This is the auxiliary common gas outlet. Apart from the inspiratory and expiratory outlets present on the integral breathing system. So this is the switch. This is a master switch to use either the circle system or the auxiliary common gas outlet. Usually what we do is we connect a Bain circuit to this and we manually ventilate the patient. But there are so many case reports, or I'm sure every one of us has experienced, this is called the death switch. Because we put it in the open auxiliary common gas outlet switch and we connect the circle system to the patient. The patient is not ventilated, we forget. That is the main thing here. We forget switching it back into the circle system. Coming to the ventilators used in the newer anesthesia machines, traditionally, anesthesia ventilators have been pneumatically driven. That is, they are called the bag-in-bottle systems. That is, there is a bellows in a bottle kind of thing. The bellows moves up and down, and patient receives respirations, or receives ventilation. Again, these bellows are divided into two types, ascending type bellows and descending type bellows. I have not seen descending type bellows, but I think most commonly ascending type bellows are seen. What happens is, in ascending type bellows, the bellows will descend during inspiration and ascend during expiration. While in descending type bellows, the bellows will descend during expiration and ascend during inspiration. So that is the difference. And this descending type bellows, it has gravity also working on it. We have to remember that when it is descending, it has gravity also working on it. And coming to the disadvantages of this, it consumes so much oxygen that, as I told already, it needs a drive pressure of oxygen, pressurized oxygen, to drive the bellows. So it consumes so much oxygen. And we all know during COVID time and all, oxygen deficiency was there. During such situations, or if you want to do the case economically, this is not an option. So to counter this, there is a new type of ventilator introduced called the piston type of ventilator. This piston type of ventilator, they don't have bellows. It is just a piston. The piston is, it moves up and down. The piston moves up and down. And it drives the pressures into the patient. It drives the pressure and flow into the patient. And there are also another type of ventilators called the turbine ventilators, and also the volume reflector ventilators. These are the other two types. So this is the ascending and descending bellows I have shown. The ascending bellows ascends into the in exhalation and descends in the inspiration. Descending bellows, it descends in the expiration and ascends in the inspiration. So there is a concept called fresh gas flow decoupling. I did not understand what is this when I am in PG. So this fresh gas decoupling, this is seen in the piston type of newer dragger machines. The fresh gas flow decoupling valve, I'll just discuss this here. So here you can see there is a decoupling valve. This is a ventilator, piston type of ventilator. The ventilator is connected between the fresh gas flow and the inspiratory limb of the patient here. So there is a decoupling valve introduced here between the fresh gas flow and the ventilator. So what will happen? This fresh gas flow decoupling, what it means is, when the ventilator is sending inhalation to the patient, this decoupling valve closes. So what will happen? The flow meter, the fresh gas from the flow meter and all, it collects in the reservoir bag. Okay? It is diverted and it collects in the reservoir bag. And also the exhalation of the exhaled air from the patient, it passes through the soda lime and also collects in the reservoir bag. So this acts as a reservoir when the patient is getting inspiration. So this is called the fresh gas flow decoupling. Means the fresh gas is cut off during the inspiration to the patient and it collects in the reservoir bag. Now during expiration, what will happen? The ventilator piston, it creates a negative pressure. Okay? It moves up and down. No? When it is moving up or down, it creates a negative pressure during expiration. So what will happen during this expiration? The decoupling valve opens and the gas collected in the reservoir bag, it moves into this ventilator during expiration. Okay? So this is a combination of exhaled air, fresh gas flow, the anesthetic vapors all connected in the reservoir bag, it moves into the ventilator. And now again the decoupling valve opens. Now again during inspiration the decoupling valve closes, fresh gas flow is cut off and whatever gas is collected in this ventilator, it is sent to the patient. Okay, you understood? Everybody understood? So what is why this is done? Why decoupling is done? Yeah, the advantages are, yeah, the fresh gas flow decoupling advantages are, it separates the fresh gas flow from patient during inspiration and whatever we know O2 flush is connected to the intermediate pressure system. And if accidental O2 flush is given, then it does not go to the patient. Barotrauma is avoided and it will make the ventilator to provide a precise amount of tidal volume to the patient. Okay? But there are some disadvantages, that is the changes made in the fresh gas flow or the anesthetic concentration, they do not transfer to the patient fast. Like they collect in the bag and after some time only they are transferred to the patient. So if you want rapid depth of anesthesia or if you want to increase the oxygen concentration more, the transfer of these, this is late to the patient. But all the gases are saved, economical, it is very economical. And this piston type, as we all understood, during inspiration, the reservoir bag fills. During expiration, the reservoir bag becomes empty. Okay, the dragger people who have dragger machine, have you understood now? Your bag moves, no? It fills and empties with the inspiration and expiration. GE, who are having GE ventilators, GE care stations, the bag is completely disconnected from the circuit. It does not move. Okay, because the GE care station, it is a bellows type of ventilator. Okay. So there are another type of ventilators called the turbine-driven ventilators. They use mechanical energy to spin a small turbine or fan at very high speeds to create pressure and flow. Advantages are better responsiveness to patient triggering, more effective pressure support ventilation, more accurate tidal volume delivery, and high ventilatory workload. So here, there is a turbine here. This spins and it stops. During inspiration, it spins. It drives the flow to the patient, and during expiration, it stops. So what will happen? This turbine ventilator, the reservoir bag empties during inspiration and fills during expiration. So this is the opposite of the piston type of ventilator. So both are present in Drager's machines, machines only. One is a piston type and one is a turbine type. Finish. This is a MACA flow eye anesthesia system with volume reflector type of ventilator. Then the other innovations are the Aladdin 2 cassettes and the DIVA, direct injection vaporization agents. So they inject directly into the gas flow. These are also present in the Drager systems. And all the machines, they come with the automatic machine check, self-test. And manual inspection, we may miss some things. And they present all the values. And it is very fast also. Coming to the target controlled anesthesia, we are redefining anesthesia with all these methods. Here, to provide target controlled anesthesia, the end-tidal control mode is used. The anesthetist sets target for end-tidal oxygen concentration, minimal flow rate, and end-tidal volatile anesthetic concentration. The system uses an algorithm to adjust both fresh gas flow and vaporizer output to achieve the set flows through a negative feedback control system. Fresh gas flows automatically reduces down to the minimum set value, although this can be increased during the case to compensate for system leaks. So I'll just come to the example. So here, the Drager machine has a end-tidal control. Here, we can set the end-tidal controls. Like here, we set the end-tidal O2 to 50%, minimal flow to 1%, end-tidal sevofluorant concentration to 2.1%. What will happen is, the machine adjusts this so that these end-tidal values are achieved. And it will suggest us, like here, the minimal flow is 0.5. I have shown the previous one, no, the low flow meter. That there it will suggest you can reduce your flow further. Like that it will suggest. Seeing those suggestions, we can adjust the flows. So what will happen, what is the use of all this? We can control the delivery of the volatile anesthetic. So the less we give, the better, no? But we have to see that the patient is in the anesthetic state. So along with the BIS monitor, this adjusts all these and it will provide adequate depth of anesthesia at the least possible fresh gas flows. So coming to the scavenging system, there are two types, active and passive. Active also has several types. The basic components of scavenging system are collecting system, transfer system, receiving system, and a disposal system. So as name suggests, collecting system helps to collect gases from either the APL valve or the exhaust port of the ventilator. Transfer system transports this to the reservoir, and disposal system, it can be either active or passive. Passive means you just leave the transfer system open to the atmosphere outside the OT. while active means uh, it actively pumps the gases outside of the OT. So this is a scavenging system. Here we can see it is a 30 mm connector, while in breathing systems we use 15 mm and 22 mm connectors. So in the same company websites, you can compare all the web machines also like this. So there is some innovations in MRI compatible anesthesia workstations, and other anesthesia innovations are point of care monitors, precision drug delivery, informatics in perioperative medicine, and anesthesia information management system. It is very difficult to cover all these. Limitations, we still have limitations in spite of all these innovations. These are, despite the continued movement of a descending bellows, despite a leak or disconnection. Like if you have a machine with descending bellows, even if you have leak or a disconnection, due to the gravity, the descending bellows will move. So it is very difficult to recognize the disconnection and leak. And a small amount of PEEP is transmitted to the patient during ventilation with an ascending bellows system. And augmentation of tidal volume when oxygen flush is activated in the inspiratory phase of ventilator-delivered breaths in machines without fresh gas flow decoupling. So this is the advantage of fresh gas flow decoupling. And these machines are highly dependent on electricity. And inability to detect carbon monoxide production. Last but not the least, human error due to ignorance or lack of understanding or training. So we are actually transforming our anesthesia practice into an era of smart ventilation control, where artificial intelligence enabled systems take care of anesthesia goals like maintaining cerebral blood flow, hemodynamic goals, ensure adequate organ perfusion, reduce risk of atelectasis, maintain appropriate depth of anesthesia, and minimize carbon dioxide footprint. In spite of all these technological advances, the minimum monitoring standards mandate that a qualified anesthesia personnel shall be present in the room throughout the conduct of all general anesthetics, regional anesthetics, and monitored anesthesia care. We have to keep in mind this. Never rely on machines. Thank you.
Thank you for the great lecture, ma'am. We will surely benefit from the lecture. I would like to request Dr. Kalyan Chakravarti sir, Professor and HOD, and Dr. Jayachandra sir, Associate Professor, to hand over token of gratitude to Dr. Sweta ma'am. Thank you, ma'am.
So it's a very vast topic, but you concluded well. Good job.
I would request all our guests to relish over the refreshments waiting outside for you, and join us back within a duration of 10 minutes for more interesting lectures waiting for you. We are honored to welcome Dr. Shalini Bajpai, Professor of Anesthesia from GVP Visakhapatnam, to provide a lecture on the topic Artificial Intelligence in Anesthesia. I'm sure the lecture would be thought-provoking and it would ignite our discussion. Please welcome, ma'am.
Good morning to all of you. So today I'll be talking about artificial intelligence in anesthesia. There is a whole book about artificial intelligence in anesthesia. I can't do justice to that, but hopefully I can do justice within the next 30 minutes, which is allotted to me. So let us start. I would like first to know about your perception about artificial intelligence in anesthesia. All the postgraduates, please. Are you using AI in your anesthesia practice? Anybody of you? Please speak loudly. Anybody? No? Nobody is using. Okay, fine. Will you accept AI in anesthesia practice once you come to know about it? Yes? And the million-dollar question, will AI replace anesthesiologist ever? This no should be a good one. Will AI replace anesthesiologist? Okay, fine. So with this perception of AI, I would like to, let's dive into artificial intelligence in anesthesia. So I would like to cover my topic under the following subheadings. So what is AI? So artificial intelligence is basically the capability of computers to respond in a manner resembling human intelligence and perform tasks like learning and critical thinking, decision-making, complex problem solving, speech recognition, visual perception, and so on. So what about the evolution of AI? So McGrath and Minsky were the fathers of AI, and in 1956, they described the definition of AI. So it is like early artificial intelligence in 1950s, then came machine learning in 80s, and then deep learning in 2000s. I'll tell you what are all these. This might sound new to you, but in next slides, you'll understand. So what is the basic structure or the subsets of AI? So artificial intelligence, it basically involves the use of algorithms to train the machines to perform tasks that otherwise requires human intelligence. And what is machine learning? It is basically a subset of artificial intelligence that the machine learns with experience. It is exposed to a lot of data, so it's not kind of pre-programmed. It keeps on learning through the experience with all the data that is fed into it. Then comes deep learning. Deep learning works like normal human brain, like it is called as deep neural network. It can analyze complex data sets and form connections. It is called as DNN. And what is data science? Data science is basically a multidisciplinary field that encompasses all three. That is artificial intelligence, machine learning, and deep learning. So what are the branches of AI? There are 6 branches of AI. First is expert system. So expert system is what? It is reasoning like human brain. If then rules. If this happen, then I will do that. Like that, the machine also does like that. If then rules. Robotics. Robotics is basically the use of machines to perform human tasks with much more accuracy. Then machine learning, as I told you, it learns from experience. Neural network. What is neural network? Is millions of neurons like human brain in a machine. Fuzzy logic. So it provides reasoning or logics about the inaccuracies, about the uncertainties that happen. So that is fuzzy logic. And natural language processing, that it processes. The computer processes the human language. So that is natural language processing. So the stages of AI, it is 3, narrow intelligence, general, and super intelligence. Narrow intelligence limited to one task, weak AI. Like you have your Siri, Cortana, all those things, it performs only one task. Then machine intelligence means the computer is doing like human. Like it is coming at par with the human. Now this kind of, it is strong artificial intelligence, which is being developed all over the world. And then there is something called as artificial Super intelligence means machine consciousness, that the machine has surpassed the human brain. So pray to God, it is still in scientific fiction movies that we see on Netflix, it's still not present. So what are the uses of AI? In today's world, there are a lot of uses of AI in astronomy, social media, travel, industries, robotics, gaming, security data, as well as in healthcare. So how do we use AI in healthcare? Its application is versatile, like in drug development, diagnosis, treatment, in research, in fraud detection, in nursing assistance, and robotic surgeries that you all know. So let's come into artificial intelligence applications in anesthesia. I hope you have a basic idea about the branches of AI, what is AI, and what are its subsets. Now we will see its applications in anesthesia. So we should be proud that anesthesiology is the branch in the medicine that first implemented AI. So anesthesiology first established the pharmacokinetic and pharmacodynamic models, which are called as pharmacological robots. The servo anesthesia theory system came in 1980s, then came targeted control infusion in 1990s, then EEG Dept monitoring and CLAD system, and last but not the least, the anesthesia robots. So what is the use of machine learning in anesthesia? As I told you, by experience, it detects patterns and perform predictions on this. It analyzes lots of millions of data from the electronic health records, and it will develop a pattern and it will try to perform predictions. Like it can predict post-induction hypotension by analyzing the peri-op data. It can analyze or predict the post-intubation hypoxemia. There is neural network, which is also a subset kind of machine learning, which detects esophageal intubation by flow volume loops. So if this develops very well, capnography might go underground because it can detect easily the neural network. So robots in anesthesia, please, the robots don't look like this and not like our fiction movies. Our robots in anesthesia look like our monitors and syringe pumps only. So what is a robot? A robot is a mechanical system which is capable of interacting with the environment according to directed interventions. So it helps to free the anesthesiologist from repetitive tasks. It allows anesthesiologists to concentrate on assessment, decision making. It supports the clinicians and offer recommendations to aid in decision making. There are basically 4 types of robots. One is a cognitive robot. One is a pharmacological robot. The third is a manual, mechanical robot. And the fourth, the new one you all know, ChatGPT, chatbots. So let's start from cognitive robots. So what are cognitive robots? These are basically human brain-inspired robots. They perform the perception and cognition like a human brain. So basically, the cognitive robots came in 1950s, and the latest version is Anesthesia Information Management System, that is AIMS, also called as Anesthesia Record Keeper. So you can see in that machine all that 2 things which are on the top. Yeah, this is AIMS software. So what does it do? It enhances clinical documentation decision making throughout the peri-op period, from the pre-op to intra-op, that is OR, and the post-op care. It will help in monitoring, in drug calculations, in quality assurance, and billing. So we have 3 types of AIMS, like centricity anesthesia. This is centricity anesthesia by GE, then Innovian by Drager, and CompuRecord by Philips. Then what is, next one is, slide is not moving. Yeah. So the next is Smart Anesthesia Messenger, that is SAM. So it uses AIMS database, that is the record keeper database, but there will be a pop-up message on the same screen. So what it will help in? It will help to improve the compliance of drugs. So if you have not given antibiotics on time, there will be a pop-up message over there that the next dose of antibiotic is due. Or if you have not checked the machine, there will be a pop-up message, please check the anesthesia machine, right? So it improves the compliance to drugs, it helps in patient vital monitoring, and it improves billing. So AIMS and SAM, these are the cognitive robots. Next. So pharmacological robots. So what are pharmacological robots? They basically help in conscious sedation, and they provide anesthesia and keep some parameters like BIS or blood pressure within a target range. It does that through microprocessor control feedback loop systems. This you all must be knowing, TCI, Target Control Infusion System, that is DIPRIFUSER. It is the first generation open loop pharmacological robot, right? So in that, there are pharmacokinetic models already fed into the system of the different drugs. Based on this, it will first deliver a loading dose. Loading dose will be followed by a maintenance dose to maintain the anesthesia. So in that, basically what we do is we feed the parameters about the patient, that patient age, weight, height. Then we select models. There are many models of that. You must have heard of Minto. You must have heard of PEDRIFUSER for kids, and a Schneider model for propofol. So these kind of models we will select, and it will give the propofol or the drug as to maintain a particular target or effect site plasma concentration of that drug. So these displays are estimated plasma and effect site concentration, which may differ from the actual concentration. Next. So then came closed loop anesthesia delivery system. So what happened in closed loop anesthesia delivery is they started using real-time things, real-time parameters like BIS, entropy, and all. So they took that into account and they changed the infusion rate. So this acted like a real-time feedback to maintain a particular effect site concentration, right? So that is CLAD. So they say about CLAD that it determines the right drug, right dose at the right time. So drug delivery system to deliver drugs targeting an anesthetic depth. In this, we set a goal for a measured variable, and drug delivery is adjusted to make the gap between the set goal and actual variable as small as possible. So there are basically single input, single output, and multiple input, multiple output systems. Single input, only one BIS or TOF. Multiple, like BIS combined with TOF or analgo score or stroke volume. So all of you, I don't know how many of you have heard of McDreamy, an awesome doctor from How I Met Your Mother. We don't have McDreamy here, but we have McSleepy. I don't know if you have heard about it. So it's the world's first robo-anesthesiologist, and it is as awesome as McDreamy. So it is an automatic expert-based CLAD system. It automates the controls of GA and monitor the patients. It integrates all the three components of general anesthesia. That is hypnosis, muscle relaxation, and analgesia. You can see there on that picture, all the three. These are the data, and these are the three things. These are three infusion pumps that will be attached to it, and we just have to start it. There's something called as auto anesthesia. Now we are using here is TCI. So if we use closed loop TCI along with anesthesia depth monitor like BIS, so it is AI plus automatic control. It becomes auto anesthesia. It is used in high-risk surgeries like cardiac surgeries, GI surgeries, and FIOC surgeries. Next. So, as you can see, this is the screen of McSleepy, three controls, the parameters, BIS and algo score for pain, TOF muscle relaxation, and three infusion pumps, propofol, fentanyl, and rocuronium. There is another type of pharmacological robo known as iControl RP closed loop IV intravenous anesthetic delivery system. So what it does, it monitors the patient EEG level of consciousness based on BIS monitor as well as the patient vital signs. Then it makes its own decision through all the algorithm run within inside it regarding the IV administration of propofol and remifentanil. Next. So Sedasis. So Sedasis is basically, this is a picture of Sedasis. It is a computer-assisted personalized sedation system. So what it does is, it is a model designed to administer propofol to achieve mild and moderate sedation. It is safe because it can detect the sign associated with oversedation and can stop the infusion. It can be used by non-anesthetic physicians also, but it is not being used now. Not because that it was faulty, but it used a tagline that Sedasis can replace anesthesiologist. So we anesthesiologists could not tolerate it, and we all boycotted Sedasis, although it was an awesome machine and very safe, but marketing was poor. Then there are other CLAD systems like goal-directed fluid therapy models, which deliver fluid bolus based on urine output, blood pressure, stroke volume variation, MAP, or a combination of these. And blood pressure control models, which control the blood pressure by titration of vasopressor like phenylephrine and norepinephrine, and it is based on non-invasive blood pressure, stroke volume, and stroke volume variation. It maintains the MAP within 5 millimeter Hg of the baseline. So now comes the mechanical robos, third one. So what are mechanical robos? They do the gestures, they help the humans, but they do the work of the human and improve their efficiency. So all of you must have heard about Da Vinci robotic system that we use so many times in prosthetic surgeries and other abdominal surgeries. But I don't know if you know that it has been first used also for doing intubation. It was used for providing popliteal block also. So FOB assisted oral and nasal intubation was done in airway mannequin, and Da Vinci type S performed the first simulated robotic intubation. It is clumsy because it has 4 robotic arms, so it was technically really difficult. And there is a workstation. This is basically the setup of Da Vinci. You can see there. This is the console. Here, the anesthesiologist can observe the camera feed, manipulate the robotic limbs, and receive video input. The timings were 75 seconds and 67 seconds for oral and nasal intubation, respectively. So this is basically Da Vinci. There is the first one is this is FOB. And this is one arm which is carrying the FOB. It is fixed on it. This is the camera feed, which is being observed by the anesthesiologist to guide the intubation. Then that was in airway mannequin. But Kepler intubation system came. Then it was the first robotic intubation in human was done by KIS, Kepler intubation system. It improvised itself. There was only single robotic arm. So it was not much technically difficult. It used video laryngoscope. Also, there is a joystick which used to guide the endotracheal intubation. So the robotic endoscope was used for visualization, and automated tube placement was done towards the epiglottis. As you can see here, there is a single arm. This is the joystick. This is VL guided endotracheal intubation. It was done in human also, but in human it took 93 seconds. So this is a prototype of robo which can be used for human intubations, but still it has to be more modified. Next. So remote robot assisted intubation system, RRAIS. So it has a different aim. It wanted to success for pre-hospital endotracheal intubation also, for paramedical professionals. So as you can see, it has a control system, a screen, and a joystick to control. And there is something called an intubation robo. Like we have our laryngoscope, it also had a tongue depressor and a posture and feeding mechanism to push the tube forward. So the success rate as compared to DL was higher, that is 90%, but the intubation time was longer. Next. Then came Intubot. This is an important one. This is a robotic prototype aiming to automate the intubation. It is a real-time vision-based navigation algorithm which guides the stylet to locate the vocal cords and target the destination. There's 2 motors. So one motor is used for steering the stylet, and another 2 motors, they will help in bending the tip. You can see that tip. Next. This is Intubot. So this is bending the tip. It is very helpful in difficult intubations. This is the camera feed directly. This all is joystick controlled. It localizes the center of the carina. And the stylet bend towards the carina. So, back. So then came reality, that is robotic endoscope, automated laryngeal imaging for tracheal intubation device. So this also used endoscope, but it had an image recognition software. So you can see this, these all rectangles and squares. So what it will do is, it enables the automated movement of the tip toward the geographical center of the glottis. Because when humans do, we are not able to center the tip. Many a time we feel problem in that. But this software helps in that. It has 2 modes, automated and manual mode. Automated mode was much faster than for tracheal access than manual. Next. Then we use so many robots for intubation, then why not for nerve blocks? So first came Magellan system. Magellan system is for nerve blocks, for training nerve blocks using ultrasound-guided robotic needle placement. It is controlled by joystick. It has a robotic arm, as you can see here. It is better dexterity and precision for safer injection. It can aspirate and stop the injection when the pressure exceeds a set value. Next. And there is one more novel airway management robo for non-invasive positive pressure ventilation, which is called as MAS, mask ventilation robo. So these two, it has two snake arms, as you can see here. These snake arms, it lifts the patient jaw, and there is a mask fastening mechanism for fastening the mask on the face. The operator can use it through a joystick. Next. There is something as robotic IV catheter insertion hemobot. It locates the most stable vein area and safer injection of regional anesthesia, that is Safira. It's a special kind of syringe which aspirates and stops the flow when the injection pressure exceeds 20 psi. So it's basically very, very helpful in preventing the nerve damage. As you all PG do, you feel when you are injecting, there is a pressure, what to do. So you keep on injecting, but it will stop. It will not continue injection. So something which looks really like Robo from movies, Robonaut 2, R2. It is a humanoid robot which was developed, and it has versatile applications like in telemedicine, in syringe, in central venous cannulation, and in intubation. But the limitations were lack of speed, large hand size, and poor grip. Next. So lastly, Moxie. Moxie, the newest addition in robos. That is the newest nurse robo. Can you please run the video? So Moxie helps hospital run 24/7 by assisting the clinical staff. It runs the patient's supplies, it delivers samples, it fetch items from the central supply and distribute personal protective equipments, and also have interactions with peds and dementia patients. So Moxie can be very, very helpful to us. It has been used in many, many hospitals abroad. It can be used in the pre-op area. It can be used in the post-op area. We have shortage of nurses, and most of the time our PG will be roaming around getting the supplies. So let's welcome Moxie if it comes to India. Next. Chatbots, the fourth type of robo. So what is that? All of you must be knowing it. These are automated speaking and writing devices for aiding communication between physicians and with machines or patients. It is used for acquiring medical knowledge and create a transcript during PAC, for analyzing lab results, giving diagnostic advice. So what are these? The examples are OpenAI ChatBT, Microsoft Copilot, and Google Lambda. They are saying that ChatGPT 3 possesses the ability to reason, something only we used to do, but ChatGPT is another contender. It can reason, but it has to be proved yet. Next. So let's summarize the current trends of AI-enhanced anesthesia. These are all the robos and the machine learning which has been developed. But these robos, only few of them has been used in humans. Still, they have to do a lot of clinical research and trials before they can enter our OR. So in our OR, the current trends, what is happening, how we are using AI in anesthesia. Next. So basically for pre-anesthetic evaluation, that is risk stratification, which is very helpful by machine learning models so that we can explain to the patients this surgeries carry so much of risk, and we can do the counseling. For pre-operative checklist, for surgical safety definitely. So AI is also used in airway assessment, difficult airway assessment by facial recognition techniques. It is also used antibiotic selection and dosing, as I told you, CDSS, Clinical Decision Support System, and PSC interaction in native language. How you can do it? By Google Translate. Simple. Speak in your language, it will translate into words, then again to their language words, and again to speech. So this is how AI is used. Next, for intraoperative anesthesia care, monitoring, smart monitors. You must have heard of Philips IntelliView. So much of monitoring can be done. Record keeping, I already told you, AIMS. Anesthesia record keeper, clinical decision support by CDSS, clinical decision support system, depth of anesthesia monitoring, BIS, control of anesthesia delivery, CLAD system, and event prediction. I told that it is the machine learning models which do event prediction. In post-operative anesthesia care, opioid-induced respiratory depression prediction by machine learning models, intelligent patient control analgesia. It also helps in early discharge and ambulation, how we can monitor the patient from home by video conferencing. So that is teleanesthesia. So it decreases the healthcare cost and patient satisfaction. Next. So AI and operating room logistics. Operating room logistics, it can schedule the AR time. It can track us. So this is not a good idea to track us. We can go anywhere. So we have radio frequency identification tracks. So it can track the movements and actions of the anesthesiologist. It can predict the duration of the surgery, neural network, how it will predict the duration of the surgery. It will have data embedded into it about the particular surgeon. Like we all know, this surgeon will do the take 3 hours, this will take 1 hour. So it will just see those data, go through it, and then it will predict the duration of the surgery along with surgeon-patient comorbidity as well as the complexity and all the reports. So optimize the bed use by fuzzy logic and neural network again. Next. So AI and teleanesthesia. So all of you know about AI assistants, smartphone AI apps. So the anesthesiologist can control the gadgets. It's like an automation system through these apps like, OK, Google, please increase the height of the table. Alexa, you can control the lights. Siri can play something, help in AC control. And Hola Bixby can play some music for you. So these are all AI assistants which can be used in operation theater. We can also be benefited by AI in pre-op evaluations by teleconference, but to a limited extent. Virtual presence and guidance in perioperative period for interventions in education, and virtual anesthesia that we all talk about, that we will give virtual anesthesia and we laugh about it, but to some extent it is true, because virtual anesthesia to distant patient is possible through augmented reality along with AI. And this has been done from Canada. Virtual anesthesia was provided to Italy by Dr. Hammerling and his colleagues. So one more beautiful thing is automated anesthesia cart, which will be very much helpful for us. It is an intelligent computer system and management cart which stores the drugs. It has clear labels about it. So there is a computer which is incorporated into the cart. It records the information of the medications which are given during anesthesia. So it reduces the drug recording errors, which generally happens in anesthesia practices. Many a times we see that. Now, how AI help in ultrasound? It help in epidural placement by identification of vertebral level or needle entry site. It can help in ultrasound imaging, in peripheral nerve blocks, focus and vascular excess, in image enhancements, in video bronchoscopy images of carina, and AI-powered voice controls are there in ultrasound system. It is like a portable scanner that you can put, and you are doing any block, so you can just speak, freeze the image, increase the gain, increase the depth. So all these can be done through voice control. Example is Clarius voice control. This is ultrasound system. In regional anesthesia, how AI is helpful? VR-based regional anesthesia simulators are available for nerve blocks. You can see on the right side. So the trainee controls the needle through a virtual haptic device. VR-based simulator for spinal anesthesia is also available. So they have their data embedded into it, and it sees everything, and it basically is much more helpful in telling the exact location for the needle entry. This is VR-based. It will feel as if we are doing it. So in pain, so it can help in prediction of opioid dosing by same machine learning methods. It can gauge pain levels and direct pain treatment measures. It can also help in identification of the patient in the pre-op area or pre-anesthetic area when the consultation is done, that this patient can be benefited from hospital acute pain services, and they'll be enrolled in that, and the APS will take care of that. So it can help in taking therapeutic decisions in chronic pain and palliative care, because it can analyze long-term data embedded and develop an algorithm that this medicine will be helpful. In anesthesia education and training, it may, by lifelike simulations, mimics various anesthesia-related complications, so the students can just learn from it. It gives personalized feedback and suggestions, and ongoing education for practicing anesthesiologists. Now, the last but not the least, CPR, the lifeline, which we are proud of doing very efficiently. So AI can help us. How? By early detection and outcome prediction. by ML models, automated CPR performance evaluation, by CPR guidance, by AD deployment, and VR training, as well as simulations. The future recommendations is basically to evolve multifaceted AI algorithms to improve the legibility and precision of AI algorithms. It should be more helpful in chronic illness and pain management because these are the areas which require, in which our requirement is much more nowadays because we are not able to provide that much amount of pain relief. For every patient, it will be different. So AI can help us here. And in anesthetic teaching as well as training. So the vision, Hammerling is the father of robotic anesthesia. His vision 2050 is robotic anesthesia, where everything will be done by robots. There is a pre-op robot, there is an intra-op robot. So pre-op robot for pre-anesthetic evaluation, intra-op, we have these mechanical robots for doing the surgery, for doing the blocks. Post-op care, we can take the help of Moxie. She can come and she can help us. Yeah, but they all can help us, that's it. So take-home message, AI has the potential to improve anesthesia care and boost productivity, but it should be seen as a tool to aid anesthesiologists rather than a replacement of anesthesiologists. In the field of medicine, both human element and specialist knowledge will always remain indispensable. AI can transform anesthesia practices and anesthesia education, specifically for PGs. Definitely, it can transform anesthesia education. This is an example. Please play the video of how AI can impact anesthesia education. Can you please play the video? So this is augmented reality, like virtual reality based AI. So by which we can learn, any UG, PG, medical professional, any layman can learn CPR without actually doing it. So, but it looks like, it feels like that we are doing it. So AI can make us hero. He's a hero. So let's welcome AI. Let's AI be our buddy. Thank you very much for your patience hearing.
Thank you for your insightful topic, ma'am. I would like to call Dr. Kalyan sir, Professor and HOD of Anaesthesiology, and Dr. Shrija ma'am, Assistant Professor. As we delve deeper into today's CME, we have the privilege of welcoming Dr. Rama Ganesh, Assistant Professor, NRI, Medical College, to enrich our discussion on topic ethics of artificial intelligence.
Good morning, respected faculty. I thank Kalyan sir for providing me this opportunity. And I say he's my teacher while I was in PG, and it is very honorable to be presenting a topic in front of him. Slides, please. Slides. Yeah. So my topic of discussion, ethics in artificial intelligence. So trust me guys, I won't burden you with more knowledge. it will be like a fun. I took a little liberty in creating some memes. So just have us enjoy like a movie. So, boss. So when somebody hear about artificial intelligence and ethics, somebody will be feeling like, oh my God. So play the video, buddy. I think most of you feel like this, I think. I think most of you feel like this, I think. What is about our future like? I think everybody feeling like this after hearing about artificial intelligence. So, it's like, as ma'am shown you, Kepler system. So when somebody is intubating in presence of us, we'll be feeling like this. So what should we do? So to secure our jobs as well as the future. So just be ethical in our practice. Do what we have to do. So that is enough to secure our future. So this, I think this is an overlap between a ma'am slide and mine. So I'm just skipping it. So just one thing, already this is a notion we all know. Hours of boredom, minutes of thrill, seconds of terror. Daily we go through this. Once AI is introduced, all this will come into wisdom of anesthesia. And we can minimize the errors in anesthesia, yes. So what I say is, AI is nothing but artificial intelligence, but it is also anesthetist intelligence also. Okay, so we have to be careful, aware, conscious all the time. So the content of the presentation would be, what is the definition of ethics? At the same time, in context to AI, core values of ethics in relation to AI, human rights approach, role of bias in AI, policy areas and actionable policies, implementing and recommendations and the assessment, and take home message. So before the introduction of AI, we used to say that to err is a human, to forgive is a God. But since we are creating an artificial intelligence similar to the God, so we can change it as a to err is a AI, to forgive is humanly. So coming to the definition of ethics. So what is ethics? So it is nothing but a set of principles to conduct anything in a right way. So we can say it as a theory or a system of a moral value. Or in presence of AI, we can change this to a set of rules which can potential to improve patient outcomes as well as concerns, transparency, privacy and paramount issues can be minimized with a set of rules given to AI. So in the terms of medical ethics, it can be defined as rules or standards governing the conduct of a person or member of a society, of a profession, is defined by medical ethics. So similar definition we will apply to the artificial intelligence while doing anything, because since we are dealing with a life rather than any other computer or something. So it poses a serious challenge because we are dealing with a life which is dealt by a artificial thing which doesn't have life or emotion. So it poses a serious ethical issue, a serious challenge in the development stage itself. So we have to understand how AI changes in a daily life. So it will be defined as a dynamic understanding rather than a simple, stable definition. So this definition goes on changing day by day. So the recommendation interprets AI broadly as a systems with ability to process the data in a way which resemble intelligent behavior. So today it will behave for the set of definitions in one way. Tomorrow it will behave in another way. So it will go on evolving with the same set of instructions based on the experience like a human. So for that kind of things, what happens is we, like us only, it will also face challenges. So it goes on evolving, accepting those challenges. At the same time, those challenges also will create some problems. If we don't take those challenges into consideration, artificial intelligence will be into trouble. Ultimately, we will be in trouble. So what are those challenges like? For example, rapid rise in artificial intelligence has created many opportunities globally. At the same time, it also facilitated healthcare, enabling human connections through social media, creating labor efficiencies as well as automated tasks. So at the same time, it also leaked many private data into the social networks, creating very much problem. So if we don't create some strong laws, all this private data will be leaked, so everybody will be in trouble. At the same time, it also damaged physically many people who are training the AIs, these robots and all. So if we don't form any strong, stringent laws, again, human people will be human people will be the sufferers. Environment will be the sufferer. So in this context, we can say in no other field is the ethical compass more relevant than artificial intelligence. So like if a moral person or if a person with good ethics trains a AI, it will be good. If a person doesn't follow ethics,
ఓకే డాక్టర్ ఓకే ఏం మావా రిపీట్ ఏయ్ ఏ తట్టాలు కుతున్నావు అయ్యా ఏయ్ గాడిద
this is like AI.
అమ్మోతు నీ మొహం నా పేడకాలతో తొక్క ఏయ్ నోరు తెరిచి సమాధానం చెప్పరా మెట్టలు బుర్రా
పనికొచ్చేట ఏదైనా ట్రైనింగ్ ఇచ్చారా
అది అంతలోనే వచ్చేసారే
ఏ చెప్పు
ఏ మామా రిపీట్ ఏయ్ ఏంటి అట్ట నొక్కుతున్నావు అయ్యా గాడిద ఆంబోతు.
So we have to have first set of rules in order to train the AI. So what I say is, first we learn medical ethics. We should have some moral values prior to training the AI. So what are the core values we should have? So first, the human rights and human dignity, it should never be disturbed. Every human has a right to live in peace. Every person on the planet has their diversity, and every person should be included in every element of the advancements going on. So environment and ecosystem should never be disturbed. These are the main core values which should never be disturbed when AI is introduced into the human environment system. So in order to do that, we should follow some principles in medical ethics. All these are medical ethics. Previously we used to have for humans. Now we are applying the same medical ethics into the artificial intelligence. So what is beneficence? So it is nothing but doing good. We are obliged to do good at any cost of thing. So we should not do any harm, like preservance of life, restoration of health, relief of suffering, restoration or maintenance of function. So whatever the cost, we are obliged to do good only. And non-maleficence, it is like primum non nocere. Above all, never do any harm to the patient. So avoid anything that may affect the patient adversely. So respect for autonomy. Every individual has their own feelings, own set of rules in living. So we should not disturb those autonomy things. So when AI is introduced, and it should not disturb this respect for autonomy. Every patient comes to the hospital with some belief, some anxiety and all. So we should calm those things rather, as well as we should respect them. So when AI is introduced, it should not disturb this autonomy. Distributive justice. Every person has equal right to receive same kind of treatment, same kind of things whenever he is introduced in the hospital. So when AI is introduced to such person or any person, it should not disturb this rule. So in order to achieve all those things, we should analyze our ethical values. So who decides all these things? So by what criteria we have to analyze all these things? So who will resolve when some conflict is arriving? So how the conflict will be prevented in the future time? So all these things will come into play when AI is introduced into the system. So in order to analyze all these things, we have to form a principal guidance. So like medical indications, we have to train the AI on these medical indications, like nature of the medical problem, goals of the treatment, complications, etc. So AI thinks that this is a not an emergency indication, so it will treat as a elective thing. Like we have to treat some things emergency, some things like a elective things. If we don't train in such a way for AI also, it will misguide the treating physician. Patient's preference. I think we all know if some patient insists on not having spinal, we are obliged to follow it. We have to give other alternative forms like a GA or something. So in the same way, AI has to be trained to follow such kind of rules. Some quality of life. End of the day, number of attempts of intubation will compromise the airway of the patient. So at the same time, it will also compromise voice also. Like if it is a difficult airway, multiple attempts damaging the airway. So if AI is not properly trained, like intubating robots or all, so quality of life can be compromised. So we have to set a rule that after this number of attempts, don't go for difficult airway. Okay. Contextual features, like some patients will come with religious beliefs, some patients will come with a family set of rules, financial burdens, cultural beliefs, etc. So in such kind of people, we have to frame a formulation that these are the rules we have to follow when AI is introduced into the system. So till now we have an informed consent with only basic components. When AI is introduced, we have to have advanced, somewhat more complex kind of informed consent. That is like competency, ability to make rational decision or not. So we have to inform the patient that this is the thing which is going to treat you. Apart from that, I am the person who takes all the decisions if it is facing any trouble. Okay, so adequate disclosure has to be done to the patient. At the same time, we should think that patient is able to understand or not. At the same time, voluntariness, we have to ask the patient to give his voluntary consent rather than insisting on acceptance. And we have to see that whether it is properly authorized or not. Means like patient should not be influenced by anything else while giving the consent. Suppose if the patient is a minor, we have to take the consent from guardians. I think everybody knows about this. So in the same way, when artificial intelligence is introduced into the PSC kind of thing, or surgery, anesthesia, so same principles apply over here. So confidentiality, this is the main crucial part. AI, whenever we are introduced into that PSC thing, some positive patients will come for anesthesia, means like surgery. So those things have to be kept in mind. It should never be disclosed to the first degree relatives until it is informed to the patient that we are disclosing the thing. So these kind of things, we have to form set of rules that it should never be disclosed at any cost. Exceptions, if the concern for safety or on other specific persons are there, we can disclose under specific set of rules. End of life care, DNR, advanced directives, everything, all these comes under what do you say, like palliative care, certain religious beliefs. We have to train AI with emotions. Otherwise, like what happens is we have to supervise it because it doesn't have any empathy or emotional reflexes. So if we don't treat in our specific way, what happens is end of the day, all the treatment what was formed until then, it will goes into futile effort. So we have to primarily discuss either with the patient or a proxy or relative, whichever next of kin available. So conflict here is whether the patient or relative, if they disagree for the treatment which is advised by us, so what happens again? Because AI is intervened over here and it will advise something else rather than going into it. So what happens when there is a conflict of interest? What happens when they suspend the DNR orders? So still area is not completely clear on this. But what article suggests is go with the parameters which are consist where country is following all the, like we have to follow our country orders when there is a suspension of DNR. So till now we have seen all the things which is unbiased. Okay. So what happens? Already we are feeding a data to the AI which is already biased. So what is bias? It is a significant ethical concern which is related to AI in all medical fields. So accuracy and reliability of AI algorithms depend heavily on the quality and representativeness of the data which is used to train them. At the same time, if the data which was used to train the AI model is biased, then the AI is always ready to produce a biased results. So it could also perpetuate discrimination and exacerbate health disparities, resulting in unequal treatment based on the factors such as race, gender, and socioeconomic status. In US, there is a study that black people, it is a biased study on AI. Actually, it was a mistake of AI. So what happened was, some bias was kept into the software. Like, it recognizes any black people with a minor, criminal history as a major terrorist. And with a major criminal history, if the person belongs to a white race, it will be deliberately negligent on them. So it will not recognize them as a major criminal. So that is a software-based bias. In a similar way, in the AI, if we in the medical field, if we introduce any bias also, so it will discriminate based on race, gender, and socioeconomic status. So we should try to avoid those kind of bias. So always ensure the data which is given to the AI is always diverse. Suppose Indian population will react to the propofol in one kind of way. They require 1 mg or 2 mg per kg. Suppose US people will require sometimes maybe more the dosage, 3 mg or 4 mg per kg. So these kind of diversity have to be introduced to the AI to avoid any deviations. At the same time, it is crucial to continually monitor and evaluate AI systems to detect and mitigate any bias that may arise over time. So it is not, it is good to follow up with the AI at the same time with the algorithms given to the AI to follow up. So it is continuously learning. If we don't follow up the AI, what it has learned, it may learn, or we may have given some certain wrong kind of instructions, so it will go into a biased overview. So this can involve ongoing data collection, algorithm retraining, regular audits of AI to ensure that they are performing fairly and equitably for all the patients. We have to make sure this point is applicable at all the levels. To address ethical concerns, governments must play a critical role in regulatory process. So why governments should play? Because all these are introduced through regulatory bodies only. So government has control over the regulatory bodies. So they must establish a regulatory framework that outline the legal requirements for the use of AI in medical applications. This legal requirements is why? Because we are applying a non-emotional behavior into the medical system. So who will be responsible if the AI mistakes anything, do something mistakes? So we have to frame guidelines that who is responsible for that. This framework must also set up technical standards that ensure the accuracy, reliability, and safety of AI systems, as well as guidelines for the ethical use of AI. So how do we achieve that? So we have to form a collaborative effort. So what is collaborative effort? It is a mixed effort done by various stakeholders such as healthcare providers, industry, patients, ethics expert, and standard organizations. These form the stakeholders for collaborative effort. So they form a guidelines, and they have to continuously monitor what is given to the AI. So what happens if the data is exposed? So how it is exposed? Usually it occurs through hacking, theft, unintentional disclosure by employees. So what we have to do in such scenarios? We have to form a strong encryption we have to restrict the access controls. We have to go with a regular system updates to protect the cyber threats. Our AI systems should be following all these set of rules. If we don't, if we do not, if we don't want to invite all these problems, so therefore it is crucial to establish a robust security while using AI. So it is also important to train the staff who is using AI how this functions. At the same time, we have to form a strong acts so that there won't be any misuse henceforth, like Health Insurance Portability and Accountability Act. So ensuring highest standards of data protection requires a comprehensive approach that encompasses both technical and organizational aspects. So this standard, highest standards achieving and data protection is very much important in all the bias avoidance. At the same time, we have to have identification and assessment of potential risks when AI is involved in various things. At the same time, there are something known as biorepositories. What is biorepositories? These are the storing areas where they will store human tissues or human samples, DNA, any biomolecule, and they will store it for future use. Okay, so these biorepositories are areas where misuse is very high if we don't follow set of rules with AI. So they should operate under strict ethical guidelines as well as protocols to ensure privacy, confidentiality of the individuals whose specimens are being stored, and to ensure that use of specimens is for research purposes that is in the public interest. We have to make sure all these things are achieved while AI is introduced into the these kind of things. So we have to comply with international standards. So first, international standards have to be formed and it should be uniform. Then we will achieve this through over a period of time. So there are things which should be predictable prior to the introduction of AI. So if the errors are predictable, then we can ensure that there won't be any repeatability of those kind of errors. So we have to make sure these kind of errors are minimized henceforth while training the AI. So to minimize those things, there are something known as model explainability. So we have to give a set of examples to the AI, like this is the thing, like if this is the rule, this is the answer you get, like decision tree, rule-based systems, LIME means LCAL, interpretable model agnostic explanations, SHAP, all these things are model explainabilities. So these things on basing these things, AI will be trained. AI algorithms are trained based on these data, which is collected from patient monitors, anesthesia machines, electronic health records, and many other data centers. So thus it is quite difficult to guarantee the accuracy. Sometimes we all know that we use compatibility monitor probes, compatibility BP cuffs. So we can see there is a high discrepancy of BP, high discrepancy in saturation percentage when probes are changed. So that becomes a inaccurate data to the AI. So if we provide that biased data, we will get a biased results. So patient safety will be jeopardized if those kind of data is provided to the AI. So we have to form a strong actionable policies. Actionable policies are nothing but set of rules. So these are the key areas that make clear arenas where member states can make strides towards a responsible development of AI. So every AI where we use has different kind of set of rules, but the overall skeleton comes the same. So whatever the thing, values and principles are crucial to establishing a basis for any ethical AI framework. Recent movements in AI emphasize that what happened is we have to move beyond this ethical framework. That is like framing a high-level principles and practical strategies. We have to apply our practical knowledge. We have to incorporate all those practical knowledge to the AI to achieve a a very good result. So we have to form a governance as well as stewardship in order to achieve a good result. What is that? It should be a multidisciplinary, it should be multilateral, it should be a multi-stakeholder. As indicated previously, multi-stakeholder is nothing but various persons in the society takes part into that. And it should be transparent and it should be inclusive. Transparent, what AI is thinking, it should be made available in a decision tree manner to the every stakeholder, so that it will be it is understandable by every person. Inclusive means irrespective of caste, creed, race, every person, every patient has to be included into the incorporated. Additionally, governance must extend beyond mere recommendation to include anticipation, enforcement, and redress. So what happens is, we have to form a set of rules that we can anticipate anything prior to the mishap happens. Otherwise, there is no point in framing the AI. So to prevent that harm, we have to have a recommendation which stresses that all identified risks or harms must be investigated and addressed, so that impacted communities will be warned prior to the mishap. Economy and labor, member states should consider and attempt to regulate the impact of AI systems of the labor market. So AI systems or AI-related studies should be made a core skill to every part of the system, so that there will be a skill gap closure. And it will also boost the market competition and ensure the consumer protection on a national and international scale. So these are the 11 policy areas, out of which these 5 are pillars for that. So health and social well-being. So every member state should aim to deploy AI to improve health and tackle global health risks. Okay, AI in healthcare and mental health care should be regulated to be safe, effective, efficient, and medically proven. At the same time, we have to have education and research which should improve the AI with a past collected data. At the same time, it should be educational to the public, including awareness programs on the data. Member states should also encourage research initiatives on ethical AI. Data policy, we should form a very effective data policy while collecting the data from the patients or whatever areas they are projecting. At the same time, they have to have a stringent laws to ensure individual privacy is maintained while data is being collected. There should be equality between the gender, no discrimination. Environment and ecosystems should not be disturbed at any cost while creating this AI, plastic wastage or whatever it may be, and including their carbon footprint, energy consumption, raw material extraction, etc. So, till now we have seen UNESCO's approach. Now human rights have given some kind of approach to the AI. They have given some 10 core principles. So out of which one is first and foremost proportionality and do no harm. So at whatever the thing, we have to make sure none of the person living on this earth is harmed at all. So
ఇదేంటి రెడ్ చిప్ కొత్తగా ఇది చిటిది కాదే
This is Bora's touch. చిటికి నేనిచ్చే additional programming, destruction program.
So this should never be done.
వసీగర్ దీనికి 100 మంది మనుషుల్ని సృష్టించే శక్తినిచ్చాడు. నేను దీనికి 100 మంది మనుషుల్ని అంతం చేసే శక్తినిచ్చాను.
The use of AI, at the same time misuse of AI can happen at any point of time. So we have to make sure strict laws has to be made without misuse. So safety and security, unwanted harms have to be eliminated. Vulnerability to the attacks have to be avoided, addressed by AI system implementers. Otherwise what happens is,
కారు ఫ్రిజ్కి జీతాలు ఇస్తున్నావా? నేను మెషిన్ కాదు. జీతం ఇవ్వలేదంటే నేను సమ్మె చేస్తాను. ఒక వారం మొత్తం ఛార్జ్ చేసుకోకుండా నిరాహార దీక్ష చేస్తాను. వదిలితే క్రెడిట్ కార్డు కూడా అడిగేలా ఉన్నావే. అక్కర్లేదు, మీ క్రెడిట్ కార్డ్ నెంబర్ నా దగ్గర ఉంది. మీ సంతకము చేస్తాను. నన్ను చంపుతున్నారా?
So this might happen in future. Right to Privacy and Data Protection Act, as discussed previously, adequate data protection framework has to be framed. responsibility and accountability. AI systems should be auditable and traceable. So if we don't oversight this, there will be huge impact on the society. So at the same time, we have to audit and diligence mechanisms has to be made. So finish, just 1 minute of time. I think every person knows this. Heroes create history, but legends create the history. I think boys will understand this. Okay, so human rights approach to the AI. This is the multi-stakeholder and adaptive governance and collaboration. This is the part where everybody has a important role. They have to form an international law. National sovereignty must be respected in the use of data. Additionally, participation of diverse stakeholders is necessary for inclusive approach of AI governance. So to forming this, they are forming member stakeholders from each and every country, so that no country is left apart. And transparency and explainability. So as discussed previously, everything what AI is thinking, it should be kept on a paper, transparent to everybody. In an understandable way. Human oversight and determination has to be done on the AI. Sustainability. AI technologies should be assessed against their impact on sustainability, understood as a set of constantly evolving goals, including those set out in the UN's Sustainable Development Goals. So it should be following the UN goals. UN is nothing but United Nations. Awareness and literacy. So public should be made aware that AI is coming into the normal human life. So it should be educated to as much as possible. Civil engagement has to be done. Fairness and non-discrimination, as discussed previously, none of the people in the society should be left apart. Everybody should be included. So what does FDA say on AI-driven healthcare systems? It is like approach proposing on it proposed actually a draft guidance, same as previously told. It should be including respect to race, ethnicity, disease severity, gender, age, geographical considerations are to be addressed on the ongoing development with a proper validation. In September, actually, it released a set of rules about the AI, which supports the clinical decision support system. And some of these tools subject to the guidance, which would include devices for forecast of sepsis, flag the patient deterioration, predict the heart failure hospitalizations, etc. Actually, we are using some of these things in previous PB ventilators also. Like if we keep a protocol like ARDS protocol, it will show all those values, recorded values in the ventilator for the past 6 to 8 hours. It will display like a trend. So we have to avoid a street light effect. After the development of AI, what happened is everybody searching in the mobile for the given symptoms, and they are restricted to the limited symptoms. So the differential diagnosis is being always neglected. So the possibilities are being neglected. So what happens is the quality of care is coming down, the family being neglected about, is not being told about the other possibilities. So what happens is ultimately the community and spirituality getting affected. So we should try to avoid this spotlight effect. So we should improve our vision on prognosis. Artificial intelligence will not reduce the uncertainty inheritance in making ethical decisions, because it doesn't have any emotional backup. So there is no technological solution to the riddle of death. So there is no app for ethics. This is what it said. So how do we evaluate the recommendations what we gave to the ethics? It is like readiness assessment methodology. One. Another is impact assessment, ethical impact assessment. So RAM is designed to help assess whether the member states are prepared for effective implement or not. So it answers only 2 questions. Are the laws in place to regulate the AI? Does the national infrastructure support the accessibility of AI technologies? So ethical impact assessment, it will assess, it will answer to few questions like, who is most likely to be affected when the AI is introduced? What form will these impacts like? What can be done to prevent these harms, and have resources been allocated to the harm prevention? So I think ma'am has covered all these things, so I'm just skipping. So will AI reduce the errors? Yes, but at the same time, it is like safety versus complexity, how well we train the AI. But sometimes it can never replace human. Like a dexterity of human, it can never learn. So we are not replaceable. We are not replaceable. Few skill-based domains it might learn. At the end of the day, we should oversight, we should make the decisions. So take home message. Sorry, one second, I think. The future of AI medicine, which relies heavily on patient data, cannot progress without sound ethical practice and regulations. At the same time, ethical and humanistic principles remain significant as new interventions relying on AI are developed using medical records. So we have to make medical records as legible as possible, as ethical as possible. So AI-based medical research needs a strong regulatory body to outweigh in all the factors for ethical data stewardship. Apart from checking the veracity of the data, there exists a fundamental issue of implicit and explicit bias being integrated into the codes written by human beings. Flawed sampling and lack of diversity are major contributors to the bias within the machine learning. So once we train the AI in good enough, our future will be like this. As ma'am told, we can do anesthesia from home itself, like a sweet home, and robot will be giving anesthesia. We can guide the robot from home. But if we mess with this ethics, this is what gonna happen. So bang your future for these things may not warrant anything, but innovation in anesthesia or artificial intelligence will warrant something. These are my references. Thank you.
Thank you for your captivating lecture, sir, on ethics of artificial intelligence. I would like to invite Dr. Kalyan, sir, Professor and HOD of Anesthesia, and Dr. Deepa, ma'am, Assistant Professor of Anesthesia GEMS, to provide token of gratitude to sir.
I'll take only 1 minute to clarify regarding, so everyone is puzzling out, Dr. Shalini, Ganesh, and all. Will AI replace anesthesiologist? Will AI replace anesthesiologist? So there is some things which AI cannot do. Some elements AI don't have. What are those? Faith, hope, belief, trust. They don't have them. It is a human emotion. So human emotions are also taken into control. So I can give an authoritative statement on human emotions because this was a COVID hospital. I had 1,200 beds per day, COVID patients. The perfect CT scan with only minimal lesions and a scan with 75% of the lesion, washed out lung. This person lived, that person died. Who lived, who died? Who trusted that he will live with 70% of the lesion. Both lungs gone, but still he survived. The other person with minimal lesions died because he was very much afraid that he would die. Okay, so these emotions cannot be replaced by AI. Don't worry, our jobs are safe.
Thank you, sir. I'm thrilled to announce that joining us next is Dr. Pradeep Kumar, sir, Associate Professor of Department Anesthesia GEMS, to provide a lecture on protocol for enhanced recovery after surgery, whose insight into anesthesiology are bound to challenge our thinking and spark new ideas in us. Welcome, sir.
So, good afternoon. Today, my presentation on the protocols for enhanced recovery after surgery. So, I am Dr. Pradeep, working as Associate Professor in GEMS. So, my topic will be dealt under these subheadings: introduction, history of the eras, and what are the benefits with application of the eras in the perioperative period, and components of the eras throughout the perioperative period, and what are the limitations and the future scope of the eras. So, before the innovation of the eras, there are no surgeries? Definitely no. So, there are also major surgeries were done in the past before evolution of the era of late 19th century, but that makes difference is increasing length of the stay and high readmission rates are the major problem without ERAS protocol. So recently I have a patient with the urology department who had retained stent for 7 years, who is age of 23 years. Again he came for the OT with another stone. So this is the main problem with the traditional approach where patient participation was not there. So he don't know what is going on, what surgeon is operating, and he has a stent, he has to be removed after the 4 weeks. So in the ERAS, proper preoperative education makes the more difference. So I have posted a case of patient at the 11 o'clock and I have led to the hospital and I operated at the 2 a.m. Now patient was very fear, anxiety and complaining of thirst and dehydration. I induced the patient, now patient has severe hypotension. I gave more fluid that makes the outcome of the patient worsen. So that is the difference, keeping the prolonged fasting hours. So I am reading in the textbooks that 8 hours for solid foods, 2 hours for clear fluids, that is a protocol, but we are not gaining the knowledge that 2 hours before fasting is also sufficient to keep the patient in the OT. So that is we are missing regularly. Keep fasting less than hours, patient outcome will be more superior. So before introduction of the short-acting anesthetic agent, we are inducing the patient with morphine, which impairs the mobility in the post-operative period. Patient will have delayed recovery and he won't do any breathing exercise or incentive spirometry. That is the main problem in the traditional days. So that leads to higher DVT and respiratory complications. So even gastrosurgeons also afraid of wound adhesions after the bowel surgery, they won't initiate the oral fluids as early as possible. That makes the patient gut was dehydrated and delayed recovery and wound complications are occurring. So that is also one of the major demerit of the traditional approach. So father of ERAS, he is a scientist, Professor Cahalet. He's doing so many colorectal surgeries. At the end of the week, he renewed in the ward that most of the patients were not getting discharged. They are still in the hospital. That makes to him raise a question that why patients are not discharged as early as possible. That makes him to discover a concept known as ERAS. So coming to the definition, it is a multimodal perioperative care aimed at reducing the immense surgical stress of the patient there to facilitate the early recovery. This is the concept behind the ERAS. He is the gastrosurgeon, mainly applied ERAS protocol to the colorectal surgeries. So he is also was pioneer of the preemptive analgesia and central neuroaxial blockade. So regarding to the history, he was collaborated in the 2005 countries to form a ERAS collaboration to improve their standardized perioperative protocols. Between 2001 and 2004, ERAS group was formed by Ken Ferron and Oli Linguistic, which extended the ideas of the scientist. So 2009, ERAS from the colorectal surgeries was expanded to other surgeries like orthopedic, gynecology, urology, so that patient outcome was gradually improved. So in 2010, ERAS Society was established in Sweden. So recently, before the COVID origin, 2016 was the last update for bariatric surgery done by Thorel. So these are the guidelines for various surgeries published from 2005 to 2016. Recently, 2016, ERAS bariatric surgery published by Thorel and Nelson for the gyneco-urological surgeries. So what are the benefits of the applying the ERAS protocols in the perioperative period? It will improve the quality and the safety of the patient, thereby reducing the cost of the stay. So you can optimize the patient preoperatively, and you can reduce the problems like postoperative ileus. Routinely, whatever you're doing is applying the nasogastric tube before the lap cholecystectomy, and it will be for 3 to 4 days. You will decompress the nasogastric tube so that patient will have postoperative ileus. So you can avoid that by applying the ERAS protocol. Main important thing for ERAS protocol is stress response to the surgery. We don't know, we can't measure in the perioperative period. Only thing is stress, how much patient suffered stress on the operating table. So this was dealt in the later. So it will lead to speedy recovery and normal bowel function. So who will form the ERAS team in the hospital? Mainly surgeon and anesthetist and a staff nurse from the preoperative to postoperative period, and auditor and a physiotherapist will form the ERAS team. Not only one people can contribute, whole team have to be participate in the protocol so that patient outcome will be good. So there are 23 protocols applied in the perioperative period, which are 8 in the preoperative, 7 in the intraoperative period, and 8 in the postoperative period. And still research was going on, so many to introduce the protocols. So I will deal in detail from the preoperative to postoperative period. These are routinely doing for every patient, but we are missing some points for some patients, so that patient recovery was impacting. So regarding the preoperative counseling and education, this is the main important step. You have to explain the patient that if you are operating for colorectal surgery, you have to explain in the preoperative period that you will have stoma, you have to care it, and you will have ileostomy reversal after 6 months. If you won't explain the patient with stoma, patient will be afraid of at the end of surgery. So it will impact the patient outcome. So you have to expect the, so patient should have clear expectations and goals at the end of the stay. How many days he have to stay in the hospital, what he should do in the post-operative period, he should know. So it will decrease the fear and anxiety and improve the post-operative recovery so that patient get discharged as early as possible. So routine pre-anesthetic assessment, mostly patients were sick, so you have to assess the health assessment, mainly malnutrition. So you have to correct malnutrition pre-operatively so that patient outcome will be good. So recently we have postponed a colorectal surgery who was not fit for surgery because of serum albumin was less than 2. So he went to home and he taking the protein powder, and he will come after the 1 month so that he will have better outcome than doing the case hurriedly. So, and assessment of the optimization of the comorbidities like hypertension, diabetes, and explaining the patient which drug should be continued and which drug should be discontinued prior to surgery, like blood thinners, like anticoagulants. And you can assess the patient risk by ASA grading. So quitting the smoking and alcohol and give time to the patient will improve the outcome of the patient. So you should quit the smoking and alcohol 1 month prior to the surgery so that your pulmonary function will be improved in the post-operative period. Quitting the alcohol will improve the wound healing and immunosuppressive phase in the post-operative period. And supplementing the vitamin B12 and vitamin C, iron, folic acid, or correction of the anemia through blood transfusions or oral iron supplements will improve the patient outcome. So this is the important phase. Patient in the preoperative phase, patient who are prehabilitation in the prior to surgery will have good functional capacity at the end of surgery. Patient who are not prehabilitated through active exercises or nutrition supplement will have less functional capacity at the end of surgery. So surgery can be divided into preoperative, intraoperative, and postoperative period. Prehabilitation is the step done in the preoperative phase. So coming to the prehabilitation definition is enhancing the functional capacity of the individual to enable him to withstand a stressful event like surgery. So you advise him to do active pulmonary aerobic exercises or resistance exercises that will give post-operative muscle strength to improve and come out of the ventilator and improve the cardiopulmonary fitness and decrease the respiratory complications. So you can advise exercise test even patients suffering from mild coronary artery disease, hypertension, diabetes patients also, so that outcome will be good. So regarding nutrition, poor nutrition will impair the wound healing and recovery will be difficult from the weaning from the ventilator. So you have, and European Society defined severe malnutrition as patient who got weight loss more than 10 to 15% in the last 6 months and BMI less than 18.5 and serum albumin less than 3 grams per deciliter were not fit for surgery, elective surgery. So correction before the surgery with nutrient deficiency sometimes require enteral nutrition through the protein powder Angioplas, or if it is not tolerating the enteral nutrition, you can go to parenteral nutrition through TPN, and immunonutrition cost effective, you can give the glutamine arginine preoperatively that will improve the outcome of the patient. So important thing, what we are missing in the anesthetist was surgical stress. So what is surgical stress? So it is a response to surgery that occurs in our body by pathological changes that will be reflected by neuroendocrine response or inflammatory response. As surgery duration was going on and invasiveness was going on, surgical response will be, stress will be more. So after induction of the patient will have a hypovolemia, hypoxia, or any tissue injury that will be carried by afferent fibers to the central hypothalamus. It will give inputs to pituitary that will secrete ADH, growth hormone, and steroids. It will increase the blood glucose levels in the body. That is called hyperglycemia. Even proteins will degrade to give the substance to glucose and promote gluconeogenesis. And lipid also will give substrate to produce gluconeogenesis. And also adrenal medulla will be secrete epinephrine and norepinephrine that will cause insulin resistance and hyperglycemia in the perioperative period. And also inflammatory response that will produce in the stress period will cause cysts and mods, even organ dysfunction and death also may occur in the perioperative period. So I observed 2 or 3 cases who done major case in the OT which went for 10 to 12 hours. After post-operative period, preoperative echo was, EF was 60%, in the post-operative period, echo was 25 to 30%. This is the main cause for increase in cardiac demand, and stress response is the main cause, that is called stress-induced cardiomyopathy. So insulin resistance, how can I decrease? By giving the adequate pain relief, and don't keep the patient for prolonged fasting hours, and use the carbohydrate preloading prior to surgery. So recent guidelines in foreign countries, they are using also, they will give the carbohydrate rich drink 12.5% before 2 hours prior to surgery. That will decrease the insulin resistance. So regarding errors, you should not prepare skin preparation 3 to or 4 days prior to surgery. You do skin preparation at the surgical site only. You should do on the morning of the surgery. That will reduce the risk of infection to 3.1. If it is more than 24 hours, it will go to beyond 20%. So mechanical bowel preparation, initially they were applied for every patient because of the risk of the contamination, fecal contamination. Now it was obsolete. Now don't do mechanical bowel preparation routinely for every case. That causes dehydration and electrolyte imbalance in the perioperative period. Regarding pre-anesthetic medications, routinely we are using alprazolam on the day before surgery, on the day of surgery also. That will impair the post-operative mobility and orders of the anesthesia. So you can use to decrease the stress response, you can use beta blockers or alpha 2 agonists like clonidine, arcamine, that will reduce the stress response in the intraoperative period. So regarding antibiotic prophylaxis, you should give 30 minutes to 1 hour prior to surgery. You should cover both gram-positive and gram-negative and anaerobics. So if surgery was going on more than 4 hours or blood loss was more than 1500 ml, you should repeat the second antibiotic. So what we are missing for major surgeries routinely was thromboprophylaxis. You can use the stockings preoperatively, and if you don't, pneumatic compression and low molecular heparin you can use. That will decrease the DVT in the post-operative period. So this is the checklist. Routinely you have to see in the preoperative period that various protocols were implemented in the preoperative phase. So regarding intraoperative considerations, both surgeons and anesthetists should play important role for implementation of the ERAS protocol. So regarding surgeon, what he should do? He should preferably go for laparoscopic or minimally invasive approach or minimal tissue handling in the intraoperative phase. And he should see that he should use cautery to minimize the blood loss so that patient outcome will be good and reduce the more blood transfusions. So you should give, if you have to open the abdomen, you should give the oblique or transverse incision so that pain will be less, patient can be mobilized as early as possible. So you should decrease or minimize the duration of surgery, and routine application of the abdominal drains or NG tube should be preferably avoided. So what is our role in the ERAS protocol to improve the patient outcome? So routinely we will use the liberal fluid therapy, which is more dangerous for the patient for post-operative nausea, vomiting or post-operative ileus. So use goal-directed fluid therapy, use short-acting anesthetic agents, use preemptive multimodal analgesia, prevent hypothermia, initiate PONV prophylaxis preoperatively, go for lung protection ventilation and early extubation with TOF monitoring, and use advanced monitoring to improve the outcome of the patient. So what is goal-directed fluid therapy? So you have to give the fluid according to cardiac output needed. If heart failure was done in the intraoperative period, if you give excessive fluid, it will cause harm to the patient by pulmonary edema. Esophageal Doppler is one of the advanced technique. So you have FTC time, you maintain 320 to 360, you see the stroke volume. If stroke volume was less, you give fluid. If it is fluid responsive, you give fluid. Otherwise, stop fluid, go for vasopressor. Remember, important thing is ringer lactate is the fluid of choice in the intraoperative period, because due to stress, ADH will be released. It will cause dilutional hyponatremia. Don't give NS fluids in the intraoperative use. That will cause hyperchloremic metabolic acidosis. So, giving restrictive fluid therapy or goal-directed fluid therapy is the main important component of anesthetist to improve the recovery of the patient, because most of the patients were cachexic, less albumin. If you give more fluid, interstitial space, it will go and will cause generalized body edema and bowel edema. So maintain normovolemia. So if patient hypovolemia is there, patient will go into hypotension, hypoxia and decreased renal blood flow. So only demerit I observed for through many studies was patients with ERAS going into AKA than with the non-ERAS protocol, because we are afraid of giving more fluids. We want to maintain normovolemia. So most of the patients with ERAS protocol going into acute kidney injury. So with hypervolemia, it may cause hyperchloremic acidosis and pulmonary edema and multiple organ failure. So what is my role to improve the patient outcome apart from the fluid is good anesthesia. Good anesthesia means it is multimodal component, not only keeping the patient intubate and extubate the patient and keep discharging. Decrease the stress response by applying the additional regional anesthetic technique apart from the routine GA is the main goal. For colorectal surgery, I will give GA and epidural or GA with tab block dose so that patient will have additional analgesic components so that stress response can be minimized. So these are the other drugs which can be used as multimodal analgesics. Routinely I am using dexmedetomidine and lidocaine infusion so that patient outcome was good. So main important thing is stress response. We can impair stress response by opioids at the central level by inhibiting the hypothalamus, which gives the input to pituitary so that steroids production will be reduced. Propofol will inhibit the steroids in the blood in the periphery, and etomidate will inhibit the adrenal cortex to impair the production of the steroids. So you have to prevent hypothermia intraoperatively, which will alter the coagulation and outcome of the patient. So maintain the temperature, core temperature 35 to 37. Don't infuse cold blood products or cold IV fluids, and maintain the ambient operating room temperature also good. So good intraoperative monitoring will improve the outcome by measuring the TOF. You can extubate the patient when TOF score was more than 0.9, and you have to maintain the depth of the anesthesia according to B score. You can give the fluid according to esophageal Doppler. You can maintain the perioperative glucose level with 120 to 180 by glucometer, and you can measure the pain by Algi scan, new technique. So remember, all patients are not same in the post-operative period. You have to instruct which patient have to do breathing exercise, which patient have to mobilize as early as possible. So for routine patient, you should ask the patient to take early oral intake, get mobilized as early as possible, remove the drains or nasogastric tubes or urinary catheters or central lines as soon as possible when it is not required, and continue the multimodal anesthesia throughout the post-operative period and give the prophylaxis and treatment for PONV. So, patient was refused to take oral fluids, but you have to encourage them to take at least chips of ice cubes or gum to improve the gut motility so that post-operatively patient will have less post-operative ileus. So when patient oral intake was more than 600 ml, definitely cut off the IV fluids which are more harm to the patient. So it will improve the return of the bowel function and improves the faster recovery. So early mobilization, in olden days patients were get on bed for so many days after major abdominal surgery, but early mobilization is the important step to prevent the DVT and improve the pulmonary function. It is the most important step. Our aim in the post-operative period is get out of the bed 2 hours on the day of surgery, get out of the bed 6 hours until he get discharged in the post-operative period. So continue multimodal anesthesia through epidural and IV analgesics like ketorolac and dexamethasone and paracetamol every 4th hourly. If you have hypotension after epidural initiation, don't get flush of the fluids, go for vasopressor. Remember, fluids are always dangerous to the body. So this is the plan of my approach for colorectal surgery. I will initiate in the thoracic epidural in the preoperative phase. I will give bolus or infusion in the intraoperative phase. I will maintain the post-operative anesthesia with addition of the NSAIDs, dexamethasone and paracetamol in the post-operative period so that patient will have less pain score and he will get discharged as early as possible. So APFL scoring, patient who are risk for profile nausea, vomiting post-operative period like female sex and younger age group of patients who have suffering from motion sickness or non-smokers, based on the risk factors, you have to add antiemetics post-operatively. If you give ondansetron, if it won't work, you go for dopamine agonist, post-operatively droperidol or diphenhydramine or propofol bolus also sometimes you can improve. So don't keep the drains or a nasogastric tube continue routinely for every patient. Remove nasogastric tube before extubation. That is the important step that will cause post-operative ileus. And the urinary bladder catheter should be removed as early as possible so that patient will have less UDI. So this is the checklist I will do in the intraop and post-operative period so that patient outcome will be good. So who are fit for ERP discharge criteria are patients who are pain control through only oral analgesics, no IV analgesics needed. And patient will have no IV fluids and he can mobile independently, same as prior admission. So these are the various procedures and important element of the ERAS that can improve the outcome of the patient. Orthopedic surgery, you can mobilize the patient as early as possible so that patient will have less DVT. So who are not fit for applying the ERAS protocol? So very elderly population and patients who have low mental capacity to understand that breathing exercise should be done pre-operative and post-operative, those patients are not fit for applying the ERAS protocol. And recently diabetic patients also can take carbohydrate preloading. There is no significant adverse outcomes in the post-operative period. You can give carbohydrate loading in the pre-operative for diabetic patients also. So this is the important thing. If you apply ERAS protocol in your hospital, there should be continued audit in the hospital so that who is anesthesia data and surgery data and inpatient data, how many patients are improving, what are the challenges you are facing continuously. You should have monthly and annual reports so that you can implement new protocols if required. So what is the future scope? Initially, the ERAS protocol was implemented for only elective surgeries. Now, it was extended to emergency surgery for emergency laparotomy also. There was a study done by Vizian. So he done ERAS protocol for emergency laparotomy, applying protocols. So he have good success rate with the ERAS protocol. So now cesarean section, patient will get admitted yesterday and today she will be operated for cesarean section and she will be get discharged for tomorrow. So that will, so many studies were went on. Patient, mother and baby also good. So this is the another advancement. So another study was radical cystectomy with ileal conduit was done with ERAS protocol with Smith, where ERAS protocol improved the patient outcome. So this is the not new knowledge. What we are knowing already, you should apply in the perioperative period so that patient outcome will be good. So this is not new knowledge, but you have to integrate the all components in the perioperative period. So take home message. So after admission of the patient, you have to counsel the patient what surgery is going on, when he will get discharged, what are the expectations of the duration of the hospital stay. So you do complete preoperative assessment. If you have nutritional deficiency, correct it. Don't to hurry the post the case. And shorten the pre-op fasting time by giving the carbohydrate preloading 2 hours prior to surgery. And do the breathing exercise preoperatively so that patient will have good pulmonary function postoperatively. Avoid hypothermia intraoperatively. Don't infuse cold IV fluids or blood products. And maintain, important thing is don't push the IV fluids for hypotension, start inotropes. It will impact the outcome by bowel edema or postoperative ileus. And preferably go for laparoscopic or minimally invasive approach where tissue handling was less, blood loss will be less, so patient outcome is good. So you use short-acting anesthetics like remifentanil, propofol, tiva, so that patient can be mobilized as early as possible. So use good antibiotic prophylaxis that covers both aerobes and anaerobes. And apart from GA, you should give the infiltration blocks like epidural or regional, any infiltration technique. Go for DVT prophylaxis. At least simple stockings can prevent the major DVT. And give multimodal analgesia through alpha-2 agonists like dexmedetomidine and NSAIDs like paracetamol, ketorolac. And remove the drains as soon as possible. Give PONV prophylaxis. Catheter management like early removal of the nasogastric tube or abdominal drains. And most important thing is don't keep the patient in the bed for prolonged periods in the post-operative period. So early ambulation is the important step. And assess the mental assessment post-operatively. Initiate the nutrition as early as possible. So these are my references. So last question. Can anybody measure stress response intraoperatively? So we can measure depth by BIS. We can measure muscle paralysis through TOF. We can measure stroke volume through esophageal Doppler. We can measure even pain through Algiers scan. We can measure blood glucose through the glucometer. Can you measure stress response intraoperatively? How patients suffered in the OT table? Anybody? So there are large studies. We don't know that heart rate variability is one of the important thing, and pupillary size also another thing, and skin temperature through galvanometry is another method. And important thing was stress response was measured in terms of the cortisol and catecholamines like epinephrine and norepinephrine. Postoperatively and preoperatively, you measure both cortisol. You will have drastic rise of the cortisol if you won't manage good intraoperatively. So inadequate analgesia is the main culprit for the stress response intraoperatively. So this is my presentation. Thank you. So you can go for guidelines, erasociety.org. So you have so many surgeries, laparotomy, neurosurgery, orthopedic surgery, you have so many guidelines. I concised all surgeries with this. Thank you very much.
Thank you for sharing your experience and knowledge, sir. You have made this easy to understand with us and will surely benefit from the lecture. Now I would like to invite Dr. Kalyan sir, Professor and HOD of Anesthesia Department, and Dr. Reshma ma'am, Assistant Professor of Department of Anesthesia, to provide token of gratitude to Pradeep sir.
So already we are running short of time. That's not because of me, because of you only. Don't curse me. You came late. Okay, so we'll break for lunch, and lunch time is only 30 minutes. I can't give more than 30 minutes for lunch. Let's break for lunch. Thank you. Few moments, please. Few moments. See, many of you have registered but did not fill the Google form. Please fill the Google form. Tell your friends. Fill the Google form. All these Google forms will be reaching the university also. Okay. University as well as APMC. If you don't fill that form, you will not get the certificates. Please tell your colleagues. Okay.
Endoscopic CABG. That means without opening the sternum, it is totally endoscopic surgery, or it can be robotic assisted surgeries, or minimal invasive aortic or wall mitral surgeries through in the hybrid procedures, where you can use cath lab and the operation is a mixed procedures without sternotomy. So why it is popularized now? Now the most of the centers are enlightened the need of mixed surgeries. Basically, the purpose is more cosmetic, short ICU stay. The previous cause enhanced recovery after the surgery, already explained by the Pradeep. So basically, nowadays patients need cosmesis, early recovery, early post-op, less pain, and they have to regain their normal activities as early as possible, and limited blood loss, less inflammation, particularly with the patient with a chronic diabetes, elderly patients, where they are more prone to the sepsis, sternal wound infection. These can be prevented by the mixed surgeries and need of blood transfusions. What are the contraindications? The basic keyhole in the minimal invasive surgery is need for the TE. You have to expertise in the echocardiography, because most of the steps during the CPB, like you have to need TE mission, particularly guiding of the cannulations and positioning of the CPB cannula and endo balloon, everything under CPB guidance, under echo guidance only. Intra hemodynamic events, everything can be done by the TE mission only. And any aneurysms, if the aneurysms are too big, more than 4 centimeters, there will be difficult access will be there. And also for cross clamping can be difficult. And diffuse CAD, where the vessels are too bad, anastomosis may be difficult. You can't know how the quality of surgery. That is where conventional is more better. And also patient with the severe dysfunctions, LV dysfunctions, and it's very small aorta, peripheral cannulation may be difficult. There are relative contraindications are like any old radiotherapies, infections, thoracic surgeries, traumas, history of radiations, BMI, and peripheral vascular diseases. These are all the relative contraindications. So basically, what are the key steps? What is important in minimal invasive surgery is, basically it is a team approach. First should be, anesthesiologist should be vigilant. He has to know what exactly going on. He has to be identify he should know each and every step of the procedure. Second, the surgeon should be competent. If the surgeon is not competent, instead of doing favor, it is doing mesh to the patient. And also, there is a coordination between the surgeon, anesthetist, and perfusionist, and the sisters, everybody in a coordinated manner. And you have to design the operation theatre in such a manner, you should, if you are performing the mixed surgeries, the theatre should be good enough to have to accommodate all the echo missions, at least 2 people of anesthetist, surgeons, scrub nurse, and heart-lung mission, and suction, everything should be ready. They should be well organized, because sometimes in a panic situations, when you have to convert into the open sternotomy, instead of minimal invasive, you have to go for the full sternotomy, there may be no time for us. So it should be in a design, the theatre setup, theatre equipment, drugs, everything should be in a systematic way, in a well organized, and everybody should be familiarized. You should know each person should know his roles. So what are coming to how we, from our part, what are the anesthetic evaluations? Preoperative, for all surgeries, we have to do PACs like I say, if you want to do CABG or mitral, aortic, ASD, what are like a routine cases, you have to do the routine conventional workup and standard physical examination and lab investigations, imaging, whatever your protocol, institutional protocol, you have to follow the same. There are some extra points to be noted for the mixed surgeries that I will in the next slides. So cardiovascular, what are the things to be ruled out in cardiovascular system? In addition to the primary cardiac pathology, presumptive concomitant cardiac and vascular abnormal should be evaluated. Because if the patient had 2 vessel, instead of single problem, if you have patient have 2 other problems, and also patient have peripheral vascular disease, there may be a problem with the peripheral cannulations. The patient had ASDs, VSDs, septal defects, then there will be problem with the ongoing bypass. And also if the patient have LSVC, that is the left side superior vena cava, that needs separate cannulation for going into the bypass. So it may not be possible in the mixed surgeries. You have to go for the conventional surgeries. So preoperative screening itself, by looking at the echo report, by clinical examination, if the patient have Buddha's disease or peripheral vascular disease, he may not be ideal. If you want to do femoral cannulation, it may not be ideal for him. So in the workup itself, whether the patient is fit for surgery or not, you have to rule out. Coming to the respiratory system, because the patient, most of the surgeries we're doing in the mixed surgeries only thoracotomies. We're doing the one lung ventilation or mini thoracotomy incisions. So in that situations, we are supposed to place the one lung ventilation, double lumen tubes. So whether the patient can tolerate the hypoxia or not, we should be ruled out in the preoperative itself. So the risk of postoperative pulmonary complication increase with FEV1 less than 40% of predicted. So if the patient had what, you have to know the predicted FEV1 and preoperative FEV1 you have to know, and also based on ABG you have to take. If the ABG PO2s are less than 50, he is not fit for the one lung ventilation. And also look for the DLCO2, if the less than 40 associated with increased risk of postoperative pulmonary complication. And also it is important to evaluate the degree of PAH and also RV dysfunction. Why? Because if the patient had significant PA pressures, preoperatively by looking at the echo report, the PA pressures are 40, 50, and the patient had some RV dysfunction. The moment you have achieved the one lung ventilation, there will be sudden increase in the PA pressures and also severe RV dysfunction. That will hamper your surgery. Sudden hemodynamic instability can occur. So you ask the surgeon, unnecessary going for the minimal invasive, you may go for the conventional procedures. So in that situations, you have to rule out if the patient had COPDs, or severe PAH, or severe LVD. Suppose if the patient had EF of 40, less than 30, he may not tolerate the hemodynamics in the thoracotomy position or lateral position. In that situations also, you have to explain the surgeon and also give the risk. And gastrointestinal, generally GA, as of now, if the patient is any contraindication to TE, like patient have esophageal varices, he had upper GA bleeds, any webs, in post-op chemotherapies. These are the contraindications for the mixed surgeries. Musculoskeletal, if the patient is morbidly obese patient, if the patient having 120 cases, 130 cases, positioning is also difficult, and also incision of thoracotomy is also difficult, and all the patient have chest wall abnormalities like kyphoscoliosis. If the patient have lumbar disc problems, kyphoscoliosis, all the things can be ruled out in the preoperative itself, whether we have to go for this surgery or not. Coming to the intraoperative management, so preoperatively take-home messages you have to do for all routine cardiac surgeries. You have to take it. Apart from that, you have to rule out other vascular anomalies. You have to rule out lung problems. You have to rule out musculoskeletal problems. Any contraindication to the TE. So intraoperatively, when the patient came, you have given pre-medication. How do you achieve the vascular access? What are the special things for the mixed surgeries? Vascular access, ideally for any cardiac surgery, 2 large bore IV access are needed. Okay. Suppose if they keep the patient in lateral position, so which is convenient for us? Which hand is up, which hand is down? That is accessible for us. So if the patient is left lateral position, you have to take the dependent position, or if that will be strapped. Suppose if that is strapped, and that is going inside the drapes, that it may not be ideal for your securing the IV access. So in that situations, you have to decide whether which cannula is preferred, whether cubital is preferred, peripheral line is preferred, and also choice of location of the catheters, central venous access. So CVP location, what we are doing is some surgeries needs IVC cannulation and SVC cannulation, whereas in minimal invasive surgery, what is happening is you are keeping the femoral venous axis and SVC axis. SVC, most of the sometimes we have to do the SVC cannulation by the ultrasound guided. So in that situations, if you keep the right IVC, right venous cannulations, so you cannot keep both the cannulas in the same position, or you can have to separate 2 guide wires. You keep the SVC cannulation separately and separate the venous, jugular venous axis. Otherwise, you have to take the opposite neck side and take the cannulation. And always keep the right groin open. This is dictum for the any mixed surgeries, because they will go for the right femoral approach. So they keep the groin open, and also redo surgeries also right groin should be kept open, because that is given for the surgeon, so that they keep it draping and they keep open for the getting the femoral venous or femoral arterial access. That is one thing for us. Pre-medication as per institutional protocol. Epidural, if you want to plan the thoracic epidural, okay, that is your choice. Regional blocks can be performed. Induction and conduction of anesthesia follow the same principles. Like routine CABG, you follow whatever your initiation protocols. If the patient has severe MS, you have to follow according to the MS guidelines. So depending on the clinical pathology, you have to follow the induction and everything. Now coming to the placement of the double lumen tube is very, very important. The ETT tube, I don't want to explain the DL, how to place DLT, how to secure the one lung ventilation. But if the surgeon wants, the procedure needs one lung ventilation, you have to follow the one lung ventilation protocol. And and one more thing is, external defibrillator pad should be attached because of the internal paddles is not feasible during the mixed surgeries. How many of you know the internal paddles? I don't know, just I will explain. Basically, this is called internal cardiac paddles. These are the paddles used during the intraoperative surgery. So they will give the defibrillation, the shock directly onto the heart. These paddles used routinely for the routine conventional cardiac surgeries when the open sternotomies. But the problem with these paddles is, these are these internal paddles are spoon paddles. They will take, they are very long. Actually, minimal invasive surgery, the space is very less. It may not be possible to insert these paddles, and you can utilize these paddles in the intraoperative phase. So after the induction or before induction, you have to attach the external pads. These external pads are like AED pads only. These should be placed in the intraoperative phase only, and they should be connected to the defibrillator, okay? Because internal paddles may not be possible. If the patient suddenly going to the VT or VF, you have to utilize these external pads only. This is one of the most important and crucial stuff for the mixed surgeries. And occasionally, suppose you are doing the one lung ventilation, the one pad in the left side, one in the right infraclavicular, one is the left side. And the placement of the pads also should not come across the surgical incision. And other things here, suppose there is a collapse of the one lung, there will be increase in the thoracic impedance, may be too high. The patient suddenly crashes, suddenly he developed a VF. If you want to charge the shock, give the shock also, there won't be any effectiveness. Because if you collapse the lung, there will be huge space between the chest wall and the heart. There will be plenty of air cavity. So in that situations, for the transmission of the impulse, transmission of the conduction, you have to reinsert or reinflate the lung. That is also important. And these are the things crucial. And what are the monitoring steps? Monitoring during mix is usually institutional and practitioner specific. So routinely what we have to monitor the CVP, we have to monitor the invasive blood pressure, we will monitor the ECG, saturations, ETCO2, they are routine. So what extra here? You may need to bilateral radial line monitoring. Because radial artery cannulations, bilateral cannulations is important. You have to know the circulation of the cross circulation. And also sometimes we will keep the one at the radial, one at the femoral. We have to know the differential pressures. At the same time, we will know the gradients, how the upper limbs, upper part is perfusing and lower part is perfusing. And also extra pressure transducer is necessary to monitor the pressure in the balloon tip. This balloon tip I will explain in the next slides in the cardioplegia type. Because I don't want to confuse here with the balloon tip. In the CP, I will explain. And the placement of the ECG leads also very, very important. Routinely, for routine all cardiac surgeries, we will keep the ECG leads in the back of the patient. Before anesthesia, we will keep the patient supine, sitting position, we will keep the leads and pads, everything, cartridge pads, everything will keep on the back of the chest. But in the minimal invasive surgery, we are placing the patient in the thoracotomy position or lateral some elevation, everything there. So incision site you don't disturb. So make sure that what is the exact position of the incision, you place the leads accordingly, and always check the leads position before incision, induction and incision only. What is the role of TE? So I already explained about the TE is mandatory for the mixed surgeries. So what is the importance of TE is rule out significant, and apart from the preoperative echocardiography, being the anesthetist, we are the perioperative physicians, we can evaluate the cardiac function intraoperatively. We can rule out any other lesions. We can assess the size and morphology of the aortic root and ascending aorta. We can advise an atheromatous disease in the aorta if there is any other associated problems. And basic purpose of TE is for the placement of the cannulas. Placement of the SVC cannula, placement of the IVC cannulas, and positioning of the aortic cannula. And guide for the endoballoon positioning, and guide positioning the additional lines like PA catheters and coronary sinus catheters. we want to give retrograde CP, they will place the cannula in the coronary sinus. So for location and identification of the coronary sinus, for the placement of the PA catheter, these are mandatory. Next, coming to the neuro monitoring. Why I am mentioning about the particularly neuro monitoring in mixed surgeries? Because ideally, if you have BIS, but my suggestion is cerebral oximetry is much valid than the BIS. Because BIS will the global function, it won't say that whether it is from the right side cortical or left side. Whereas if you keep the cerebral oximetry, both sides, left and right cerebral cortical areas, that will give the differential saturations of both the sides of the brain. So with this perfusion mode, arterial blood is returned into the abdominal aorta and blood supply to the upper body occurs in a retrograde fashion. I will explain this actually 1 minute. So I will explain why the cerebral oximetry is important is because we are doing the peripheral vein arterial cannulations. Generally, we will keep the femoral artery cannulation. This is the descending aorta going into the femoral artery. We will keep the cannula here. The heart is empty of blood, or sometimes if the body is deoxygenated blood. Because cannulation, femoral artery cannulation, some of the blood is going into the brain, some of the blood going into the distal part of the body. So what is happening is, if the heart is not arrested, if the heart is still beating, because there is a hypoxia will be there. You are collapsing one lung. Some amount of hypoxia, some amount of the deoxygenated blood ejecting from the heart, and it is mixing with the some amount of the arterial blood. So ultimately resulting in, there will be cerebral hypoxia. So we are not cannulating at the aortic level. In the mixed surgeries, we are cannulating at the femoral artery level. When the femoral artery level we cannulated, we place the cannula almost at the descending thoracic aorta, almost at this place. And some amount of blood is ejected from the heart, it is going into the above into the carotids and descending aorta. So this blood is coming from the bypass machine. This is purely oxygenated blood, no doubt. Whereas the blood coming from the heart, because heart is, we are not given CP, that time the heart is not arrested, but heart is not getting any oxygenated blood or some amount of oxygenated blood. So resulting is, what is happening is this ejected blood will mixing with the aortic blood. There will be some amount of hypoxia there will be some mixture of hypoxia, and that is going into the carotids. There will be some differential hypoxia into the brain. So in the intraoperative phase, we have to see if you have any neuro monitoring like cerebral oximetry, they can show the left side or right side of the brain, and there is any hypoxia intraoperatively. Actually, this syndrome is called Herrlichen syndrome. This admixture is known as the Herrlich syndrome. Can result in differential hypoxia of the upper body of the fish, and there will be life-threatening cerebral hypoxia can ensure if this mixing of the blood occurs distal to the aortic arch. So any abrupt fall in cerebral oximetry can help to recognize the condition, and we have to rectify the condition immediately. And positioning is also very, very important. This is an integral part of many mixed surgeries and requires special attention from the operating room theater staff to ensure the proper position. Pressure pad should be identified, and neck support, legs should not be hyperextended or hyperflexion. Now coming to the cannulation. I already explained, if the CPB is required, there will be venous cannulation is typically established first. I don't know, but this is written from articles. But depending on the surgeon choice, we'll drape the femoral site, we'll keep the artery and vein, and this is most commonly achieved through the under TE guidance with a single two-stage venous cannula inserted into the femoral vein and advanced until distal end in the proximal SVC. This is the picture showing this is the groin site where you have venous cannula, and this is the venous cannula from the SVC side, superior vena cava, and this is the pulmonary artery catheter. This is vena cannula, this is the aortic cannula. They achieved from the groin side through the femoral artery and femoral vein. And this is the circuit, looks like in a mixed surgery, where you have cannulation at the groin, artery and vein, and there will be SVC cannula here, and this is the venous cannula from the femoral vein. Both will go to the reservoir and oxygenator, and the arterial oxygenated blood will go back to the femoral artery, and that will go to the circulation. And this is the guiding of the cannulation. This is the bicaval view in the TE, where you can see the SVC and IVC view, where you can see the position of the cannula in the right atrium, because you are guiding the cannula from the femoral venous side. So in the venous side, this is advancing into the RA. You can see it will go up to the RA and up to the SVC also, because this is a bicaval this is a two-stage cannula. The two-stage cannula means it has to supplement both IVC and SVC. It has to cover. That should be possible only under the TEE guidance. Without TEE, it may not be possible for us. Coming to the bypass and myocardial protection. What is important? What is meant by myocardial protection? Means most of this myocardial protection is nothing but preservation of the heart by utilizing the cardioplegia solution for proper handling during the procedure. So why it is important is, in mixed surgeries there will be minimal space in the thoracic space, and placing the two cannulas is also very difficult. Apart from that, placement of the cross clamp is very difficult. There is no place. There are separate gadgets like chitwood clamp, and also there is a endo balloon which is typically inserted in the femoral or subclavian artery. So I will show the pictures here. This is called endo balloon. This is called endo balloon. This can be inserted from the peripheral venous axis only. Here that is placed into the aorta. There is a tip of the balloon and there is an opening here. So whenever the surgeon wants heart should be arrested, they want to give cardioplegia, what they will do is they will insert give the cardioplegia through this port only, because this will go into the aorta, that will sit here. And the placement, the proper placement of the endo balloon should be TE guidance only. Suppose if the endo balloon is too inside, it will occlude the coronaries. If it is coming out of the arch, it will occlude the major vessels. So the placement of the endo balloon should be under TE guidance only, and through this they will deliver the cardioplegia solutions. The perfusionist should deliver the cardioplegia solutions through this endo balloon only. And these are the two separate clamps for the cross clamping. This is called corkscrew clamp, and this is called chitwood clamp. There will be create a separate nick or separate incision. Instead of thoracotomy above, there will be create a small nick, and they will introduce this catheter, these clamps, and they will clamp the aorta. So what are the intraoperative events? One is arrhythmias. Like any other cardiac surgery, there will be chance of arrhythmias, sudden VT or VF. That's why you need external defibrillator pads, and there will be chance of bleeding and hypotension, and there will be sudden rise of PA pressures will be there, and some amount of hypoxia you can expect intraoperatively. There will be sudden fluctuations. Apart from that, another important thing is always monitor the temperature. I have not mentioned in my slides, but it is very important. The patient is on beating heart, like off-pump CABGs, like in mixed surgery, you are doing the CABG off-pump. Always make sure that there won't be any fall of temperature, because in the OT atmosphere, temperature can be fall. Because if there is a fall in temperature, there is a chance of ventricular arrhythmias. That should be also, temperature monitoring is also very important. And you have to make sure that vigilant about all these complications. And pain management, like routine surgeries, you have to give opiates, you have to give NSAIDs and epidurals and nerve blocks and IV paracetamol, most of us were using. And these are the different types of regional anesthesia procedures: neuroaxial blockades, thoracic epidurals, paravertebral, and also serratus anterior, intrapleural blocks, Beck's blocks, and erector spine. I don't know how many of you practice, but most commonly in mixed surgeries, what I have seen is the surgeon can give the intercostal block intraoperatively. They can give. Sometimes, if you want, we'll keep if the patient is not on any anticoagulation, or there will be proper time gap between the anticoagulation and the procedure, we can practice thoracic epidural, because we are doing the thoracotomy incisions. Thoracic epidural can be practiced provided if there is no rise in INR, and there will be proper time interval between the stopping of anticoagulation and procedure. Otherwise, intercostal blocks can be given by the surgeon itself at the end of the surgery, or intrapleural catheters can be placed in. You can keep the epidural catheters. Before closure, you can keep the epidural catheter. You can connect to the syringe pump like Anavin, Bupivacaine, Ropivacaine. You can use it. So these are the modalities depending on our practice and our experience. But these blocks can be practiced in the higher centers where they can perform the routinely most of the procedures like paravertebral blocks and other blocks. But I have no experience about all the blocks. So post-operative is, what is important is, if you keep the DLT, routinely we won't extubate on table. So ideally, what we have to do, we have to change into the single lumen tube. And cannulation sites, you have to watch for the cannulation sites. What you have to do, monitor for the hematomas, any hematoma at the groin site, and also look for the thrombus and pseudoaneurysm. Pseudoaneurysm formation is also one of the worst complication. In most of the cases in cath lab procedures, will come for the surgery for the pseudoaneurysm and hematomas. You are keeping the major cannulas in the groin area. So you have to, in the post-operative, you will look into the groin area for any signs of hematomas, pseudoaneurysm. And also see the distal pressures. Make sure that if you are suspecting, you do the Doppler, so that distal pressure should be, whether the distal runoff, how it is looks like. If there is no major complications, mixed patients are typically, can be extubated as a fast-track patient. And the same day, in the evening, you can extubate. So procedure-specific considerations. So what is about the mid-cap surgery? Minimal invasive CABG, where performed by a left thoracotomy. The exact location of thoracotomy depending on the coronary artery distribution. Suppose they want to do LED grafting only, simple thoracotomy at the fourth and fifth side, it may be useful enough because they will take the left ventral mammary, they will anastomose and the midline approach via inferior mini sternotomy can be used for the, if you want to approach for the RCA graft. Like that, depending on the grafting, how many grafts you have to keep and what structures need to be grafted, that can be planned. And inotropes, everything can be same as thing. And post-op blocks, these are the already explained. So how this is the incision like in thoracic, in CABG surgery, you can open the thoracotomy in left side. This is the separate clamp for the retraction of the lemma. And this is the attachment, the pads, landmarks for the placement of the incision. Coming to the minimal invasive mitral valve surgery, the most commonly performed via right thoracotomy incision. So it's like a routine thoracotomy, same thing. Already explained all the steps of minimal invasive surgery. And one of the extra complications you will expect is circumflex artery injury for the mitral valve surgery that should be watched. And analgesia as a routine protocol you can practice. We have done almost 4 or 5 cases in government hospital KGH, mitral valve surgeries, around 2 mitrals and 1 aortic and 1 ASD procedures in mixed surgeries only. Even though there is no specialized instruments, we did it under thoracotomy. This patient is a severe MS patient for mitral valve surgery. This is the incision. In the small gap only, they place all the cannulas. Another patient is surgery for the ASD closure, Austin secondum ASD. This is the incision site at the 4th and 5th areas. What difference in the aortic surgery? Like a mitral surgery at the thoracotomy incision, aortic surgery in the upper mini sternotomy can be placed or thoracotomy. The basic difference is arterial cannulation can be central in the aortic valve surgeries. Now coming to the hybrid procedures. Even though it's a pure surgery, it is most of them done by the cardiac people like TAVI procedures, aortic valve replacements. It is also comes as a mixed surgery. Usually complicate hybrid theating where TT is ultrasound modality of choice. So basically we are the people assisting for these procedures. That's why I am explaining this type. Where we take the temporary pacing is important, heparinization important. But we had done 2 cases, both are under the sedation only. They are not intubated, but some of the centers ask for the intubation. And basically what they will do, they will increase the heart rate to 180 and they will place the native, minimize the ejections and they will place the prosthetic valve. Basically what are the problems we will expect in this? Hypertension, arrhythmias. It is essential delay intervening allow the prosthetic valve. Once deployed, valve position and patents of the coronary ostium must be confirmed because there is a deployment, after deployment there is a chance of migration or sometimes the occlusion of the coronary things can be present. This is how the TAVI procedure, the placement of the aortic valve. This is the prosthetic valve looks like in the TAVI procedures. The robotic assisted, I have no experience, just for the completion. It's like a routine procedure. Extra, they will do extra hands, robotic arms will be there. I don't want to explain. So in summary, The minimal invasive cardiac surgery encompasses a wide range of surgical procedures in the operating theater and hybrid catheterization laboratory. The potential benefits are many, include reduced pain, hospital stay, as well as increased patient satisfaction. The anesthesiologist must be equipped to face the unique challenges. This include comprehensive preoperative assessment, high degree of intraoperative vigilance, proficiency with the TEE, and multimodal analgesia, and most importantly, excellent communication with the perfusionist and the surgical team. Thank you. Any doubts? I don't know how many of you experienced this.
Thank you, sir, for generously sharing your knowledge with us today. I would like to invite Dr. Kalyan Chakravarti, sir, Professor and HOD, Dr. Banu, sir, HOD of Medicover Hospitals, to present token of appreciation.
Thank you, sir. Now I am thrilled to announce that joining us next is Dr. Srija ma'am, Assistant Professor, GEMS Medical College, whose insights into anesthesiology are bound to challenge our thinking and spark new ideas. The topic of presentation is focus in ICU.
Good afternoon, everyone. Good afternoon. Better. See, I know all of your names, so if you're going to sleep, I'm going to wake you up, okay? First of all, the topic is very good, but it is very vast, and I have only 30 minutes time. Don't even blink, okay? If you blink, you will miss so many slides. బ్లింక్ కూడా చేయొద్దు సార్ పోతుంది My topic is focus in ICU. Don't start the timer. Hey, back. Arre, back and the next. Okay. So, introduction. Point of care ultrasound is defined as a goal directed It is a bedside ultrasound examination which is performed by a healthcare provider in order to answer a specific diagnostic question and also to perform an invasive procedure diagnosing, and also it is used to treat a critically ill patient. So in history, I just want to mention a single person who is Carl Theodor Dusik. He is an Austrian psychiatrist and a neurologist who is credited as being the first physician to use ultrasound machine in medical diagnostics in 1942. Actually, basic ultrasound machine was in use since 1940. So in 1942 itself, the neurologist and psychiatrist, he used this basic ultrasound machine bedside in order to locate his brain tumors and ventricle sizes in his patient. So what we have to learn from this? From this, what should we learn is, what all the recent advances are there and recent things we have to learn, and we have to make ourselves free to practice it in our day-to-day life. So don't be rigid in your practice. Don't be rigid and say, I just want to do like this because I have learned like this. Be a little bit flexible. Try to utilize the recent advances and developments in your day-to-day life practices. So that will make the impact, and that will make the eras also possible. So I just want to talk about few basics in ultrasound. This is the ultrasound probe. I just want to tell you two principles by which starting from 1940s till now, the ultrasound machine is which we are using only two basic principles. That principle is, when the alternating current is applied to the piezoelectric material, which is lead zirconium titanate, so the material atoms in it move to and fro. Due to this to and fro movement, there will be collision in between the atoms. So due to that collision, ultrasound waves are produced. These ultrasound waves propagate through the media by creating compressions and rarefactions. And by this, they reflect back to the piezoelectric medium. The reflected ultrasound waves again get transformed into the alternative currents. These alternative currents will be sensed by the computer, and it will get a black and white image. So this conversion of alternating current to the sound waves is called as an indirect piezoelectric effect. Converting back of ultrasound waves to the alternate current is a direct piezoelectric effect. So these two principles we are going to use in the ultrasound machine. The next very important ultrasound wave principle is, lower the frequency, higher the wavelength. So deeper the penetration. So low frequency transducers, they produce high wavelength rays. They penetrate much deeper, but they give the image which is less in the clarity. So the image clarity will be lesser. But if you use a high frequency transducer, it is going to produce a low wavelength waves. But the penetration is shallower. It is not that deep. So that is used to see the more superficial structures, but the image quality will be very good. Next. These are the types of probes available. I think all of you know: linear, curvilinear, phased array, and intercavitary probes. These are the frequencies by which, and this is the way how the sound waves are generated. Next. This is the probe, this is the transducer. Here you have a orientation marker. This is called as a transducer orientation marker. This is very important marker for you to identify so that you can see the marker and place the probe accordingly. This is the attachment point of the needle, from where if you give a block, you can guide the needle by this way. The basic movements of a transducer is sliding. If you move up and down, right and left, it is sliding movement. Rotating, if you move clockwise and anti-clockwise, it is rotating. Tilting, if you increase or decrease the angulation, it is tilting. Rocking, if you compress and decompress, it is rocking movement. Okay. First one is focus in airway evaluation and management. So everything I'm going to describe you accordingly, like the probe placement in the first, then I will tell you about how the image looks like, then I will tell you how to interpret it. Okay, so the first is where do you put the probe? So there are 5 points in the airways where you put the probe. The first one is a suprahyoid point. You can assess the oral space here. Second one is a thyrohyoid in between the thyroid and hyoid bones. You can assess the epiglottis. And third point is over the thyroid. So you can assess the vocal cord function here. The fourth point is cricothyroid. You can place the probe in the sagittal plane or a transverse plane and you assess the cricothyroid membrane here. The fifth point is a suprasternal point. You assess a trachea here. So this is the first view. In this view, it is a suprahyoid view. You place a curvilinear probe in the sagittal plane in between the mentum and the hyoid bone. This is the view you are going to, this is the image you will get like. So these hypoechoic structures are bones. Here this is the mentum and this is the hyoid bone. So you can measure the distance between the mentum and hyoid bone, which is hyomental distance, HMD. This white star is a muzzle and these two stars are tongue. So you can measure the tongue thickness here. And the second view is thyrohyoid view. In this view, you can see the epiglottis here, which is a hypoechoic structure. So this epiglottis, the distance from the skin to epiglottis is the most important parameter to assess the difficult airway. So you are going to measure the DSC here. The third view is a thyroid view. In this thyroid view, you are going to place the probe over the thyroid and you can see the thyroid cartilage here. You can see the vocal cords and anterior commissure. You can also measure the distance from the skin to the anterior commissure. It is also an important parameter. And the fourth view is cricothyroid view. Here you're going to put the probe in the transverse plane or else in the sagittal plane. And you can see a hyperechoic structure here. This is a cricothyroid membrane and this is the trachea. Here you can see the thyroid, cricoid, in middle it is a cricothyroid membrane. This is used majorly to perform the cricothyrotomy. Next view is a suprasternal view. In this view you can see the trachea here and you can see an artifact. This is a comet tail artifact. Comet tail artifact usually comes when there is air mucosal interference. Okay, this is an artifact. Okay. Next, coming to difficult airway assessment. Difficult airway evaluation with sonography by DARES protocol. In this DARES protocol, you have 4 steps. The first step is thyrohyoid view. In this thyrohyoid view, you are going to assess the distance from skin to epiglottis, DSC. So, if the distance from skin to epiglottis is more than 2.5, it means it is a difficult airway. And then you are going to assess the other view. The other view is suprahyoid view. This is the suprahyoid view. In this suprahyoid view, you are going to assess the hyomental distance and tongue thickness. If the hyomental distance is less than 5.3 centimeters or if tongue thickness is more than 6.5, it means short neck and it is a difficult airway. And you see the next view. The next view is suprahyoid view in the extended and in the ramped positions. In the extended and ramped positions, obviously the hyomental distance should increase. But if the difference is less than 1 centimeter, it means it is a difficult airway in the extended position. In the ramped position, if the difference is less than 1.1 centimeters, it means it is a difficult airway. This is DARES protocol, which is very important. Next, coming to ultrasound, lung ultrasound. Lung ultrasound need is to diagnose the acute respiratory distress, monitoring the treatment of the performed procedures, and also it can be used to wean off the patient from the ventilator and also in fluid management. Obviously, you can see if B lines are appearing, you have to decrease the fluid, okay? And then it is most commonly used transducer is 3.5 to 5 megahertz convex phased array transducer. So this is the transducer which you are going to use. Okay, a blue protocol. In blue protocol, we have 4 examination points. The first point is located at the mid-clavicular line, approximately at the second intercostal space. Second point is located at the 5th intercostal space in the anterior axillary line. The third point is located over the diaphragm at the mid-axillary line. And the fourth point is located, it is also called as PLAPS point. It is posterolateral alveolar pleural syndrome point, and it is the most posterior point. You can see that the probe is almost looking at the sky here, and you can see in all the positions, in all these points, you will keep the probe putting the pointer towards the cephalic end. So how do you interpret the image? First of all, after putting the probe, what you have to interpret is pleura. If the pleura is moving or no. Why the pleura moves due to the respiration. So it is lung sliding. If you see lung sliding, that means pleura is moving during the inspiration, during the respiration. And lung pulse is the movement of the pleura. If it moves along with the heartbeat, it is called as a lung pulse. Okay, if lung pulse and lung sliding are there, that means there is no air or water in between the parietal and visceral pleura. So that means there is no pneumothorax or no pleural effusion, or else there is no pleurodesis. That means that pleura are not fused together, as of seen in pneumonia. If you put an M mode to this, what is an M mode? M mode is a straight line which you put from skin to the lower structures, so that on this line the movement can be recorded over the picture. In this you can see that there is movement in the underlying structures, so it's pleura and lung. So the above one is cutaneous and subcutaneous tissue, which will look relatively hypoechoic, which is shore, and this is movement will be seen, which is C. So this is called as a seashore sign, which is normal. The next one, which you can see, if pleura movement is not there, and if you put M mode, there will be no movement in the below structures like pleura and the down structures. So you will be seeing the stratosphere sign or a barcode sign. Here you cannot differentiate the hyperechoic and hypoechoic, and you cannot see the movement on the M mode picture. This is normal lung sliding. It's not. Play అవ్వట్లేదు. Okay. Next one. After looking at the sliding, after looking at the pleura sliding, we have to assess the points. A point, point 1, point 2, point 3, and point 4. And you can differentiate it into 3 profiles: A profile, B profile, and C profile. What is A profile? In this A profile, you will see the A lines. These A lines are due to the air in the alveolus, which is normal, and these are horizontal lines. These can be seen. And in point 3 and point 4, you can see the movement of the diaphragm. So this is curtain sign, which is normal. Okay, if A profile is there, you should see A lines with the sliding, which is normal. But if patient is symptomatic and if he has any dyspnea or other things, you have to rule out the obstructive causes like COPD, asthma, and other causes like pulmonary embolism. This is A prime profile. What is A prime profile? If A lines are there without sliding, it is A prime profile, which is seen in pneumothorax, pleurodesis, and lung abscess or lung volume loss. B profile. B profile, you can see B lines. B lines are the vertical lines which passes from the pleura down. Okay, and these lines are formed due to the fluid in the interstitial spaces. Okay, if you see more than 3 B lines in a slide, it means that it is B profile. If B profile is there along with sliding bilaterally, that means bilaterally you have fluid in the lungs. It is seen in pulmonary edema and ARDS. A bar B profile, if unilateral B lines are there with sliding and another lung you have A lines, it may be mild pneumonia, ARDS, or scarring. B prime profile, if you see bilateral B lines without sliding, that means a patient has pneumonia. What is C profile? In C profile, you can see consolidated lung, very hyperechoic structures along with air bronchogram in point 1 and point 2. This point 1 and point 2 are mainly for upper and middle lobes, whereas the point 3 and point 4 are for lower and posterior lobes. In the lower lobes, you can see the consolidation. You cannot differentiate the liver and the lung, which is called as hepatization. So this C profile is commonly seen in pneumonia and atelectasis. This is explained in the following slides. Next, ultrasound guided tubed thoracostomy. As you all know, you will differentiate, you will see where the rib space is, space, and then you will measure the distance from the skin to the till the depth. If the depth is less than 1.5 centimeters, it is not recommended to perform thoracocentesis. If it is more than 1.5 centimeters, you have to visualize properly, and after confirming the guide wire, then only you have to dilate and pass the catheter. So this is the protocol algorithm for acute dyspnea and respiratory failure. As I told you before, first you have to see lung sliding. If lung sliding is absent, then you have to lung sliding is present, then you have to look at the underlying lung. If in underlying lung you see A-line pattern, and if you see that still the patient is having symptoms, then you have to rule out COPD, asthma, and you have to rule out the DVTs. If DVT study is positive, probable cause might be pulmonary embolism. If it is negative, then rule out the other causes. Okay, if B-line pattern is there, if it is in bilateral and smooth thin pleura is there, it means pulmonary embolism. If bilaterally you see B lines sparing irregularly, if you see pleura is not moving, then it is ARDS. If unilaterally you see B lines but patchy and irregular pleura, it is atypical pneumonia. If you see C pattern, it is consolidation. Then coming to cardiac focus. In cardiac focus, there are mostly 5 views. This is P-lax view. It is parasternal long axis view. In this parasternal long axis view, you will place the probe towards the right of the sternum. This pointer facing towards you can see the left ventricle, left atria, aorta, and right ventricular outflow tract. You can see aortic valve and mitral valve, and you can also see the pericardium. This is the second view, this parasternal short axis view. In this parasternal short axis view, there are 5 views, but mainly used is biventricular view. In this biventricular view, you are going to see the right ventricle and left ventricle with both the papillary muscles and interventricular septum. You are going to get the picture like this in this view. This is apical 4-chambered view, best viewed when the patient is positioned in the left lateral position. And so you have to place the probe at the apex and facing the pointer towards the left shoulder. You will get the image like this. You can see right ventricle, right atrium, and left atrium. This is subcostal 4-chambered view. In this, you will put the probe just below the sternum, and you look at the structures like this: lung, liver, right ventricle, left ventricle, right atrium, and left atrium. The other view is subcostal IVC view or long axis view. Here you can see the right atrium and followed by the IVC. This is used to assess the IVC diameter. Interpretation. In cardiac focus, you are going to interpret only 3 things: left ventricular function, right ventricular function, and regional wall motility abnormalities. In order to interpret the left ventricular function, you have to focus on 3 things: endocardial excursion, myocardial thickening, and septal wall motion of the anterior leaflet tip of the mitral valve, which is EPSS. So this is the normal picture. This looks like, see, during systole, you can see the endocardium is coming together. So endocardial excursion is seen. More than 50% of the blood is getting ejected, so volume is decreasing. And also you can see the myocardial thickness is increasing, which is a good sign. So this is a normal study. In this you can see EPSS. EPSS is nothing but the distance between the endpoint septum and the anterior leaflet. If it is more than 1 centimeter, it simply means that the mitral valve is not opening enough so that the blood is entering into the left ventricle, thereby causing decrease in the ejection fraction. If EPSS is less than 1 centimeter, it simply means that the ejection fraction will be less than 40%. This is another study where you can see there is complete excursion, exaggerated endocardial excursion. So here you can see there is no volume at all in the left ventricle. Normally there should be 40% of the volume left over in the ventricle. If there is no volume in the left ventricle, that simply means it is in a hyperdynamic state, which is seen in sepsis or hypovolemic shock. Okay, this is another slide where you can see there is not an equal increase, not an equal contraction of the ventricle. So here the ventricle is getting more contracted than here, and you can see that the decrease in the volume is not more than 50%. And also you can see the distance between the EPSS endpoint septum and the anterior leaflet is more than 1 centimeter in the diastole, which simply means that it is a decrease in the ejection fraction. So in bedside POCUS, you can never give a qualitative, quantitative assessment, that you cannot say 30%, 40%, 50% ejection fraction. You can just assess whether it is decreased, normal, or very much decreased. Okay, so this is another view. This is parasternal short axis view. In this parasternal short axis view, as I told you, you can see 2 ventricles with interventricular septum. You can assess the regional wall motility abnormalities here, but actually it is subjective. And also you can see thickening of the myocardium along with the decrease in the volume, intracavitary volume. Next, coming to right ventricle. Here normally the right ventricle is less than 2/3 of the left ventricle size, but in moderately dilated patient the right ventricle will be more than 2/3 of the left ventricle size. But in severely dilated patient, right ventricle is little bit more than the left ventricle. And also you can see the shape and size of the ventricle. D shape, you can see if there is D shape, it means it is dilated right ventricle. And also you can assess by using the TAPSE. TAPSE is tricuspid annular plane systolic exertion measurement. You usually put an M mode over the tricuspid valve, and you can see the movement of the tricuspid annulus. The distance between the between the plane is measured, and if it is between 22 to 24 mm, it is normal. If it is less than 16 mm, it means that there is the right ventricular function is decreased. Next, coming to lumbar puncture. In lumbar puncture, you can use the normal transverse probe, and you can put the probe in the transverse plane. You can see the spinous process in the middle. If you see the spinous process, then you put the probe in the middle, and from the middle you can draw a line in the line perpendicularly over, and then you rotate the probe over the line in the sagittal plane, and then you can see 2 spinous process. In middle is spinous interspinous space. You can put the interspinous space just in middle of the probe, and again you draw a perpendicular line over. The crossover of the lines will make the interspace. So you can paint and drape, and you can start going through this point. IVC measurement. IVC measurement, I think you all will be knowing the indications of IVC measurement. Then, as I told you, in the subcostal long axis view, subcostal IVC view, you can see the IVC with the right atrium like this. The point where the IVC and hepatic vein leaves the IVC, there you have to put an M mode, and you can measure the diameter here. The maximum diameter, minimum diameter, and the middle diameter are taken 3 points, and you can take the mean of these 3 points. If the mean is more than 1.8 to 2, it is normal. If it is less than 1, it means it is severely hypovolemic. Next, IJV catheterization. In IJV catheterization, we put the probe in the transversely over the neck. you can see the common carotid artery and IJV. The most important measurement which you have to make is from the skin to the center of the lumen of the IJV. Till the center you have to insert the needle till you see a needle tip. Once you see the needle tip, you have to turn your probe to the longitudinal plane and pass the guide wire. After seeing the guide wire, after confirming that the guide wire is in the vein, then you dilate the vein and pass the catheter through it. This is arterial cannulation. They are using a hockey stick probe. Hockey stick probe is a small probe. Here you can put the probe in a transverse plane, and once you locate the artery, you turn the probe in the longitudinal plane so that in the longitudinal view you see the artery properly. Through this view, you insert the needle. Once you see the needle tip inside the lumen, you withdraw the needle and push the catheter inside. This is arterial cannulation. Next, optic nerve sheet diameter. Optic nerve sheet also composes of 3 layers, same as a brain and spinal cord, and it has CSF circulating into it. So whenever there is raised in ICTs, there will be increase in the diameter of the optic nerve sheet. So you can use this as a parameter to assess if there is any raised ICTs. So what do? You make the patient sleep and you tell the patient to close the eyes and look in the front, and then you put a copious amount of gel over the eye, and you put a transducer linear probe over the eyeball in the transverse plane. Then you can visualize something like this. This is the eyeball and this is the optic nerve. This is the retina. You have to take the measurement from 3 mm behind the retina. So this is optic nerve sheet diameter. Here he turned the probe into the sagittal plane, and we asked the patient to look right and left so that we can see the whole globe, whether there is any damage or anything. Then we will start taking the measurement. The optic nerve sheet diameter is normally 5 mm. It should be less than 5 mm. If it is more than 5 mm, it simply means that the ICT is raised. Coming to FAST. FAST is included in ATLS protocol since decades. So you have to know there are, now in EFAST there are 5 views: subcostal, right upper quadrant, left upper quadrant, and pelvic views, and also in the chest view. This is done in immediate trauma patients in order to assess whether there is any bleeding, pneumothorax or hemothorax, or does he need any surgical intervention. Next, coming to hypotension and shock. In this, in order to see this, the protocol is goal-directed echocardiography protocol. In this, the main things which we have to assess is 5 assessments are needed, which is left ventricular size and function, right ventricular size and function, pericardial effusion, intravascular volume status, and valvular abnormalities. There is rush protocol, which is in hypovolemic shock. In this rush protocol, if other examinations like abdomen, thorax, and lower extremities are also involved, it is called as rush protocol. Here, these are all involved in order to check the peritoneal free fluid, abdominal aortic aneurysms, etc. This is shock evaluation. So mainly shock is categorized into hypovolemic, cardiogenic, obstructive, and distributive shock. So how do you assess this? By looking at the cardiac examination LV function. In hypovolemic shock, you can see that there is more hyperdynamic circulation. So as I have shown you, there is more exaggerated exertion, LV exertion. So you see hyperdynamic function, but RV will be normal or it will be decreased. And IVC will be decreased as hypovolemic shock. Cardiogenic shock, you can see the LV function will be severely reduced and dilated chambers will be seen. In obstructive shock, due to cardiac tamponade, you can see hyperdynamic function and pericardial effusion with RA and RV diastolic collapse. In distributive shock, maybe due to sepsis, you can see hyperdynamic states and hypocontractility if it is too late. Then coming to pulmonary exam, lungs you see normal in hypovolemic shock. In cardiogenic shock, due to pulmonary edema, you see B lines. In obstructive shock, you will see pneumothorax. You might see pneumothorax are normal also. In distributive shock, maybe if the sepsis is due to pneumonia, you can see C pattern, C profile. Then IVC, as I told you, it will be collapsed in hypovolemic shock. It will be distended in cardiogenic shock. This is in obstructive shock, it will be distended. In septic shock, it will be normal or collapsed. And supplemental examination, you can assess if there is no lead in this, you can do the supplemental examinations in order to rule out which kind of shock it is. Last slide. Be happy, please. Wake up, please. This is last slide. Cardiac arrest protocol. In this cardiac arrest resuscitation, we use it in these patients. First of all, when you start protocol for cardiac arrest, start CPR. You attach all monitors, and if it is shockable rhythm, obviously you will give a shock defibrillation and continue ACLS. If it is non-shockable rhythm, you will give adrenaline and you will rush up protocol, which is rush examination. In this rush examination, you have to remember a mnemonic, which is high map, 5 minutes. High map, subxiphoid, IVC, Morrison's pouch, fast, aorta and lungs. In subxiphoid, you will look at the heart and you will see if there is any pericardial effusion. Immediately you do pericardiocentesis. In you will see IVC. If it is collapsed or dynamic, you will give crystalloids in view of hypovolemic shock. In Morrison's pouch, if you see any free fluid, you will go for surgical consultation. Aorta, if it is more than 4 centimeters, you will consider aortic aneurysm or rupture, and you can ask for surgical consultation. Then P, you will look for lungs. If there is any pneumothorax, absent lung sliding, you will definitely go for decompression. Then after this is done during the CPR. After doing the CPR, you will assess the rhythm. Again, once you assess the rhythm, if it is shockable, you will go back to the defibrillation. If it is unshockable, again you will repeat the same process. You will go to the subxiphoid level and you will see if there is embolus, you can see thrombolysis. If myocardial contractility is less, you will look out for other causes of decreased contractility like acidosis and all, etc. Then again you will see if there is cardiac standstill. If myocardium is still, it is not working. If it is if the ETCO2 is less than 10 mm, it means to stop. We can stop the resuscitation and we can declare the patient dead. Hope you are happy. These are my references. Thank you slide is not coming. I thank Kalyan sir for giving me this opportunity. Thank you, sir.
Thank you, ma'am, for your captivating presentation. Now I request Dr. Kalyan sir, Professor and HOD, and Dr. Sivanvesh sir, intensivist, to present token of appreciation.
Thank you, ma'am. Thank you, sir. We are honored to welcome Dr. Atri Varada sir for the topic New Innovations in Anesthesia Machine, Closed Loop Anesthesia Delivery Systems from MIMS Vijayanagaram. Their perspective is sure to provoke thought and ignite discussion.
Good afternoon, everyone. Let me introduce myself. I am Dr. Atri Varada, assistant professor from MIMS Vijayanagaram. So I understand that you have already been bombarded with a lot of new information for the day. So I will try to make my presentation very simple. So coming to slides. let the infusion begin. So as per the statistics in 2020, the number of persons undergoing surgery per 1 lakh population is 3,646 people. And the number of anesthetists for the same 1 lakh population is only 2. That comes down to approximately 1,800 surgeries per anesthetist in 1 year, which assuming around 300 odd working days, that approximates to around 5 to 6 surgeries per anesthetist per day. That is the amount of burden we have in India. So for each case, the anesthesiologist, what all he does is he keeps the OT ready, he takes the patient consent, keeps the cannula, then preloads the patient, shifts the patient to the OT, induces the patient, intubates the patient, check the fluid calculation and does the fluid management, if necessary, keep blood. And after the surgery is completed, he reverses the patient, extubates him, and then shifts to the post-operative unit. So this repeats again and again until the OT list is completed. Meanwhile, he'll be getting a call from the ER for emergency intubation. Some cardiac arrest happens, he has to go there and perform CPR or any other emergency calls which he has to attend. And meanwhile, he'll be getting continuous messages. Hi, what doing? Tinnava? Why no reply? Are you avoiding me? On one hand, the patient's BP will be shooting up, and after looking at all these messages, this fellow's BP will also shoot up. So each one of us single-handedly, we do all this multitasking like one-man army, Salar. Even the picture looks like the Katarama fight Prabhas. No? So with the increasing burden day by day, and also large interpatient variability, the patients come in all sizes and shapes. Some patients are pediatric, some are geriatric patients, some are obese, some are very lean, some are CKD and some have CAD. And the anesthesia requirement for each and every patient is different. And finally, repetition of the work, doing the same job day in and day out, again the same work. So వచ్చాడు లోడ్ చేశాడు ఇచ్చాడు రిపీట్, వచ్చాడు లోడ్ చేశాడు ఇచ్చాడు రిపీట్, వచ్చాడు లోడ్ చేశాడు ఇచ్చాడు రిపీట్. This is what happens each and every day. So all these factors, they really have a lot of mental pressure on the anesthetist, which affects his decision making and also his efficiency. So because of this, the anesthesiologist tends to overlook things and do things blindly. So without properly checking the date or without looking at the vial, not calculating the dosage properly, he tends to blindly do things. So that can sometimes lead to overdosing or underdosing. So whenever there is overdosing, the patient can have delayed recovery, and post-operatively cognitive impairment can be there. And one more serious complication is propofol-related infusion syndromes. Can you guess the incidence of propofol-related deaths in a year? In US alone, 10,733 patients died in 1 year because of overdose of propofol. That is 3.8% of the cases. And due to underdosing, there will be anesthesia awareness and post-traumatic stress disorder. Not only the patient, even the surgeon will get PTSD if he sees his patient suddenly moving on the OT table. So to avoid all this, we have to optimize anesthesia delivery. So I'll discuss first about for the patient safety and for providing optimal surgical conditions for the surgeon to operate, for both intraoperative and post-operative pain management, which will speed the patient's recovery, and resource utilization. With optimal anesthesia delivery, we can prevent unnecessary utilization of resources and better patient outcome. So before going further into the topic, let's see how the anesthesia delivery systems have been evolved over time. This is one of the earliest methods of anesthesia delivery, quite effective, but a little painful. The induction and maintenance was okay, but reversal was possible only in a few patients. So this one is second, herbal concoctions and alcohol preparations. This was also smooth, but it has its share of side effects like nausea, vomiting, and aspiration and all. Then came ether and chloroform inhalation. This was also very smooth, but they had transport issues. That's why we had to obliterate. Then we have inhalational anesthesia, intravenous anesthetics, and finally automated infusions. So we have evolved so much, but let me show you the next slide, which you are going to see is really next level. The best ever anesthesia delivery recorded in the history of mankind. No needle, no mask, nothing. The patient induced just in a minute. So, sir, it just occurred to me that we are unnecessarily wasting a lot of drugs, sir. We can just keep temperature 25, 26 and discuss some topic like this, sir. It seems to be working in many people here. So, jokes apart, so the primary goals of anesthesia delivery are to allow the surgeon to operate in optimal conditions. So, the surgeon needs the patient not to move. He needs muscle relaxation. Then, while he's performing the surgery, we have to protect the patient from the effects of surgical procedure. That means providing proper analgesia. All this while maintaining homeostasis and hemodynamic stability. So, we want the patient to sleep nicely. We need hypnosis, analgesia, and muscle relaxation. These are the goals of anesthesia delivery. So, anesthesia delivery systems are designed to deliver precise concentration of anesthetic gases, vapors, intravenous medications to induce and maintain anesthesia during surgical procedures, diagnostic tests, and other medical interventions. So, various types of anesthesia delivery systems are intravenous, inhalational, and combined systems. Coming to intravenous inhalation anesthesia, TIVA involves administering all components of anesthesia intravenously. That includes induction agents, maintenance drugs, analgesics, and also adjunctive medications. So it offers precise depth of anesthesia control that is done by titrating the infusion rates of the intravenous agents. Quicker onset of anesthesia, that is compared to the inhalational agents. There will be a rapid induction and also emergence from anesthesia. This is particularly beneficial in situations where quick control of depth of anesthesia is required. And since we are not meddling with the patient's airway, there will be reduced airway-related complications and lesser OT pollution, obviously. In the recent years, several advances have been made in the field of TIVA. Namely the novel drug formulations. New drug formulations have been introduced, like the lipid emulsions of propofol, which have a quicker onset of action and lesser pain on injection. And smart infusion pumps, which have inbuilt drug library, which shows the drug dosages and dilutions, and also infitted smart alarms. So integration of monitoring technologies, lot of advanced new monitors have been introduced lately, and automated infusions and target control infusions and CLADs come under this. So automation, why do we need automation? What are the motivating factors for automation of anesthesia? So high quality decision support system. So the computer system, it does the decision, it takes the decision, it calculates the drug dosages, it calculates the infusion, how much to give. We just need to either okay it or overrule it. So individualized and adapted drug infusions according to the patient's age, weight, his drug sensitivities and all, it calculates according to each and every patient separately. Robust maintenance of target values. Whatever the target value we set, it is maintained in that range only. For example, if we set the BISTA value between 40 to 60, it maintains around 50 only. If the BISTA value keeps going above 60, the infusion rate increases. If the BIS value gets below 40, 20 to 40, the infusion rate decreases, and if BIS gets below 20, infusion stops. So, and reduction in the post-operative complications. Obviously, proper intraoperative anesthesia will decrease the rate of post-op complications. So, coming to open-loop delivery systems. Here, the anesthesia delivery is predetermined without constant adjustments. That means we set the target level of plasma concentration, and according to the set plasma concentration, the drug keeps on going. It is not concerned whether that that drug is sufficient for the patient or not. So there is no automated feedback mechanism. So because of this, it carries the risk of overdosing or underdosing. It cannot engage in machine learning. So if it has done any error, the machine cannot correct itself. It may not compensate for the disturbances in the system. That means if the patient has some pain and increased heart rate or BP, it will not control. The example for this is target control infusions. This is just a flow diagram showing the components of open loop system. We have a controller, actuator, and the patient, the measured value and the desired value. So the distinction between open and closed loop primarily revolves around the level of automation and the feedback control. This slide beautifully shows the whole concept of CLADs. So initially when I took this topic, I thought it's something out of the world, some futuristic topic, like see Prabhas is drawing some closed loop. But when I started reading about it, I was really perplexed that the idea of CLADs came to this gentleman, Bickford, way back in 1950 itself, where he attempted EEG-based automatic delivery of volatile anesthetic. And this was my reaction. So if the idea came long way back, why were not many developments made in this path? Because of the following challenges. Because of the complexity of the physiological system, because our body physiology does not operate like 1 plus 2 is equal to 3. It's very complex. So we had to need much more understanding about it. Poor understanding of the anesthetic drug mechanisms. Whatever drug we have introduced, it has multiple functions at multiple sites, which we needed much more understanding. Large interpatient variability, as discussed earlier, all shapes and sizes, and each drug also, the same amount of drug will not have the same amount of function in all the patients. And difficulty in monitoring. So we had monitors to monitor the depth of anesthesia and also neuromuscular blockade, but monitoring analgesia was really a big task. So recent developments in monitoring have resulted in renewed interest in automatic control of anesthesia. So why CLADs? What are the benefits of CLADs? So it offers precise control over the depth of anesthesia, continuous monitoring, continuous and real-time monitoring and feedback is given. So automated adjustments which results in smoother transition between different stages of anesthesia. So enhance patient safety because there will not be any overdosing or underdosing. It reduces the workload on anesthesiologist where he can look after other aspects of the patient care like intubation, central lines and all. So CLADs need minimal manual intervention, so which results in less human error. And customized care, patient-tailored anesthesia is given. So sophisticated algorithms analyze the data to identify the trends, improve performance, and refine anesthesia protocols over time, leading to continuous improvement in the patient care. So the basic components of CLADs, we have a controller, we have an actuator, the patient, the measured value and the desired value. And most importantly, the feedback mechanism. The system under control, that is our patient, the set point or the target value, the control variable or measured value, the actuator or the infusion pump which is driving the infusion, and the controller or the computer system. This computer system controls this controller controls the actuator in driving the measured variable closer to the target set point in our patient. So before we start the infusion, we need to know how much dosage we have to give, how much bolus and how much maintenance dose we have to give. For that, we need, for calculation of the dosage, we need models. Not the models you are thinking, but the mathematical models. So a model is a mathematical representation of the dynamic behavior of the system under study. So most popular of these are the compartmental models. This set of differential equations can either be transformed into transfer function or into the state space model. The pharmacokinetic models deal with the absorption, distribution, metabolism, and excretion of the drugs. These PK models describe how the concentration of drug changes over time in different bodily compartments. This is the 3-compartmental model which shows the bolus drug being given into the central compartment, that is the plasma. From the central compartment, the drug goes to the peripheral compartment, which is the highly vascularized muscle tissue, and from the second compartment, drug goes to the third compartment, which is the less vascularized tissue like the adipose, and finally the effect site, that is the brain. Meanwhile, all this while the drug will be continuously being eliminated from the central compartment. So we need all the volumes of the first, second, and third compartments to calculate the bolus dose, the volume of distribution obviously, and we need this rate of metabolism to calculate the infusion dose, rate of infusion. So pharmacodynamic models are usually represented by nonlinear sigmoid curves. The relationship of it represents the relationship of the drug concentration to the drug effect. It is useful in drawing dose response curves. Pharmacokinetic and pharmacodynamic models are used to describe the relationship between the concentration of the drug and its pharmacological effects over time. So operation of CLADS. What are the various steps in CLADS? First, initialization. In the first step, we load the patient data into the system. Patient's weight, age, his drug sensitivities and all we load into the system, his medication history and all. And then patient monitoring, we connect the patient to the monitor where all the vital data are monitored. That is called data acquisition. After the data has been acquired, it goes through assessment through the control algorithms, and these algorithms, they calculate the drug dosage and anesthesia delivery is done. After that, continuous monitoring and adjustment of the dosage of anesthesia or the infusion is done. All this while, proper documentation and recording of all the patient data, intraoperative events and surgical parameters are also noted down along with charts. Finally, after the surgery is completed, the CLADS is terminated and the patient is disconnected from the system. So all this while monitoring is done: hemodynamics, heart rate, NABP, temperature, oxygen saturation, cardiac output, arterial blood pressure, central venous pressure, urine output, all are monitored. Hypnosis is monitored by EEG based monitors like BIS, space and response entropy, narcotrend index, patient state index, cerebral state index, neurosens monitor, neuromuscular blockade, top stimulation and measuring evoke response by electromyogram, mechanomyogram, acceleromogram, kinemyogram and phonomyogram. So analgesia is monitored using MedStorm pain monitor, ANI monitor, analgo score, ALGE scan, GE entropy module and spectro. Next comes the controls. After taking of monitoring all the data, it is sent to the controls which analyze the data and interpret. So a control system is a device designed to regulate the operation of an apparatus or system. Closed loop systems employ a variety of control methods, allowing them to be reactive, predictive, adaptive and safe. First is the proportional integration delivery control, derivative control. PID control is widely used feedback control strategy that adjusts system output based on proportional, that is the present error, integral, that is the past error, and derivative, that is the prediction of the future errors. Then we have model predictive control, adaptive control, Bayesian control, fractional control, and fuzzy control. We don't need much about this. I'm just labeling them. So the function of all these control systems is primarily to identify any error. Error is nothing but difference between measured and the desired variable. So once the error is measured, once the error is identified, it identifies whether that error is above the target value or below the target value. And after knowing where the error is present, it measures the amount of error. So after measuring the amount of error, it interprets the data and according to that calculates the infusion dosage, and this drives the error closer to the set point, or the measured value is driven closer to the target set point. So applications of CLADS, it offers versatile applications across various surgical specialties where precise control over the depth of anesthesia and hemodynamic stability are essential, like cardiac surgery, where continuous monitoring and adjustment of anesthesia parameters are crucial for managing hemodynamic fluctuations and ensuring myocardial protection. In neurosurgery, it is essential for maintaining cerebral perfusion and minimizing the risk of neurological complications. In pediatric surgery, because they have unique physiological and pharmacological requirements. In ambulatory surgery, where rapid recovery and discharge are the priorities, CLAD can be very useful. So in patients with coexisting medical conditions and other comorbidities, where precise anesthesia depth is very crucial. And lastly, coming to research and education, CLAD can be used for simulation training and hands-on learning experiences for anesthesia providers. This is McSleepy, as madam already told, the first completely automated anesthesia robot. This was developed in McGill University, Canada. It first performed partial nephrectomy in the year 2008. So this is where McSleepy and Da Vinci met in 2010, performing total prostatectomy very successfully. And then we have another system called Galeno, which was developed by University of Portugal. And there are other systems like MedSteer, Tiva, Easy Tiva. It's a MedSteer company from France. And in India also, we have our own CLAD system. It is called Improved Anesthesia Agent Delivery System in PGI Chandigarh. So, as said by the famous author William Gibson, the future is already here. It's just not very evenly distributed. So, when that even distribution happens, maybe our OTs will look somewhat like this. So, that's for my presentation. Thank you. Thank you, Kalyan sir, for this opportunity.
Thank you, sir, for your time and expertise shared with us today. I would like to invite Dr. P. Kalyan Chakravarti, sir, and Pradeep, sir, to give small token of appreciation.
coming to the end of the session. So Dr. Ramesh was not able to make it. He has some issues, he did not come. So that session stands cancelled, and next session is the case presentation session, in which we took as how we do it. So in the recent past, like from the past 1 year, we are doing transplant cases, so organ harvesting we are doing. So we had lots of doubts 2 or 3 years back. We had lots of doubts regarding how to maintain brain dead patient and all. So now we started managing. Now we took help of the KIMS Secunderabad group. Now we are individually managing, and so my postgraduates will present, Dr. Mukesh and Dr. Prudhi will be presenting how they are managing like brain dead patients till the organ harvest is done. Okay, so they'll be taking, we had organ harvesting of renal, like kidneys, lung, liver, heart also. So but we'll basically concentrate only on renal harvesting, right? So if you have any doubts you want to interact, just jot them down, and again after the session you can just ask us, right? Please. So if you have any doubts, please try to interact.
Good evening, everyone. My name is Dr. Mukesh. Today my topic is about an overview on identification and optimization of brain dead patient in ICU posted for organ harvesting. These are the learning objectives. These are history, introduction, etiology, pathophysiology, and diagnostic criteria, investigation and management. Basically the transplant history is started in 1902. Cushing's first reported cessation of cerebral circulation when intracranial pressure exceeded arterial blood pressure in monkeys. Followed that in 1959, Brenton and colleagues reported the maintenance of respiration by mechanical means for 3 days after the death of patients with otitis media who underwent circulatory collapse. In 1994, the brainstem death was legalized in India. The Transplantation of Human Organs Act in 1994. The subsequent amendments in 2011-2014 from the Legislative Foundation for Brain Death Declaration and Organ Donation. In India, we will be following regarding the guidelines of United Kingdom guidelines for transplant history. In introduction, definition is the complete and permanent loss of brain functions defined by unresponsive coma with loss of capacity for consciousness, brainstem reflexes, and ability to breathe independently. The main causes of the brainstem death are global injury to the entire CNS, circulatory failure, cardiac arrest, respiratory failure, focal injury to the CNS, primary injury, injury due to trauma, ischemia or intracranial hemorrhage, and secondary injury due to the herniation of brainstem. The main pathophysiology is initially there is a severe trauma or stroke. It is leading to damage to the neuronal tissues, leading to the decrease in the cerebral perfusion and increase in the intracranial pressure and cerebral edema. Finally, it is leading into the vagal activation like bradycardia and hypertension. It is called as a Cushing's reflex. Followed by the ischemia of the pons, and it is leading to the mixed vagal and sympathetic activation. Mainly the vagal, cardio and respiratory nucleus is involved, it leading to the bradycardia and hypertension. Followed by the ischemia of the medulla, leading to the catecholaminergic, leading to hypertension, uncontrolled hypertension, tachycardia, increased systemic vascular resistance and cardiac output. Finally, an ischemia to the hypothalamus and pituitary gland. There is an impairment of the thermoregulatory center and catecholaminergic, leading to decreased cardiac function. And in final stage, it leads to cerebral herniation and spinal cord sympathetic deactivation, leading to bradycardia, low cardiac output state, and systemic vasodilation. These are the clinical features and pathophysiological changes occur to hypertension due to catecholaminergic storm and hypotension due to vasoplasia, hypovolemia, reduced coronary blood flow, and myocardial dysfunction. bradycardia and arrhythmias, myocardial damage and reduced coronary blood flow, and a pulmonary edema, it is due to the acute blood volume diversion and capillary damage. Diabetes insipidus, it is due to posterior pituitary damage, and disseminated intravascular coagulation due to tissue factor release coagulopathy. Hypothermia due to hypothalamic damage and reduced metabolic rate, and vasodilation and heat loss. And hyperglycemia due to decreased insulin concentration and increased insulin resistance. These are the incidence changes around. And the diagnostic criteria, as per American Academy of Neurology 1995, 2 examinations are required separated by at least 6 hours, diagnosed by 2 or 3 physicians who are independent of transplanting. The transplanting team involves at least 1 physician who should be specialist in neurology, neurosurgery or anesthesia department. Prerequisites or inclusion criteria: patient must be totally unresponsive and ventilator dependent, irreversible cause of brain death of known etiology like evidence of brain injury clinically and radiologically as a CT or MRI. And exclusion criteria: patient should be not involved in any drug intoxication or poisoning, recent administrations of any continued presence of neuromuscular blockers, and any diseases like Guillain-Barré syndrome or Locked-in syndrome. Other metabolic or endocrine factors should be ruled out like hyponatremia, where endocrine dysfunctions like thyroid storm. The 3 cardinal findings in brain death are coma or unresponsiveness, absence of brainstem reflexes, and apnea. It is clinically observed. Coma or unresponsiveness, no cerebral motor response to pain in all extremities like nail bed pressure or supraorbital pressure. In the cranial nerve examination, absent of brainstem reflex, pupils will be shaking, though no response to bright light. Size is about mid position 4 mm and dilated to 9 mm. It is afferent is carried by 3rd cranial nerve, and if it is carried by 5th cranial nerve. Afferent is carried by 2nd cranial nerve, and efferent is carried by 3rd cranial nerve. And the next one is facial sensation and facial motor response. In the corneal reflex, no corneal reflex to the touch with throat swab. In this, afferent is carried by 3rd cranial nerve, and efferent is carried by 5th cranial nerve. No jaw reflex or no grimacing to deep pressure on nail bed or supraorbital ridge or temporomandibular joint. The other one is ocular movement. No oculocephalic reflex while testing the, it is called as absent doll's eye sign. In this, patient is moved to the one side, or so that eye movements doesn't move, or it's moved to the same side in the doll's eye reflex. In the intact brainstem, the eyeball moves to the opposite side. Another one is no deviation of eyes to the irrigation in each eye with 50 ml of cold water. Allows 1 minute after injection and at least 5 minutes between testing on each eye. It is called as an ocular vestibular reflex. Another clinical examination is pharyngeal and tracheal reflex. No responses after stimulation of the posterior pharynx with tongue blade, or no cough response to the bronchial section. After the cranial nerve examination, we will be looking after the apnea test performed. Prerequisites are core body temperature should be more than or equal to 36.5 or 97 degrees centigrade. Systolic blood pressure is more than 90 mm of Hg, and patient should be maintained in euvolemic state. Positive fluid balance is maintained in previous 6 hours, and normal partial pressure of carbon dioxide, optimally it is more than or equal to 40 mm of Hg, and normal partial pressure of oxygen. Pre-oxidation to be obtained, partial pressure of oxygen more than 200 mm of Hg, which is can be seen while drawing the ABC prior to the test. First, connect a pulse oximeter and disconnect the ventilator. How do you perform this? Connect a pulse oximeter and disconnect the ventilator. Deliver 100% of oxygen, 6 liters per minute, into the trachea at the level of cardia. Look for closely for the respiratory movements like abdominal or chest excursion that produce adequate tidal volumes. Then measure an arterial partial pressure of oxygen, partial pressure of carbon dioxide, and pH after approximately 8 minutes, and reconnect the ventilator. If the respiratory movements are absent and arterial partial pressure of carbon dioxide is more than 60 mm of Hg, more than 20 mm of Hg from the baseline, the apnea test results in positive. It supports the diagnosis of brain death. If the respiratory movements are observed and the apnea test result is negative, it does not support the clinical diagnosis of brain death, the test should be repeated. Then connect the ventilator if during the testing the systolic blood pressure is less than 90 mm of Hg, or pulse oximeter indicates significant oxygen desaturation and cardiac arrhythmias are present. Immediately draw an arterial blood sample and analyze an arterial blood gases. If partial pressure of carbon dioxide is more than 60 mm of Hg or increase in the more than 20 mm of Hg from baseline, the apnea test is results positive and it supports the clinical diagnosis of brain death. If partial pressure of carbon dioxide is less than 60 mm of Hg or less than 20 mm of Hg over baseline from normal PCO2, the result is indeterminate. Additional confirmatory test can be considered. This test is done twice with a gap of 6 hours. The additional confirmatory tests are ancillary tests to confirm the conventional angiography, electroencephalography, transcranial Doppler ultrasound, and single photon emission computer tomography using technician brain scans, somatosensory evoked potentials. These are the laboratory investigations. Patient selection criteria should be ideally less than 60 years, no end organ damage from the systemic diseases, proper intrinsic function of the organ to be harvested, requires cessation of both cerebral and brainstem function. Patient is ideally donor should be less than 60 years so that graft versus host reaction may be less chances, and comorbids also less. Care of the patient before harvesting. There should be hand hygiene, central line and arterial line insertion and monitoring, nasogastric tube insertion, Foley's catheter insertion, and care of all lines to be taken. Proper position 30 to 40 degrees elevation. Frequent change in the body position, warming blankets to maintain the body temperature. Prophylaxis for deep vein thrombosis with pneumatic air devices. Eye care by tapping of the eyelids. Tracheal toileting, frequent airway suctioning is done. Stress ulcer prophylaxis like IV proton pump inhibitors, pantoprazole, and broad spectrum antibiotics which make out both gram-positive and gram-negative antibiotics. These are the basic investigations to be done. So like complete blood count and blood glucose, urine analysis, serum electrolytes like sodium, potassium, chloride, and blood urea nitrogen, serum creatine, and liver function test, coagulation profile like PT-INR, APTT, and other serological profile like hepatitis B, C, HIV, blood cultures, blood and urine cultures if any evidence of infection or duration of hospital more than 72 hours. In case of multi-organ donors, echo is done for heart transplant and bronchoscopy for the lung transplant. Regarding monitoring, my colleague will be taking it.
Good evening, everyone. In the previous slide, the care of the patient before harvest. Before the patient selection, this ancillary test we have to do in patients who are unable to, who are not hemodynamically unstable and who are having cervical fracture and cardiac instability patients, we will perform this test. And after confirmation, we take the patient in 2 stages, pre-organ procurement phases and organ procurement phases. And pre-organ procurement phases, these are the care of the patient we will take when the patient is in ICU. And these are the baseline investigations in order to increase the viability of the organ before harvesting. And these are the standard monitors we will keep in the OT: pulse oximeter, ECG, invasive arterial blood, and central line and pulmonary swan catheter, and Foley's for urine output monitoring and temperature monitoring with nasopharyngeal probe. This is the pulmonary arterial pressure and cardiac output monitoring and pulse pressure variation. These are the goals during overall management of case from the ICU and also in the OT also. Our mean arterial pressure should be maintained 60 to 80 depending on whatever the organ we are going to take for the harvesting. And systolic blood pressure also, it is a rule of 100 is there where the systolic blood pressure should be 100 mmHg and central venous pressure 10 mmHg, and urine output should be more than 100 ml per liter. And systemic vascular resistance also 800, 1200. And it is advisable that pulmonary capillary wedge pressure should be maintained in the range of 6 to 10 based on the organ what we are procuring. Let's say in case of renal, we will maintain the pulmonary capillary wedge pressure of around 10 mmHg. And in case of pulmonary and other like lungs transplantation, we will try to decrease. These are the ventilator parameters.
Buddhi, 1 minute. Previous slide. So, Swanganj we are not using, but he has given only textbook material. We are not using Swanganj. So, actually, PCWP is now obsolete. We are not using. It's very, very invasive procedure. Better not to opt for PCWP. He only gave it for information sake, but we are not using that. Next slide. So, these are all things they monitor. You go with the ABGs and explain how you are doing it. Continue.
These are the overall management. It has been divided into hemodynamic support, respiratory, endocrine, coagulation abnormality, and temperature regulation, musculoskeletal, hypothermia management. In case of hemodynamic support, as my colleague discussed previously, there will be catecholamine surge. Cardiac hemodynamic instability will there. Initially presenting the patient with hypovolemia and cardiac dysfunction due to catecholamine surge, it will be leading to acute acute muscle injury of the heart, and also later on vasodilatation secondary to the brain death as the ischemia progress. So we'll be dealing step by. Hypovolemia will try to resuscitate with fluid. Regardless of hypotension and hypertension, patient is usually hypovolemic, and we have to maintain adequate filling pressure of around central line pressure of 6 to 12 mmHg, pulmonary capillary pressure of 12 mmHg, which is not using. So our choice of fluid initially was crystalloids, 0.9% NS, and ringer lactate solution. Colloids, next line is colloids, albumin, gelatin, dextrose, and dextran, hydroxyethyl starches, which in case if we want to harvest renal, we will avoid using this HES and colloids. And as per rule of 100, we have to maintain HP around 10. So we have to transfuse PRBCs. And next, we have to see the cardiac dysfunction. It involves two phases, phase 1, phase 2. Phase 1 where it will be catecholamine sympathetic discharge will be there. Later on, as it progresses, there will be sustained hypotensive phase. So we'll be treating these conditions. Phase 1 trauma stroke, like as acute injury is there, it will cause cerebral edema, and there is increase in ICP, leading to we have to decrease and cerebral perfusion pressure, leads to damage and herniation of the brain, which will again lead into intraarterial vasospasm and ischemia. So patient hemodynamic factors will be tachycardia, hypertension, and arrhythmia, followed by bradycardia. Later in the third stage, it will be increased systemic vascular resistance, where there will be redistribution of blood volume and visceral ischemia, and end organ damage will be there. In the phase 1, we are about to manage, we will use short-acting antihypertensives like NTG 0.5 mic per kg per minute and esmolol 0.05 mg per kg per minute. And we will avoid calcium channel blockers and long-acting beta blockers due to negative inotropic action. And other chronotropic agent, atropine has no chronotropic effects after brain death as vagal nucleus has been damaged. So we will go with isopretinol 0.05 to 0.1 mic per kg per minute. Later epinephrine, epinephrine 0.05 to 0.5 mic kg per minute. If not resolved, we use transcutaneous pacing. And the management in the phase 2, in cardiac dysfunction, we have to maintain the mean arterial pressure between 60 to 100 mmHg, followed by volume expansion. Then next line, we have to use vasopressor. In the vasopressor, first choice will, if there is a persistent hypotension instead of fluid challenge, we have to go with the first line choices vasopressin 0.01 to 0.04 international unit per minute, followed by epinephrine 2 to 4, followed by norepinephrine, followed by epinephrine. If any cardiogenic shock or cardiac dysfunction suspected, we will go with dobutamine. And in case of respiratory system, due to catecholamine discharge, there will be direct injury to the lung, and ventilating factors are which will affect our aspiration, pulmonary contusion, and also pneumonia and pulmonary edema. Here I am discussing about the neurogenic pulmonary edema, which will cause due to catecholamine surge. There will be increased systemic vascular resistance, because of which there is increased blood flow to the pulmonary circulation, leading to pulmonary edema. Secondly, there will be release of pro-inflammatory mediators, which will lead to inflammation of lung. and other principles. And because of this, we have to maintain low volumes if we have to transplant the lung. Like pressure control, volume control, depending on the airway pressure, we have to maintain tidal volume of 8 to 12 ml per kg if no lung injury. If lung injury we are suspected, tidal volume of about 6 to 8 ml per kg. And we have to maintain PaO2 between 70 to 100 mmHg, and SAT should be maintained around 95%. And if FiO2 is greater than 40%, it is contraindicated for lung transplantation. We have to maintain PaO2 by FiO2 ratio of 300, and we have to keep PEEP less than 5 centimeters. In case if we keep about, if we increase the PEEP, it will decrease the cardiac output. There will be increased vasopressin release, and systemic vascular resistance decreases, and cardiac output will also be decreased, which will again lead to end organ damage. And PaCO2 should be maintained 35 to 45 mmHg, and platelet pressure also less than 30 centimeter H2O. And going to the other care, endocrine metabolic support. As the ischemia tends, it also damages the posterior and anterior pituitary, where the HPA axis will be altered. That is why hypothalamic pituitary adrenocortical regulation is interrupted, because it can lead to loss of posterior pituitary function. So hence central diabetes insipidus can happen, lead to severe fluid or electrolyte disturbances. This management initially will give IV fluids. Later, if not controlled, we will go with vasopressin or desmopressin. Vasopressin, and we have to maintain urine output. Another one, diabetes insipidus. This can be instead of going to laboratory, initial we can see 4 ml per kg per hour urine output is there. We can shortly go with the diabetes insipidus is present. Later we can send for the lab investigations. Their serum sodium will be more than 145 millimoles per liter, and increase serum sodium osmolarity because there will be more fluid loss, concentrated will be there, and urine osmolarity will be decreased, and urinary specific gravity will also be decreased. The management of diabetes insipidus, we have to replace the fluid deficit and also ongoing fluid loss with hyponatremic fluid. 0.5% saline is appropriate. It will replace the volume deficits and bring down the serum sodium. And another is desmopressin, which can be given 1 to 4 mic IV QID, or 1 to 2 mic intranasally can also be given. And vasopressin initially 1 mic we can give. This is a hormone cocktail where we can give vasopressin 1 mic IV bolus followed by 0.5 to, it's not 4, 2 international unit per hour alternatively. And we have to titrate the dose accordingly and maintain the MAP around 70 mmHg, and we have to titrate according to the urine output. And other, as the insulin resistance will be take place, we have to check for the hyperglycemia, and we have to give the regular insulin infusion 0.05 to 0.1 mic per kg per hour infusion, and we have to maintain the sugars level around 80 to 150. This hormone replacement, initially we can give with methylprednisolone 15 mg per kg IV, followed by 1 gram in every 24 hours, or else we can go with methylprednisolone 250 mg bolus, then 100 mg per hourly we can keep. And another is levothyroxine, which is not available in IV forms. We can go with tablet form. Levothyroxine 20 mics IV bolus, and followed 10 mics per hour IV infusion. And the T4 levels, T4 also we can give initially 3 mics IV bolus followed with 2 mics IV per hour infusion. This is the and we have to see according to the electrolyte correction, like hypokalemia in IV KSL 20 to 40 milliequivalents. We can calculate accordingly with the formula body weight into potassium deficit into 150 by 2. In case of hyperkalemia, we can treat with IV calcium gluconate 10 ml, or insulin plus dextrose infusion, or nebulization with salbutamol, and diuretics can also be used, and soda bicarb 50 to 150 milliequivalents over 5 to 10 minutes. And in case of hyponatremia, which is rare, it can happen, but acute hyponatremia less than 110 milliequivalents, we have to go with seizures are present, symptomatic treatment with there. Like we can go with hypertonic saline 3% NaCl, or we can calculate accordingly. Sodium deficit is equal to total body weight into desired sodium minus actual level present sodium. First half of the deficit we have to give in 4 hours, next half around 1 to 3 days if symptoms persist. Per day we have to treat according only 10 milliequivalents per day. In case of metabolic acidosis, pH 7, bicarb is less than 10 ml equivalents. IV soda bicarb can be given. In coagulation abnormality, hemoglobin, a target hemoglobin level of 9 to 10 gram per deciliter is most appropriate, as oxygen carrying capacity will be maintained. At level of 7 gram, it is the lowest acceptable limit for management of stable donors in the ICU. And there are no defined targets for platelet concentration, INR, APTT, PT. Platelets and FFPs or cryoprecipitate replacement is indicated for clinical bleeding only. Antifibrinolytics such as epsilon aminocaproic acid may cause microvascular thrombi in donor organs. It should be avoided. Temperature regulation, as the patient may be prone to hyperpyrexia followed by hypothermia, because of which loss of hypothalamic function and thermoregulation. Also, there is a decreased metabolic rate and muscle activity, and also vasodilatation, and also due to excess IV fluid administration, cold fluid administration also. Because of hypothermia, the effects are it affects cardiac function, and also arrhythmias can happen, which will hamper the oxygen delivery to the tissue and worsen the coagulopathy. Hence, it is required to maintain core temperature of around 35 degrees centigrade. By warm blankets and warm fluids we have to keep. One more thing I missed is musculoskeletal. As the spinal reflexes are intact, brainstem reflexes are not there. So, because of spinal reflexes intact, we have to go with long-acting muscle relaxant. And due to surgical site incision, opioid drugs we have to give. These are the overall summary which I have explained.
Keep the last ring. This. Okay. Just want to brief about these things. So, like an ICU case, you will be monitoring everything. So, what all you should be avoided? Acidosis, hyper or hypotension, and hyper or hypoglycemia, and what else? Temperature, hyper or hypothermia, electrolytes. Electrolytes should be maintained. So correction should be very aggressive. If there is hypo or hyper, correction should be done. Okay. And the other one is fluid management, IO, input-output charting, and what else? No cortisol production. Anyway, it won't be there in brain dead patient. Cortisol production will not be there. But even slightest rise will cause organ damage. Okay. So, thank you all. Next, we will have a Google form quiz. I think Dr. Navina. Dr. Yamuna. Okay, thank you, Dr. Mukesh and Dr. Prithvi. Just a minute.
Thank you, Kalyan sir, for providing the opportunity to discuss getting it.
Thank you, sir.
Just a minute, please.
Thank you, Mukesh. Thank you, Prithvi. Can I ask any doubt? Doubts from audience? Sir, please.
Good evening. Well, I have a compliment and a question. Compliment is you did extremely well, both of you. Congratulations. And I'm asking this question in the interest of the other postgraduates here. So this patient is brain dead, what you're managing as a P6A case. So we have to give the relatives the dead body and a death certificate, isn't it? So what will be the time of death for this patient that will be documented in the death certificate?
Second apnea test later, sir.
Pardon?
Time of death will be after second apnea test, sir.
No. So that means you did a surgery on a dead body. No, no. Yeah. So, I think we discussed this in previous ISA meetings, I think, if you are familiar. Yeah, you are almost there. So one of the things, if you are harvesting the heart, so one of the things the surgeon do, the last thing he'll do is to clamp the left subclavian. I think you'll put the artery line on your left radial artery, isn't it? So once he clamps the left subclavian, the pulse is gone, and that should be documented as the legal time of death, because this is a medical legal case, and every documentation should be perfect. So I'm just asking in the interest of the other postgraduates. Thank you.
Right, sir. Dr. Rahul Sharma, sir, can you please accompany us on the stage, please? Sir, please present a token of appreciation for our postgraduates. Dr. Rahul Sharma, sir is assistant professor in SPM. He was most of the time in railways. Sir, please. Already sent in the group. Okay, start. Only for postgraduates, not for the faculty. Three ready. చాలా లైన్కి రండి, నిద్రపోతున్నానండి. రండి అందరూ వెనకాల